Hello, 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 hello. Hello, 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 hello.
Good morning all. A very warm welcome to you all. So we appreciate and respect your early presence at this academic event so that we can start on time. So we are not wasting any time. We hope you enjoy the sessions. Once again, thank you for being part of this event. So let's start with the first session. First of all, I invite Dr. Rajesh Purushothaman, Professor, Government Medical College, CALICUT, to chair the session. And I also invite Dr. Nabil Mohammed, Senior Consultant, Orthopedic Surgeon, Maitra Hospital. First, I would like to invite Dr. Rajneesh R., Senior Orthopedic Surgeon, Baby Memorial Hospital, reading between the lines, unrevealing the knee MRI reports. Over to you, sir.
Thank you. Thank you for giving me an opportunity here. Good morning, one and all. So let me start with the first topic as an opening batsman. So my topic is how to correlate the MRI to clinical scenarios. So today is a knee day. So it's about the basics of MRI knee. So why imaging in orthopedics is required? Why we have to have a talk with our radiologist? To confirm our diagnosis, there's always you need a documentation to avoid litigation in future, need for the counseling necessary for corrective procedures and surgery, treatment in deciding what line of management, what to do, and what type of implants you have to have. So you should be very much thorough with the MRI yourself, not just depending on the radiologist giving the report. If you don't have a proper communication with your radiologist, they can't give you a proper report. So you have to share your clinical scenarios with them. If you don't give, then they will, if there is an inadequate communication with the surgeon to the radiologist, there can be a lack of clarity in the request given by the surgeon to the radiologist, then the report won't be accurate. We want an accurate clinical radiological correlation to give an apt treatment to the patient. So I will take you through basics of knee MRI. First, the coronal view, the sagittal view, and the axial view. These are only basics, okay? So hope this video plays well. So starting with the coronal view, can you off the light, please? Okay, so coronal. I'm starting with the coronal view of knee. This is a right knee. Okay, so when you are going from anterior to posterior, this is a quadriceps tendon, this is a patella, and this is a patellar tendon. So as you go along, so when you go from along from anterior to posterior, you can see these things. Then as you go posteriorly, you can very well see the side structures. So this is a femur, this is a tibia. In between, you have to look for the meniscus. On the left-hand side, this side, you will see the medial meniscus. On this side, you will see the lateral meniscus. How you differentiate the side? Just look for the fibula, fibular head. Okay, so when you see a structure like this, there's a chance that there can be a tear there from the capsulomeniscal region. Coming to the center, onto the center part, you see the notch On this side you will see, because this is a lateral aspect, on this side you will see the ACL part, and this side you see the PCL part. So this is the wedge-shaped or triangular-shaped medial meniscus. This is a wedge-shaped lateral meniscus. As you go posteriorly from anterior to posterior, you will see the attachment of ACL, the PCL. This is the root of the medial meniscus. This is the root of the lateral meniscus. And as you go more posterior, this side you will see the posterolateral complex, and this side you see the medial complex. So this is the popliteal structure, and this is the FCL. As you go more posteriorly, you will see the biceps femoris attaching to the head of the fibula. Okay. So when you go more posterior, this is the popliteus artery, and then you will start seeing the gastrocnemius muscles. Coming to the sagittal view. Coming to the sagittal section, this is also right knee. We are going from lateral to medial. So this is a lateralmost aspect. You see how you identify it? Just see the fibular head. Okay. Then this is the first part of the capsulomeniscal region of the lateral meniscus. This is a femur. This is a tibia. As you go from lateral to medial, this is towards the midline. You are coming towards the midline. You will see the lateral meniscus. And now, the same MRI, you can see the small tear here. That's a capsulomeniscal tear in the lateral meniscus. This is the anterior horn. This is the posterior horn. This part is the anterior part. This is the posterior part. And we are going from lateral to medial. Okay? Now, this structure, what you see is the cartilage. This is a subchondral bone, and this is the cartilage. So whenever you see any defect or a fluid-filled area, there can be a cartilage damage. As we go more towards the center, we will see the quadriceps tendon, the patellar tendon, and we can start seeing the ACL, which is attached from tibia to femur. This is the ACL. And towards the posterior aspect, you can see the PCL. And this area is known as the champagne glass drop sign, which is the attachment of the PCL towards the tibia. So as we go more towards the medial side, we are moving from lateral to medial. This area is known as the champagne drop sign of the PCL attachment on the tibia. Thus, you can see we start seeing the medial meniscus. This is the posterior part. This is the anterior part. If there is any tear here, that can be the ram lesion. That is in the posterior part of the medial meniscus. This is the anterior part. This is the patellar tendon. This is the patella. This is on superiorly, there is a quadriceps tendon. So we come to the more medial aspect, where you start seeing the attachment of the semimembranosus and the semimembranous semitendinosus and the gracilis. And this is the capsulomeniscal region of the medial meniscus. Now, coming to the axial views, this is the tibia, upper part of the tibia, and here you see the fibula. So this is the lateral aspect, this is the medial aspect, and we are coming up from distal to proximal. Most of the time we used to get 3 MRI films. One consists of the coronal view, other consists of the sagittal view, and the other is the axial view. So what all things you have to see in the axial view? So here anteriorly you will start seeing the patellar tendon. This attachment of the patellar tendon onto the tibial tuberosity. Then comes the patella and the quadriceps tendon. This is the tibia, this is the fibula, and this is the most important structure in the knee. That's a neurovascular bundle. That is a popliteal artery. Look how close it is to the tibia. This is the popliteus muscle. Okay, as we go more superiorly, we start seeing the proximal tibiofemoral joint. Proximal tibiofibular joint. Okay, where you have the attachment of the tendons, ligaments to the tibia to So here is the proximal fibulotibial joint, and this is a popliteal vessel, and now we are going superiorly, where we start the tibial plateau, then we will see the medial meniscus here and the lateral meniscus here. Posterior root of the lateral meniscus, posterior root of the medial meniscus, intermeniscal ligament. This is the anterior intermeniscal ligament. Now the most important part of this MRI of the axial cut is how you look for the trochlear groove. This is a lateral, this is a medial tibial, this is a lateral femoral condyle, and this is the LPFL, this is the patella, this is the trochlear groove. Whenever there is a tear, so okay, a few seconds, means a few minutes, I will just go through some of the MRI films. This for ACL tear, you see the sagittal view, the axial view. This is the tear of the ACL. Don't miss the mucoid degenerations in ACL. This is mucoid degeneration, ciliary stalk appearance. When you see this is a PCL tear, this is a champagne glass drop arm sign. You can see the tear in the axial view. Mucoid degeneration PCL not to be missed because it comes as a tram tract lesion. This is very important when you are doing a PCL retaining TKR. If there is a mucoid degeneration, the pain in the knee may not go. Then this is how you see the MPFL tear. It can be avulsion from the femoral side, patellar side, or the mid substance. You have to correlate with the trochlear dysplasia.
Rajesh, can you just 2 minutes, can you finish?
Yes, sir. It's almost over. You have to go through the intactness of the quadricep mechanism, then the PLC injury, this is the area of the PLC injury, FCL and the popliteus tendon, the MCL injury in the MRI, then go through the meniscus. If there is a discoid meniscus, it will be seen like this. Double PCL sign where there is a PCL and the meniscus in between. And this is a triple PCL sign where both meniscus are bucket handled with PCL. The RAM lesions, the cartilage lesion which I have told you, this is a signal there with a defect there. Look for other pathologies also as well. Thank you.
Thank you, sir. Hello. 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 Hello.
May I invite Dr. Abdul Ghafoor for his enlightening talk.
Good morning. So at the outset, I would like to thank the organizers for the opportunity. I'll be speaking on how to get the portals right and how to do a diagnostic knee scopy. So the first step in your knee arthroscopy is examination under anesthesia. And your clinical examination is not complete without doing that. Arthroscopy can be done in the supine position with the leg on the table, as it can be also done in the knee hanging down position. The patient is positioned with the use of a leg holder or a lateral post. There has to be a well-padded tunicate which has to be applied in the proximal thigh. Foot supports can be kept at two positions. One is to keep the knee at 70 degrees and the other is to keep the knee in hyperflexion. The arthroscopy cart and the monitor has to be positioned on the opposite side. A Mayo stand may be useful so that your shaver, camera, etc. can be kept when not in use. So mastery of the surface anatomy allows accurate and reproducible portal placement. So once the patient is draped, the first thing that you need to do is to mark your bony and the soft landmarks. The patella has to be marked, the tibial and the femoral condyles, the patellar tendon, tibial tuberosity, and the soft spots has to be marked. Multiple portals have been described for the knee arthroscopy, but the most commonly used ones are the anteromedial, anterolateral, accessory anteromedial, posteromedial and the postlateral portals. So always be careful that to use a disposable non-detachable blade with handle, or in case you are using a blade, tie it so that you do not land up in trouble. So once you are ready to go, we can go in and make the portal. The first portal that we make is the anterolateral portal, which is the primary viewing portal. It is made 1 centimeter above the joint line, inferior to the tip of the patella, and 1 centimeter lateral to the edge of the patellar tendon. So you have to be very careful regarding your portal placement, because if you are not making the portal in the right place, you will not get a good view. So if you go very inferior, you can injure the anterior horn of the middle meniscus. That is one thing. Other thing is that you will not have a good vision on your posterior structure. So the portal has to be adequately placed in a high view so that you get a good bird's eye view of your knee joint. 6 mm is the usual size of your sheath that we use for a 4 mm scope. So that is the incision that we usually make. You can make a horizontal or a vertical incision. A vertical incision has the advantage that you can have a bit of play in going superiorly or inferior. A larger incision would result in increased fluid extravasation. So once the skin incision is made, you can go into the joint with the help of the trocar and sheath. So the knee has to be in 70 degrees of flexion. Initially, when you enter the joint, there will be a hard resistance. So soon after you enter the joint, the resistance will stop. So at that point, you can extend the knee and push your trocar and sheath towards the suprapatellar pouch, and you can confirm your position by moving your sheath on both the sides. And once you reach there, so this is just a video demonstration. The first step is to make the landmarks and then feel for the soft spot. And when you make the incision, it is always better to keep the sharp end of the knife on the upper side. And you have to be very clear about the direction. You have to direct it towards the intercondylar area, keeping the sharp end upward. And this is in 70 degrees of flexion. You are entering the joint. And once the resistance is gone, you can extend the knee and you can go to the suprapatellar pouch and change your obturator for your arthroscope. And the first thing that you see is your suprapatellar pouch. So it's always nice to have a systematic way of examining your knee. Start from the suprapatellar pouch. You start from the suprapatellar pouch, and then once you come inferiorly, you can see the trochlea. When you turn your light source, you can see the undersurface of the patella. You can also look at the patellar tracking by gently flexing and extending your knee. And once you are done with that, you can go to your gutters, where you look for your plique. You can look for loose bodies. Also, you can see for the periphery of the meniscocapsular attachment as well. So once you are done with that, you can come to the center of the joint, the intercondylar area where you can see the ACL and the PCL. So you should know how to use a 30-degree scope. You are viewing at a 30-degree angle, so the field can be changed by rotating the light source. And at this point, you are ready to go in to make the anteromedial portal, which is 1 centimeter above the joint line, medial to the patellar tendon, inferior to the tip of the patella. So here you can feel the soft spot. Since you are already inside the joint, with the light source you can get a transillumination, so you can avoid injuring the subcutaneous veins. And you should be careful that there is the infrapatellar branch of the saphenous nerve which might get injured, so you have to be mindful regarding your anteromedial portal. So you can use your needle technique for triangulation. You can look where your needle is reaching. So this is the place only where your instrument is also going to reach. So you can readjust your needle according to your need. So once your instrument is in, you can start making your vision clear. You can remove the extra synovium, the ligamentum mucosae, and only the essential fat pad. Don't go and shave off the entire fat pad, because you need to remove only what is necessary. You have to see the nose, you have to see the anterior horns. So once that is there, you're good to go. And always be careful while you use your instruments. Your sharps has to be kept at a safe distance from your scope. Your shaver has to be played only at a safe distance. And you can switch between your viewing and your working portals to keep the mouth clear for your easy working. And the next thing that you have to look is the medial compartment, where you have to look for the medial femoral and the tibial condyles and the medial meniscus. A valgus, you can use either a leg support or your assistant can stabilize the thigh against the lateral post, and then the other person can give a gentle valgus and an external rotation. If needed, you can do a gentle pike crusting as well. So the medial meniscus has to be seen in this way. Similarly, in a figure of position, you can look at the lateral side. You have to look at the lateral meniscus and the lateral condyles. Just a few words about the other important portals. The accessory anteromedial portal is one portal which we all use for during our ACL reconstruction. So this is a much medial and a lower portal compared to the anteromedial portal. It has the advantage that it avoids the fat pad, and you can have a direct entry for your femoral tunnel in your ACL reconstruction. Posteromedial portal is very useful because many suggest to have a routine posteromedial portal to look at the posteromedial area and to look for the ramp lesions, especially when you have a kind of pivot shift when you see in the examination under anesthesia. So look for the soft spot between the MCL and the tendons of the semimembranosus and the middle head of the gastroc. Not just the ramp lesions, posteromedial portal is useful for your PCL reconstruction, loose body removal, etc. Other portals that we use are the postlateral portal, the transseptal portal, Gilchrist portal occasionally. So the other portals may be used when you are in need of that. So you need to have an idea regarding the other portals as well. So as with any procedure, knee arthroscopy can have complications if you are not very careful. And the most common complication is damage to the articular cartilage. So when you enter the joint, be gentle. When you push your trocar, you should know where you're going. So directly towards the intercondylar area. And for the beginners, you have to understand that when you keep the knee in 70 degrees of flexion, there is a posterior slope as well. So if you try to go horizontally, definitely you will go and hit the femoral condyle. So you should have an idea, go slowly, and then when you play your shaver, don't go blindly, because many a times when you play your shaver, you can result in damaging your meniscus and your intact ligaments as well. So try to avoid that, and be careful while placing your portals to look for the sensory branches. And when you are doing the posterioroscopy, you have to keep your shaver facing anteriorly, because just as the previous speaker told, the popliteal vessels are very close to that. So before your procedure ends, you have to clean your joint. There can be bony and soft tissue debris. So that has to be also done. Thank you.
Thank you, sir. Now I invite Dr. Sujit Jose, Professor and Head of the Department of Orthopedics, MOSC Hospital and Medical College, Kolancheri, to explain on tendon harvest and preparation.
Good morning. It's nice to see a good crowd at this time in the morning on a weekend, Sunday. That shows the interest in arthroscopy now, and cheers to our IAS team, especially Dr. Sandeep Beraris, who is here, Dr. Sachin, Dr. Samir Ali, Dr. Bashir, who's worked very hard to bring this program to this level. So I'll be talking on quad tendon and peroneus longus. So I've named the tendons for difficult scenarios. So there are confusions and thoughts about the second one being the primary graft. I'll come through the thoughts which are in the minds of people in the literature now. So indications for alternative grafts, multi-ligament scenarios, revision ACLs, PCLs, where you needed stronger grafts, ligament laxity. So that is one thing you have to check before embarking on an arthroscopy or even a bank cut or any soft tissue procedure. So the ligament quality is not good, the collagen is bad. You have to think about stronger grafts, and the stiffer grafts are the bone patellar tendon and the quadriceps. Dr. Sheila Jose will be talking on bone patellar grafts. So those are the evidences, the latest ones about the quality. I'll talk about the quadriceps tendon anatomy. It is a thicker graft. This is one graft which we don't think about. We think below the patella. We have been thinking below the patella. So there is a graft which is slightly better above the patella is what we are going to talk now. The average thickness is around 16 in female and 18 in male. We only require 8 or 9. And it's either bilaminar or it can be trilaminar trilaminar commonly in 58% and bilaminar in 30 and 4 layers in 5%, and it's a single layer in 7%. We cannot differentiate between the layers. So we have to plan to retain the inferior-most layer. The vastus intermedialis layer is retained. If you take all of them, probably you may end up with a weakness of the quadriceps. That is what the Lind study showed, the Danish registry, which said the quadriceps graft may be inferior in 2020, but they themselves corrected themselves that in the future studies that it was the harvest technique in the steep Levin curve which caused the trouble. So it's a predictable graft, versatile, up to 9 mm can be easily harvested without disrupting the quadriceps mechanism. Favorable biomechanics, equivalent or superior clinical risk compared to BTB in various studies, and significantly lower complication rates. I'll come to that. That was a Lind study I was mentioning the Danish registry, but they themselves corrected them in the subsequent year when the results were better in the follow-up studies. So tips. You have to visualize through, it can be done through a very small incision or a longitudinal incision exposing the whole 8 centimeters. A 2 centimeter transverse incision is all that is required. Take only the superficial part and close the gap so that the quadriceps is just like when we do a knee replacement or a surgery where only the upper part above the patella is disrupted. So that's the quadriceps graft in revisions, multi-ligament or ligament laxity scenarios. So it's a strong graft, thicker graft, smaller incision which can be more cosmetic and see that is all that is required now, and another joint is not violated when you're looking at a revision scenario or a multi-ligament scenario. Advantages: there is low donor side mortality, minimally invasive, predictable graft size, favorable clinical outcomes, large graft, thick, strong graft can be harvested without patellar bone plug as well as a soft tissue graft. Disadvantages: the lack of a bone-to-bone healing when you don't take the bone piece. You could take a bone piece from the superior part of the patella as well, or unfamiliarity. That is the most common disadvantage. The surgeons have to be well read or trained in this procedure to harvest a graft without causing donor side morbidity, which is very reproducible. And there is a risk of rectus femoris retraction if the harvest passes across or proximal to the myotendinous junction. So those are the biomechanical properties. Yes, quadruple ST fares better, but in a patient with good collagen, and it has much better strength than low tensile strength than the native ACL, like the other grafts. The ultimate quadriceps graft size, native ACL is 725. The load to failure is 2000 for quadriceps grafts that we said in the previous slide. It is 70% more than similar width of patellar tendon graft. And prosperity data of nearly 1,000 grafts with a mean patient age of 20 shows only 4% failure rate, and those are the strength data. So coming to the technique. So that is a quadriceps harvest system that I use. They have come up with something more. The Quad Pro, which has come now, there's a company which markets the quad graft harvest system. That was a case example. A 50-year-old gentleman who came a few years after an ACL reconstruction, maybe 7 or 8 years as I remember, and the graft had failed. It was a vertical tunnel which probably was the reason for his failure. Those are the coronal images. You can see the medial meniscus which is torn and displaced medially as a flap, as a parrot beak, and the sag image showing the graft which is very loose, and we had a grade 3 Lachman positive, although the graft hadn't completely torn, and that's the patellofemoral joint, and those were the reasons where revision was indicated. Marking and diagnostic arthroscopy. Point is marked 8 centimeters above the superior polar patella, a transverse incision 2 centimeters transversely. Those are the regular portals, the anterolateral and the anteromedial portals made, and that's a diagnostic round. You can see the patellofemoral joint is good, the cartilage is pristine there, and the graft was very lax. there, it is hardly functional, and the ACL graft, although it's continuous, it's very loose. Probably the vertical tunnel was accepted by the surgeon at the primary setting, and the clearance of the parrot beak, the cartilage was good, the alignment was not affected. I always take a hip knee ankle alignment X-ray, and that's the harvest of quadriceps, the horizontal incision. You can view inside the whole length of the 8 centimeters. There is another technique by Dr. Rajiv Raman where he takes a long strip of a thin strip superiorly and uses as a quadruple graft as well here. But this is the standard described technique where you get a predictable thick 8 centimeter long and about 9 or 10 millimeter wide thick graft. So I use a Cobb's elevator to dissect the soft tissue off, and I can go all the way in. That's the scope inserted, a dry scopy. To one, it will give you the direction in which the quadriceps fibers are. They are slightly towards the lateral side, and that's the graft, and that's the blade being inserted. So you have 8, 9, and 10 mm blade. I usually use a 9, and you make parallel cuts from the superior polar patella. You make a incision on the quadriceps tendon, and you hold it with an Alice or a Cocker. And the parallel blades are used to cut a slot towards the upper part proximally, and the inferior part is again elevated with mesenteric scissors and Cobbs, and the distal part is whip stitched with fiber wire, and that is a graft harvester where you have measurements on this device about 7, 8, 9, and 10. And you can take as much graft as you want, and you just snip it, and the graft comes in your hand. It's as simple as that. And you stitch the defect that you caused on the quadriceps tendon. So that's the tendon, which is thick and robust, the tendon clearance. And when you are, this is a soft tissue graft, totally soft tissue graft, and one side is already whip stitched. The other end we use a fiber tack like device. So it's a thick fiber sheet, or like a tape through which you can pass your pre-formed. So it's a tightrope with fiber tack, which holds the other end and the graft into its position, and there. So it's got the adjustable loop attached to it, and there. That's a very, very, very strong graft, and I love doing this when we have a difficult scenario. So, and the defect being closed. So that's a quadriceps graft fixation. And another patient, collagen deficiency, 7 million. Do we have a minute more? So that's another 29-year-old male. So I was looking at what fixation device they have used. I couldn't see one, but in the lateral view it was visible here. So the marker on the X-ray hit the adjustable loop button, and that was a ruptured graft. And the reason was he had a significant ligament laxity that could have been the reason for, because the tunnel positions were good in this case. That was a grade 3 Lachman, and hyperextension demonstrated on the table. So I went ahead with a quad graft with a modified lemur. Whenever you have a ligament laxity, add something extra. You add the lemur, especially in a revision scenario. That's a modified lemur. So quick word about the peroneus longus. Yes, it's a strong graft. It's attached under the foot, and you got the peroneus brevis to take care. The peroneus brevis might hypertrophy. It's a very easy graft to take. You get a minute more. Yeah. So about 8 millimeter you always get. It's a very thick and robust graft. You're very happy getting the peroneus graft. It's the strongest graft I have seen in a primary setting, and that's it. You detach it and behind the angle and fish it out. But there are nerves nearby, and the original technique describes stitching the peroneus brevis to longus, and the longest is harvested, and you get the stripper, and it's out. It's much easier than hunting for the hamstrings. But there is no functional difference, and the regeneration potential is huge. It regenerates in a few months' time, It's a larger graft diameter, consistent size, less thigh hypertrophy. A doubled peroneus longus is as thick or as strong as a quadruple HT. So it's like the anaconda. It just gives you a very good satisfaction. But there is no level 1 evidence to suggest that's the standard practice guidelines. There are papers coming in about the complications, because the peroneus nerve, when you push it too far in, you can touch the peroneal nerve and cause numbness on the lateral side of the leg. There is hyperesthesia described. So there were 800 patients who were followed, and in this there were 2 compartment syndromes, transient peroneal injury. So the quadriceps peroneus are good graft options for revision scenarios. Similar properties as BTB, slightly better of quadriceps. The peroneus longus is very strong, but level 1 evidence is still awaited about peroneal longus as a primary graft. Thank you.
Thank you, sir.
So the topic is open for discussion. Any questions to any specific? I request the speakers to come to the dais.
Good morning, Sujit sir. Two questions to you, sir. One is that quadruple tendon harvesting. How do you stitch it with that small incision? After taking that, how do you stitch the remaining quadriceps in that small transverse incision? And is there any lag or quadriceps recovery problems which you felt after taking it? Are the quadriceps able to be firing normally as you take another graft, as in the quadriceps tendon?
Stitching is usually not a problem. I use even a retractor to lift it up. 8 centimeters is not that far. So you can use your needle holder and go in and take the bites with a fiber wire or an ethibond. The second part of the question is a very, very, very relevant question. Do we lose quadriceps power? Yes, I have had burned my fingers when I took, because I didn't know the layer concepts when I started doing it. So I was less read in that aspect, and I inadvertently took the inferior layer as well, and I could see that I had gone into the joint. I was sure, but then I stitched it very well. But still, the patient had some weakness of quadriceps. The patient wasn't that happy. So then I went to the technique and went around and found out that all the layers shouldn't be taken, because I was happy getting a very thick graft, but you shouldn't go all the way down. So it is about 18 millimeters or 16 millimeters, we already said. So you have to take only that 9 or 8 millimeters. The rest, you can use the scissors to make that slit, identify that lamination. Usually you have the vastus intermedius layer, which is separate. Unless it is that the last 5%. So you can just snip it and go all the way in and take that graft.
So do you use an arthroscope routinely underneath to see that the inner layer is not breached?
Not for the inner layer. For the superior layer I use. But inner layer you cannot see with the arthroscope. It's a feel you get. So you have to have a finger on the superior part, one person holding on to the traction suture, and you can snip and go forwards and use a Cobb's elevator or a sharp device to separate the layers.
And do you routinely tenodesis the peroneus longus and brevis after taking the graft? Because sometimes it might get tightened and create problems.
Painful bump can form behind the ankle. That is one thing I am again concerned with, because you can feel that knot there. So I initially used to stitch them, but then later on, now not the literature. I was hunting for literature for not stitching, but all literature says stitch the peroneus longus to brevis, because it's a very strong support for the ankle. And it's the anaconda you're taking out from the ankle. It's supposed to be there for running purpose, and you're taking it out. So I'm worried about taking the peroneus longus as a primary graft anyway.
Thank you.
If there are no questions, can we go? The live surgeries get ready.
Any other questions?
Thank you, Dr. Rajesh Purushothaman and Dr. Nabil Mohammed.
So next we have a live surgery, case 1 by Dr. IPS Oberoi. So we have a ACL reconstruction with plus or minus meniscal balancing. He had a twisting injury 1 month back, has pain and instability for 1 month duration. So the anterior drawer is positive, Lachman is positive. The range of movement is fall. Stress valgus varus is negative. Pivot shift is negative. The X-rays looks okay. And this is MRI. There is a signal in the meniscus as well as a complete rupture of the ACL. So over to the theatre.
Now I invite Dr. Srihari CK and Dr. Schiller to moderate the session.
Good morning, sir. IPS, sir.
ഹലോ കേൾക്കണ്ടോ? നോക്കി അവിടെ മ്യൂട്ട് ചെയ്തിട്ടുണ്ടോ നോക്കി. ഇത്രയും നേരം കേട്ടോണ്ടിരുന്നല്ലേ. ഹലോ.
Good morning, sir. Can you hear?
Hello, hello. Hello. Hello.
Yes, sir. Good morning.
Hi, morning.
Yeah, Dr. Srihari and Dr. Shilla Jose here.
Hi, morning, Hiller. Hi, Shri. So you already had a history. 45-year-old young man fell down, had an injury around month and a half back, pivoting injury. Knees relatively unstable. You saw the exam part, which was pivoting was positive and latchment test was positive. In all these patients, whenever the injury is month and a half old, it is always a good idea to do a diagnostic arthroscopy first. So already surface marking has been done. If you see, this is the patella here. That's the ligamentum patelli down, and that's the joint line. You do have a soft spot on the lateral side and a soft spot on the medial side. Our arthroscopy portal would be on the lateral. Our instrument portal is on the medial side. So this is up and down. We're giving a small stab incision here, anterolateral. You can give a transverse incision or a vertical incision depending upon the choice of the surgeon. It's very close to the patellar tendon. Perfect. And we'll just take a trocar and go in. So you go inside, then extend the knee and go to the suprapatellar pouch. That is how you do it. We connect our telescope. We'll do a just quick diagnostic round. Just lock it. Lock your trocar. Diffuse. Okay. So is the fluid on? I don't need a suction. So can you see the inside picture now?
No, not yet. Yeah.
Yeah?
Can see now, yeah.
Is the inside picture seen?
Yes.
You have to say slightly loudly. Okay, so we are in the suprapatellar pouch. That's the trochlear notch. That's the undersurface of patella. There is small chondromalacia on the undersurface of patella. We'll roll, that's the medial plica, and hypertrophied medial plica. We'll roll over the femoral condyle, go into the joint. That's the medial joint here. You could see the meniscus fragments there. That's the intercondylar notch.
where the ACL seems to be torn. There is a stump of ACL. I need a light, just don't make it dark. We make the second portal for a diagnostic part. So that's the needle which is going in. Always put a needle to put a second portal. It should be slightly higher because then you will be able to reach towards the anterior cruciate ligament part, lateral wall, towards the chondral and the medial meniscus, and the needle can also go towards the lateral meniscus. So that's the stump of the ACL which has fallen down. You can see loose bodies inside the joint, and on the medial side there is a loose piece here, there is a cartilage damage, and there is definitely a meniscus tear as well. So we'll do a quick cleaning of the joint. You have to come on this side for the lateral. So we make a small stab incision here. I'll just put a shaver to clean the joint. Give me the shaver, please. Give me the foot strip also, foot switch. We'll just do a quick cleaning of the joint because the joint has been injured around a month and a half back. There are loose pieces, so we are removing the loose pieces and preserving the stump as much as possible. That's the broken part of the ACL. These are loose flaps of the cartilage. I would need a grasper as well. Yes, grasper, just a grasper. And we'll just then quickly remove a bit of fat pad and try to see the medial side, evaluate the medial meniscus. Suction is not working. Can you check, please? So that's a loose piece of cartilage which are forming loose bodies. You grab it and then we'll have to remove it out like this. Give it a valgus strain, slightly valgus, external rotation. So foot goes into valgus external rotation. We are able to see the medial joint here. That's good. I need a shaver. So that's a flap tear of the medial meniscus. That flap is going here.
Yes.
Don't move the knee. I'm removing the fat pad here on the medial side. There is a chondral damage as well. Valgus, external rotation valgus. Foot goes into external rotation. Yeah, here, valgus from here. Come near, don't go away.
Dr. O'Brien, could you just outside image, somebody is always coming in front of the camera.
Yeah, please, from outside, he has to focus the camera. We're going towards the cartilage side. There is a loose cartilage flap. Just removing these loose flaps. Give me the probe, please. We come here. That's the flap of the meniscus which has gone up. We should excise this flap out. Give me a small biter. Small straight. We'll go in. See that we can excise it from the pedicle. It's a hard meniscus tissue. We are excising from the pedicle. Another one, please clean the punch.
Dr. O'Brien, a quick question.
Yeah.
Considering the amount of visibility that you have to the posterior part of the medial compartment at this stage,
yeah,
would you consider pie crusting early or just go on with the procedure?
No, we'll just proceed. We'll see if we need a pie crusting. We usually proceed it. No, I need a grasper, please. It's slightly tight. It says around 45, 46. We'll see if we are unable to really remove it, then we'll do a pie crusting. But right now we are removing that flap. Because there is a chondral damage also, I would need a needle, please. Isko hold kar lena. Leave that. I'm just doing a small pie crusting here. Just couple of small on the femoral side. It would help me opening the joint. Leave it. Yeah, hold that. And put on the external rotation, please.
So you do a pie crusting routinely on the femoral side?
Yeah, I do it on the femoral side. Needle, please. There are surgeons which do on the tibial side as well. So see, the joint has opened up a bit, and I think that's enough. You don't give me a probe, please. We are able to now see the medial compartment nicely. That's the medial meniscus. We have removed the flap. There is a small bucket handle tear behind. That one. Give me a shaver, let me clean, and then we need a punch. Foot switch, please. Foot switch of the shaver, please. Thank you. So it's a macerated tear. There is a piece which has gone behind. There is a piece which has gone on the medial side. Give me a left punch and so these are bad tears. Left. This is the right side. I need the left side. Yeah. So we go with the left punch. Go till the root here. So now these are macerated tears. You can't repair these tears. You see the tissue quality is so bad. So all you need to do is stabilize this meniscus to a stable margin.
So is it a root tear?
Shiver blade, please.
So one question.
Dr. Oberoi,
yeah.
The question here is, what do you do with this root? Is it salvageable or?
No, it's not salvageable. The meniscus is already extruded here. There is a cleavage component to the meniscus. There is a bucket handle tear close here, and the root is gone. You can't reduce this root. This patient would end up with a subtotal meniscectomy. Left side, please. Right side, please. We are always happy to preserve the meniscus, provided that surgery is successful. You can't repair a meniscus and thinking that it will not unite, because the chances of any kind of fixation in this is bad. This is a degenerate. And that is why it's important to identify a degenerate root tear. Valgus, please. And if you look into that meniscus tissue, it's already yellowish in between. There are all degeneration which can be seen, and you have to remove that loose pieces. So it's not a simple meniscus root tear where you are able to bring the root back. It's essentially a quite damaged meniscus root.
Oberoi, looking at at your findings, do you still believe the injury is only 1 month old?
No, I don't think so. I don't think so. Often these patients have an injury which is actually quite chronic, and they keep on neglecting it unless and until they finally end up with a meniscus which is bad and it starts giving mechanical symptoms. So see, so you'll have to see that everything is balanced out well. And I think it was a clever idea of yours that you said that we should actually go ahead and do a pike rusting, because when you see patients like these, sometimes you end up with that iatrogenic damage. So this part of meniscus is gone. We do have a peripheral meniscus which is left. There is a small cleavage component. I'll just clean it. On the root side, this is all calcified. It's hard tissue. We'll try to dissect that part out. Left punch, please. Go towards the root and try to remove it. It's a hard tissue. Avascular, calcified nodule, and with the shaver we'll just smoothen it. I'll need a left punch, right punch again for the meniscus balancing, and then we'll have to look at the. So this is done. This is done. You don't have, a patient has actually lost that part of meniscus. Give the right punch, please. And we do have a small cleavage component here. Any surgery which we want to preserve and repair the meniscus should yield result. If you put lot of sutures there in a degenerate meniscus, it actually causes more problem, especially in a patient who is already arthritic. You already see that there are cartilage damages here on the weight bearing area. Let us see the lateral side. Leave it, please. Just gently. Don't move. So that's the lateral side. We'll just probe the lateral side. So lateral root seems to be quite good, pretty good. So this is the lateral root. The meniscus is flowing nicely. That's the lateral popliteus tendon. You go under the popliteus tendon, that's the popliteal hiatus. That's the normal synovial fold. The body seems to be good, and as you come, the anterior horn seems also to be good. So lateral meniscus seems to be good. The lateral cartilage is good. ACL is broken. It's fallen down on PCL. The lateral wall is empty. So this is the lateral wall which is empty. So you have a complete ACL tear. The ACL from the tibial side is intact, but as it goes towards the femoral side, it breaks from the lateral wall and falls on the PCL. It's a stump of scar tissue which is actually falling here, which has no physical function. We'll just go directly to the graft harvest now. Our plan is to take a hamstring. We will see what best hamstring we can get out of him. He's not a sporty guy, but hopefully we should be able to get a hamstring nice and good. Give me a marking pen, please. If you look into this part of the knee, do we have an outside picture focusing on the knee? Yeah, here, where my finger is.
We have
Put the light properly.
Could we have the outside image made larger?
So
please?
this is the joint line we have already marked. Make it large. This
can
is the
have
tibial
the-
tubercle.
Yeah, thank you.
Perfect. And we go 2 fingers below the joint line and a thumb breadth away from the tibial tubercle. You can give a transverse incision, you can give a longitudinal incision. We usually give a longitudinal incision for the press exposure. So 2 fingers below the joint line and a thumb breadth away from the tibial tubercle. That's a straight incision which is given, slightly larger just for demo purposes. Go down till skin and soft tissues. Scissors, please. Lift it up, raise the medial flap, and do a small blunt dissection like this. It will help us in pushing the superficial branch of the infrapatellar branch of the saphenous nerve. One goes under the medial side, other goes on the lateral side. Looking into it, you usually need a 90-degree artery like this. Palpate it like this. You will see the pes. Palpate the pes fascia. Go down into the pes fascia. Open the pes fascia like this. Give me a forceps, please, an 11 number blade. With a forceps, hold the pes fascia and just give a small extending incision which is going down like this, down. Small incision which goes down. With this, you are able to raise this flap up 90 degree. And when the flap is up, you can actually use your 90 degrees artery, the mixture one, to go in and fish out your graft like this. Create a snare like this. The free ends go into the loop. It creates a snare and you are able to snare it off. You can go down now so that we are able to see. Now, you can take one graft, you can take the second graft as well. I'll just lift out the gracilis as well. Though I think CME should be enough in this patient, but possibly when we see the length, they are usually not good. So what we are doing is lifting the gracilis also out like this. And then free ends goes into the loop. You become loop into the loop and this creates a snare. Now you are going to lift both of these out of the wound like this. With the periosteum, you are going to remove it. Hold it. Knife, please. So this is semitendinosus. I'm just taking it out from the periosteum. Get the length as much as possible. If you look here, you have to focus from here. Scissors, please. There are a lot of adhesions into semitendinosus which are going this one, and you have to cut that band like this. 1, 2. These are 2 or 3 consistent bands, and with your finger you go in and then bluntly dissect out. Seems to okay. The tendon is gliding. Give me a tendon stripper, please. No, that's okay. That's okay. We take the tendon stripper, put the threads into the tendon stripper, go out, go gently, rotation and traction go together and together, and we are able to get a very nice graft out. So this is a good graft.
Yeah.
Okay.
What's the fixation method you are using here?
Perfect. Give me the ethibond. You have to have an ethibond, please.
So one question.
So you can take a single graft. You can take so we'll quadruple that graft, and this is the gracilus. We do have a gracilus as well. So sometimes we want a six-tailed graft because the footprint seems to be bigger one. We'll see if we need a six-tailed graft.
Probably the question is, what kind of fixation are you planning?
So it will be a suspensory fixation on towards the femoral side, and on the tibial side would be a interference screw fixation.
So what's the minimal length you are hoping? What's the minimal length you need?
The graft preparation is started in the back table, and what we are going to do is just take a gracilus out quickly, give it back to the back trolley, and then go back into the joint and see how things are happening. And we prepare the isometric point on the femur as well as on the tibia and start our tunnel preparations. So that's the second graft. We put it in. Graft harvest doesn't take more than 30 seconds to a minute or two. It is always better to have a good collagen. So I usually prefer to take both semitendinosus and gracilus. And our grafts are usually six-tailed grafts, which are thick graft of diameter between 8 and 9. So that's done. We do have a pes fascia here, which can be stitched back. This is the pes fascia. So outside picture, if you can see, just show it here. Right angle again. Can you keep the right angle here? So this is the pes fascia, and you can just stitch the pes fascia back. Especially very common in athletes. If you stitch the pes fascia back, they don't have the problem with running. And this is a simple flap which can be just stitched back. See? Okay. So let's go back into the joint. Meanwhile, they start preparing the graft from the back trolley.
So one question.
Yeah.
Suppose you accidentally cut the graft while harvesting. Any tips to retrieve?
So there is a posterior-medial incision. You give a posterior-medial incision in the back of the knee. You are able to retrieve the graft sometimes in the posterior-medial incision as well. So let's go back into the joint.
Any questions from the audience?
Shiva, please. So any questions at this moment? We expose the lateral side. That's over the top position. And this is a fat. You see there is no, and that's a fat over the PCL. And that's a soft tissue interface where you develop an interface so that you are able to remove this scar tissue and able to reach over the top position. So if you look like a window, that's around 12 o'clock above. Then we have 11 and then 10 and then 9. Go all the way back, clear it all the way back. Keep the wire ready and the drill ready. So we'll just show the isometric point on the femoral side. I've just removed all of this scar tissue from the lateral wall. As I told you, that's around 12 o'clock, and you go as down as possible so that you are able to do a graft which is laterally placed, because a laterally placed graft will help us in correcting the rotations as well. Okay. So we'll flex the knee slowly. This is at 90 degrees. You keep counter here. Shaver, please. No, this is not the offset. I gave the offset before. What is this?
So one question, do you prefer to use an offset guide or?
Yeah, so you can do a freehand also. I usually prefer to do an offset guide. Have you prepared the graft? What is the diameter of graft which is coming? .5 is the diameter. 70, sorry?
So how much is the diameter coming? It's always a good idea to go over the top because you tend to miss that over the top position. As far down as possible. Pro please. So we are in a deep flexion position. The knee is at around 120 degrees of flexion or so.
We have the outside image of the knee, please.
You
Yeah,
have the
thank
outside
you.
image. That's good. Give me a knife, stab knife, please. And prepare the drill with the wire. And give me an offset guide.
So where exactly do you place your accessory portal, Oberoi?
So I usually don't use an accessory portal. I'm going to use the same portal as my medial portal because it's usually slightly higher up like this. And with this portal you are able to. So this is the resident ridge in the front. People mistake it. You have to really go back as far as back as possible. That's over the top position. Offset guide. So that's the offset guide from outside you can see. And you usually use it from the medial portal. Wire is ready. Okay, drill. So I would need an offset guide. But then I don't use this. I use a normal wire. Normal wire.
So what's your offset, Dr.
Put it
Oberoi?
like this.
What's your offset?
So our tunnel is, our graft is coming around 9.5. So which means we would have 4.5 of reaming which is there anteriorly and 4.5 behind if I'm going to use a 9 mm. So if I use a 6 mm, we will have a 1.5 mm wall which will be left posteriorly. So that's over the top and that's a diamond. Can you flush? Is there a... No. The pump, is there a flush? Flushing means flush is there in this pump or no? The flush, no, the kadam question is. So this is over the top. And that's a diamond drill. Just be slow. Flush here. Here, drill. Yeah. Drill. Flush is not working. You flush it, no? Drill. Go to the lateral cortex. Go, no? Yeah, perfect. This will not come out. This will come out. Give me a shaver, please. You don't need anything here. Don't do anything. So that's over the top position. That's PCL. I'm just removing a bit of fat pad here. Like this. So you go as far as down as possible with our reaming wire. I'll just pull it back and see where it is. Yeah. Perfect. Good. So what is the diameter you said? 8. Huh? I graph diameter you said 9, no? It's coming. I'm not asking diameter here. Can you hold it? Let me just check. Show me the graph. Can you come here? Focus here. Give me the ethibond, please. Hold it. I'll show you a technique to stitch it. We usually don't do any needling. So that's a loop. This is called as a loop into loop technique. This is a loop which goes. It goes under the loop 1. We reverse the loop 2. And we reverse the loop 3. So just 3 loop into loop techniques. and then bring everything together, close to the end, pull it apart, pull it like this, put half hitches, one on this side, other on the other side, and lock it. You don't need to stitch the graft. It is done. That's a quicker way. Just got it published as well. That is called loop into loop technique of stitching the graft. Hold it. Give me the ethibond another one. So she will hold the other side as well now, as we did for the first side. No, that's okay. No, I need the long one. Huh? It will help us in traction. Okay, show me again. We'll do it again. This actually saves a lot of time on graft preparation. Okay, I'll do with the small one. So that's the loop which goes into the loop. We reverse the loop, goes into the loop. We reverse the loop and goes into the loop. So 3 interlocking stitches. Bring everything together to the edge. Pull traction. Lock it. Put half hitches on one side. Reverse the half hitch on the other side and just knot it. So this gives an excellent holding strength of the graft. Remove the artery, please. Like this. Like this. Perfect. Give the graft, give the graft. Give me the other graft piece. An artery. Give me a ethibond, please. Hold it. Again, we'll quickly do loop, into the loop, into the loop. I need a longer ethibond actually. Loop, into the loop, into the loop. It's very small there. Give me an ethibond. Give me a scissor. Let me prepare the graft nicely. There is an. Hold it. Give me ethibond, please. Remove all of these.
Any questions from the audience?
So any questions at this time? This is nice and long. Loop. It should not break. It has been used, I think.
I have a question. Regarding the 2 portal and a 3 portal technique of making making 2 anteromedial portals. One as a visualizing portal and one for making a far lateral to make a tunnel, versus using one anteromedial and one anterolateral, like a 2 portal or a 3 portal technique, which is better and what would
Depends upon the surgeon's preference. I usually do always 2. The 3rd portal is always for a meniscal surgery if I need to do anything. I don't use it for the tunnels.
Okay.
It's only for the meniscal surgery. Sometimes, give me a ethibond. So I use 2. So we are just finishing the knotting. It helps actually. This is a quick method because when you do baseball stitches and a bunel stitches, they actually take a long time. This is a quicker method to stitch it down. We have tested its pull-out strength. It's absolutely wonderful. Give me another ethibond, please. Hold this. Open the artery.
O'Brien, what's the length of your CME and grafts?
What was the length? It's pretty long actually. What is the exact length? 300. 300 millimeters. Can you double it?
I have a feeling you're going to have an oversized graft if you're using both.
Yeah, it's a very good graft. Hold it. And give me another ethibond. Give me another ethibond. Fucking yeah.
Dr. IPS, Sujit here.
Do it.
Good morning.
Hi Sujit, morning.
Yeah, wonderful surgery.
Give me a diameter, please.
We were just discussing about your technique. It is very nice. It's a strong hold with a number 5 ethibond.
Yeah.
We were just concerned about the diameter in the tunnel. Would it?
No, we actually use number 2. This time they don't have a number. This is number 5.
Okay.
Yeah, usually is number 2. That's a 9.5.
Okay.
Single graft 9.5 actually.
All right.
Tibial side slightly tight on 9.5. Femoral is very good on 9.
Okay, good.
Femoral is very good on 9. If I add a gracillus, it will become roughly around 10ish.
Yeah.
It's a very robust graft, very thick graft. The length of graft is also very good.
Yes. So would you use what interference screw would you use with this?
So I'll use +2. So it says 9.5 or somewhere around 10. So I'm going to use 11 or 12 depending upon the bone quality. 70. So that's length is good. So you just keep this one intact. So we'll use a 9 reamer on the femoral side because we get a 9, please. 9 reamer. So that's the position of the. Give me an artery, please. Give me a 9 reamer, please.
So what's the total length of the tunnel here? So one question.
Yeah.
What's the total length of the tunnel here?
I'll have to make the tunnel. I've not yet made. I'll usually keep around 15 to 20 on the femoral side. Not yet made the tunnel. Only thing is that we have put a bead wire which has got a trocar tip, so it always make a tunnel for 4.5. So now we go with the 9 reamer. Slowly and slowly. As I told you, we're just going to make around 15. 15 or 20. I don't usually make too much of the tunnel on the femoral side. Give me shaver. Can you do the flush on the shaver? Don't put it here. It pushes all the bottle out. Flush is never done here. I'm just cleaning it. Too much of debris. The moment you go at a bigger tunnel between more than 8, the debris formation is too much. So that's over the top position you have regained. That's cleaning. I'm just going to use a RF just in a case that you can pull out this wire, out. Don't move the knee. Take the wire out and don't move the knee. We're just going to clean it. The tunnel should be nice and clean. I don't want the graft to get trapped. Give me an RF. I'm just going to clean the margins. Give me the foot switch for RF. These are sharp edges which often damage the graft, especially if you have a tight fitting graft. So make it nice and make it rounded like this. Shaver, please. And then we'll peep into the tunnel and see how the debris is into the tunnel. We have to take it out. And I need a bead wire with a suture, ethibond, to pull the graft. So that's the tunnel. We have a very good bone in the back, around 1.5 millimeters of bone.
Yes.
And an ethibond to pull the graft up. The depth is around 20. The full length is around 45. It's a variable loop which we are going to use. So should not be a problem. When you use a variable loop, it's usually not a concern. Always remove all of this debris from inside the tunnel. Okay, give me a bead wire, please. And give me suture. Ethibond suture. So we'll give a bead wire. We'll go here. Wait. I'll go into the tunnel, bullseye, come out like this. Put me suture both threads. 2. Yeah, that's okay. No. Leave it. Yeah, wait, what is the second? So we have a suture here on the femoral side. Just keep it here. Don't move the knee. You have to hold it here, otherwise it will go inside the knee again. Okay, now the tibial side. So we'll change the angle to 90 degrees or so when we do the tibial. So for the femoral side, it's hyperflexion. For the tibial side, we go to the 90 degree. Hold the knee, please. Shaver, please. And now we'll see the isometric point on the tibial side. I'm just removing a bit of fat pad here. Give me the tibial zig. I've already set everything. Don't move it. A normal reaming wire. Put a right angle retractor. So if you see here, give me the probe. I think I'll just show the landmarks. There are a couple of landmarks which are there. That's a PCL. So you go around 6-7 millimeters ahead of PCL, somewhere here. That's the lateral tibial spine. That's the medial tibial spine. You have to come somewhere here in medial. That's the footprint. That's the anterior most part of the footprint. So wire should come somewhere in this part of the stump. That's the anterior horn of the lateral meniscus. You have to be in line of the lateral meniscus. So if you see all these things, somewhere here 6-7 millimeters along the line between this and in the center. So somewhere here we are expecting the wire to come out, and this is the right direction. That the graft has to be not standing graft, but it should be something like a sleeping graft, which should go to the lateral wall. So this is the point where we want the wire to come out. Drill.
Sir, just a question to IPS, sir.
Yeah.
Sir, do you usually preserve this much of a stump or?
No, I'll remove it. I don't think we will be able to preserve it. It doesn't make sense, but that's a pointed reduction. Can you put a wire inside and see that it is going? Wire from the tube inside and see if it is going well. Perfect.
So what's the angle of the tibial jig here?
So we keep it around 45-50 because this is a patient which is not too tall. And if you see there is a capture here, so this is going at around right ahead of PCL. We'll put a wire. From the sagittal plane, it's around 30 degrees, and from up and down, it is around 45 degrees or so. Yeah, drill please. Perfect. Yeah, withdraw a bit. Very slowly, but that should be okay. Give me an artery, please. Give me an artery. Seems okay. Go hold with an artery. Give me a smaller reamer first. Don't go directly to a 9.5 because the tibial side was 9.5. Maybe give me a 7 or 8, whatever is it. Just a bit smaller reamer, just to be really sure. Which is this size? Yeah, 7 should be okay. Give me a right angle retractor. The bones are usually hard, so we usually use a hard cortical reamer. Right angle retractor, please. Yeah, that should be good. So just use a hard cortical reamer. Now you can give me the softer reamer and we'll go by size 9. That is okay, that's okay. Open this. Or you can remove it, give me the wire. Seems okay. Perfect. Give me wire and give me the artery again. And give me 9 reamer now. The hole, put it there. Just stop the water. Oh, there's a big hole. Put it in the hole from here. It has to be here. Give me an artery, please. With the artery, I'm just going to hold it again. This is 9 now. Hold it. Yeah. We will remit at 9. That water is finished. Yes, sir. So that's size 9. Should be okay. Because the graft was 9.5, I'll show you a trick how I do it. Open it. Give me a shaver. I need a 9 flower reamer. So I've just stopped the water inflow. Right angle retractor, please. Put it properly. Put it properly. Both retractors, one on medial side, one on lateral side. Give me a small nibbler. I want to open the mouth nicely. A small nibbler or something. So this is the dry part of the arthroscopy. We usually do a dry arthroscopy. And give me an artery, please. Artery. So we remove all of these loose pieces. See these loose pieces? It is always a good idea to remove these loose pieces out. The ones which are posterior don't bother, but one which is anterior here often causes cyclops lesion. So I would usually do a dry arthroscopy at this point, and in dry arthroscopy I'll just remove all of this. So entire thing is dry. See that you don't form any cyclops here. And I want to open this. Give me a small nibbler or something. I just want the mouth to be open. And give me the reamer I told you. 9 reamer again.
Dr. Oberoi,
Yeah.
Looking at the position of your tibial tunnel,
Yeah.
Do you think it's a little more medial than you would have actually wanted it to be?
No, it's perfect. Abhi, it's 9. We have to make it 9.5. So we'll go a bit lateral now. Give me the reamer here, 9. So this is a freehand reaming which we commonly do. Give me right angle. I'll then show you like this. See? So we don't move them. So reamer is coming here and I have to clean the wall on the lateral side slightly like this. Like this, like this, like this. So the 9.5, between 9 and 9.5, it will be the working more on the lateral wall, like this. It's a freehand reaming. Perfect. Hopefully graft will not get in between now and it should be able to pass. Uh-huh. 50, 20, 40, 40, 45. Variable loop, it doesn't matter too much. Okay.
There's a question from the audience.
Yeah.
Do you ever use a dilator, and would you like to have used a dilator instead of the freehand?
Dilator?
Yeah.
Yeah, I usually love to use a dilator. We don't have a dilator here.
Okay.
We usually ream at 9 and then dilate it to 9.5. And then again, we see the tunnel from inside, clean the tibial tunnel. This all debris usually moves along the graft and goes into the joint. So if you can actually clean this area, it's nice. Can you recheck the graft diameters again? 9 on the femur, 9.5 on the tibia. Can you recheck please? When the graft is in the back trolley and they have soaked it in a saline, sometimes it becomes a bit more. Can you check and give it to me? Artery, open the artery. Put an artery here. Yeah.
One question, you use any antibiotic for the graft?
I usually don't use any antibiotic, never use an antibiotic. Right angle.
So what will be a screw size here? 9.
So we have actually reamed it around 9.5. So I will preferably use either 11 or 12 because bone quality is good. I think 11 should be good enough. 9.5 on the tibia and 9 is femur. I think that should be okay. So we'll just opening the mouth nicely so that we don't get graft which is getting stuck. Okay, give me a spreader or something. I need to pull the wire down, or maybe a hook, or a probe or a hook. We'll go in from here, go towards this, and let the thread come. Let it come, don't stop it. Yeah. Perfect. Give me that, hold the scope. Okay. Show the assembly. So that's the graft assembly which they have made in the back trolley. So if you see here, there is a button. The button has got a green thread. Green thread would be helping us in pulling the graft up. And then there is something like a tiger kind of wire. They are going to actually help us in flipping the graft. And then there is a white loop, which is actually going to make this loop smaller. So this is a variable loop. You do have a loop here. Focus it here. Focus here. Here. So there is a loop. It's a button which has got 4 holes. In between the holes, it's a loop which is going, a loop configuration. These are called 4 threads which goes into the loop. And there is a Chinese finger trap which is outside here on the upper side. You do have a green suture which is actually for pulling. And you do have a tiger again also for pulling and flipping. But you have to shorten this loop, and you shorten the loop with these 2. He has already marked it here at around 40 and another, okay. And there is also a tibial mark. Graft diameter on the femoral side is coming very nicely at around 9, and tibial is coming 9.5.
So
What
which
we're going to
company?
do is, we're going to load it, and who's going to come up? Or you will do it. I'm just going to load it up, all these sutures together, and yeah, you can give it to me, and you can take it up. Yeah, just let it go. Easily, slowly, let it go. There you go. And take all the threads out with you. So if you have an outside picture as well and an inside picture as well, you could see this. And I'll just show you from inside. So now he is holding for the pulling the threaded, and this is for the flipping. So see here now in the tunnel, we are seeing over the top position. All these sutures and the threads are going up nicely.
Yes.
Yeah. You should always see this position. See how the button is standing. It's not sitting. It's standing like this and going slowly and slowly. More. It's got flipped. Yeah. It's flipped nicely. And he's pulling it from down to check it is flipped or not. And he's toggling it above. It's okay. You're comfortable. You're sure it's flipped. Perfect. See, it's matching the mark perfectly here. Now, as I told you, this is a variable loop. He's going to give a gentle traction on this side. And our friend on the top is going to make the loop shorter. Just by pulling that loop, it's going to make loop shorter. Counter dekhe rakhna. Yeah. Yeah. Wonderful. And see how the tibial side is there. So graft starts to move up. Go over the PCL, just touching the PCL, brushing the PCL, and this is the mark which we are there. So we do a bit more maybe, because we do have a tibial mark here also and the femoral mark. It's actually fitting very good. Perfect. Rock solid. So this is the graft which is going in. It's okay. You're secure. Give me a probe, give a traction. So there are a couple of things which I want everybody here in the audience to have a look. These are 3 impingements which you should be careful when you put a graft. If you look here, this is the PCL. Our graft should not press on the PCL. It should just brush past the PCL. So there is no pressure on the PCL, no internal impingement on the PCL. Number 1. Number 2, no impingement to the lateral wall. See the lateral wall, it is going by far fast. There is no lateral wall impingement and no roof impingement. A graft is always a sleeping graft which is going down at around 9:30 position, fitting well into the lateral cortex, going down here on the tibial. It's sitting nicely because we reamed more on this side. You can see a small here, but that's okay. That's always there. This is going to all heal well. This is how the graft is. We have actually put it around 20-ish. We'll just pull it down later once we have fixed the tibial side. So beauty about a variable thing is that once you have already pulled the graft on the femoral side, you go to a tibial fixation and then you can go back and do a bit of tightening on the femoral side. We're going to do that. Give me a wire, please, for the screw. 1, that's 10. Give me 11. It's a hard HS screw which we are using. 1 up should be good. So we're 10:30. We do have a 10.5. 1025. So we'll use a 10. The bone quality is very, very good. Yeah. Anterior. Put.
What's
So we
the
are going to just put a wire slightly anterior to the graft.
What's the position of the knee now?
Yeah, we'll do it in 30 degrees of extreme. We'll come back. So that's anterior to the graft, the wire. And we are going to bring it now to around 30 degrees. Like this. Section, please. And with the extension, see how the graft is sitting nicely. Perfect. So we're going to just take it out. Outside is like this. Give a right angle retractor, please. Right angle retractors, 2 right angle retractors, and a suction. Yeah, that's okay. We usually don't do cycling these days. Once we have pulled the graft in the back trolley, nice and now good traction. It's a HA coated biocomposite screw. Posterior side, and we just go. Perfect. Just don't no jerks. Friction, please. Friction. Guide wire, we take it out and then we just complete our. So see the sound which you can actually hear from this. It's a very nice screw which goes well, fitting and got a very nice fixation here. Once we have done that, give me the. That's okay. And we can go into the knee and just let us start washing the joint because all of these joints need a lot of washing. Just keep it holding like this gently. Give me the shaver with the suction, please. And put a small. Very good. Give me a suction, please. Suction. Do we have suction tape also? I need a suction tape. So that's the graft which is sitting well, going all the way into it. Now we'll.
Dr. O'Brien, could you just show us the graft in full extension?
Yeah. Go into full extension. That's a full extension. From outside, that's a full extension. Yeah?
Yes.
No impingement, very much away from the wall. Can you hold this leg? This is perfect. We'll just do a section, remove all of this.
Dr. O'Brien, I think we might have to leave you at that.
Yeah, we have finished already. So that's a nice looking graft. Can you flex it now? So that's in full extension. It gently goes into full flexion. That's in the full flexion here. That's how the graft is looking. Shiva, please, with the suction.
And thank you for this excellent demonstration and also the commentary that you gave, which was like very helpful to us all.
Can you tighten it a bit?
Let's give a good hand to
I think
Dr.
we should
O'Brien.
thank the team here, the anesthetics team, the surgical team, and the company people all around. See how well the graft is. He's pulling on the femoral side to see if we can actually tighten it a bit more. I think we don't need to. See that lateral wall has got no impingement. The roof has no impingement. There is no internal impingement. Graft is sitting nicely tight. Absolutely tight graft. And thank you very much for being with us. It was pleasure operating at this hospital with all the team working together. I must thank Indian Arthroscopy Society for giving an opportunity to demonstrate here at an important IAS meeting, which is an outreach program. Thank you very much.
Thank you, Dr. O'Brien. Thank you very much.
Yeah. It's now all your papers. So finally, we always check if there is no phytic flexion deformity. So it's
Thank you,
going
sir.
into a normal hyper. Yeah, you can cut it.
Good morning, ladies and gentlemen. Once again, I welcome you all to another wonderful event at Mitra. I welcome you all to join IAS 1 CALICUT CME on knee replacement, knee arthroscopy organized by Mitra Hospital in association with Indian Arthroscopy Society. Learn from the masters. Yes, today we are privileged to host some of the most distinguished and esteemed experts as we mark a very significant milestone in our journey. Thank you so much for taking the time out from your heavy schedules and marking the spectacular event with your glorious presence. The event showcases a unique opportunity to learn, discuss, and connect with these eminent mentors. Now I invite Dr. Jijo Vicherian, Dr. George Abraham, Dr. Sandeep R. Biraris, Dr. Sheila T. Jose, Dr. Samir Ali, and Dr. Bashir on stage, please. Can we have a huge round of applause, please? With that auspicious start, I would like to call our Medical Director, Dr. Jijo Vicherian, to please give the welcome address.
Good morning, all. I think it's another wonderful day, a great day for Maitra to be working in association with the Indian Arthroscopy Society to conduct the CME and the workshop on arthroscopy. So as doctors, I feel that we have always been into learning, to keep learning, and this learning cannot stop at any points in our life. And I'm happy to see you all here on this Sunday. When we would all like to be at homes, in beds, with children, with family. So it's a wonderful moment for all of us here. I am sure that we are all here to attend this CME and this workshop, and I will not take much of your time with this welcome address because I'm sure that all of you are here to watch the surgery and the cases rather than listening to my welcome address. Anyways, it is customary to invite you all on behalf of the Maitra family, which I represent as a medical director. And let me invite the faculty from all over the state, across the country, all the delegates who have come over here to participate in this wonderful program. And I also take this opportunity to congratulate and appreciate the efforts taken by Dr. George, Dr. Samir, Dr. Bashir, and the entire team. When I talk of the entire team, I must say that even though we have separate units for spine and hand surgery, I'm sure that all of them have pitched in to support their joint counterparts to conduct this program. I also congratulate the organizers of this program, the marketing team, and all the employees of the hospital who have pitched in to make this a grand success. So welcome once again, and thank you all for being here. Thank you.
Thank you, sir. Now I invite Dr. George Abraham, Chairman and Senior Consultant, Bone, Joint and Spine, Maitra Hospital, to address the gathering.
Warm good morning to all of you. First of all, let me extend greetings from the Center of Excellence, Bone, Joint and Spine, Maitra Hospital. The 7th year we have started this department here. I first of all thank the Indian Arthroscopic Society for giving us the privilege to host this program. I also congratulate my colleagues, Dr. Samir Ali and Dr. Bashir, for initiating the program here. In the undergraduate and postgraduate days, teaching and learning is compulsory. But once we pass out of a medical school, the same thing is repeated as sharing of knowledge and seeking knowledge. And that's what happens in this kind of academic programs. I wish all of you an enjoyable academic day. Thank you. Jai Hind.
Thank you, sir. Dr. Sandeep R. Biraris is the head of orthopedics, Mumbai Port Trust Hospital. He is the past General Secretary, Indian Arthroscopy Society. I deem it a privilege to welcome you on stage to speak a few words.
Respected Dr. Cherian, Dr. Abraham George, Dr. Samir Ali, and Dr. Bashir, and Dr. Siral Jose, sir. So, on behalf of Indian Arthroscopy Society, I would like to thank Maitra Hospital for providing this venue and making arrangement for this conference on such a short notice. So, IAS 1 is a brainchild of actually Dr. IPS Oberoi. So these meetings were started in the tenure of Dr. IPS Oberoi and Dr. Sundar Rajan with the aim to train the doctors in the field of arthroscopy in Tier 2 and Tier 3 cities across the India. So this is the 16th program which we have been conducting with a generous supports from the industry also. Industry has been participating in this program, like as in today, MyTech has given a generous academic grant for this program. So thank you very much, sir. And I extend my greetings on behalf of Dr. Sachin Tapasvi, President, Indian Arthroscopy Society. Thank you.
Thank you, sir. We have Dr. Sheila Tijos to grace our event. He is the President, Association of Arthroscopic Surgeons, Kerala. I invite Dr. Sheila to speak a few words.
Thank you. On behalf of the ASC, the Arthroscopic Association of Arthroscopic Surgeons of Kerala, I'd like to welcome you all to this program. And I'm actually so glad to see this hall is so full of delegates, like almost like a IAS con. So it goes on to show like how many of us are like so keen on arthroscopy. And I guess that is exactly the intention of IAS to hold this outreach programs, which I just learned from Sandeep that they have one every month in different parts of the country. So that's exactly the aim of IAS, to get more people involved with arthroscopy. Because only when more people are involved, we get more talent into the specialty, and that's how we progress and we refine our techniques. So I welcome you all again to this program, and thank you for coming. And I hope you have a wonderful day today and go back home with new ideas and learn new techniques. Thank you very much.
Thank you, sir. Now I invite Dr. Samir Ali Parawat, Head of the Department and Senior Consultant Arthroplasty and Arthroscopy, Center for Bone, Joint and Spine, Mitra Hospital, to deliver the vote of thanks.
Respected dear friends, colleagues, ladies and gentlemen, I stand here in front of you with a great gratitude because we brought the IAS to our home. And this incredible journey would have been possible without the dedication and support of the numerous individuals and group. I'm going to say my thanks. First of all, my sincere thanks to the Indian Arthroscopy Society, the officers Sachin Tapasvi, Sandeep Bijaris, and Dr. Sundar Rajan for making this event great successful, and your leadership paved the way for the success of this event. And along with our home, the ASK, the Sheila sir, Dr. Sujit, for giving me their guidance how to conduct and how to structure the program. Immense thanks to you, Sheila sir, and Sujit for your support. And the most important of any conference is the faculties. Let's our colleagues, our local faculties, my dear friends, for giving here. You're spending all day because most of the time you're working a Sunday, sparing on Sunday you used to spare for us. So thank you so much for being here and enlightening your words and encouraging the upcoming surgeons for the new techniques and your wisdom. And to all the delegates, especially are the key of the success of any organizations. So thank you so much for being here, because since the 8:30 we started, I think the hall was almost 50% at this time. So thank you so much for being here and making this event a great success. And big round of applause to all the Mitra staff, including the admins, especially the marketing team. They have been here for the last 1 month, even though it's a very short notice. They have been running behind this, and thank you so much, especially for the Riaz, Praveen, and Naveen, and all the teams for making this event without any hassle-free. A note of appreciation for the audiovisual staff and food and beverages. And as the Sandeep told, this is sponsored by the MyTech, and for the immense financial support for this event, I thank them. And last but not least, certainly my deepest gratitude goes to the most important person behind these scenes, that is my colleague Dr. Bashir, and your meticulous organizational leaderships have been the commercial events to making this event a grand success. And in closing, let me carry this forward, the knowledge and the connections for during this conference. Thank you all for being here and being a part of this conference. Thank you all. Jai Hind.
Thank you, sir. Before we move on to next session of the event, we would like to invite and felicitate our esteemed guests with a small token of our gratitude and appreciation. I request Dr. Jijo Vicharian to felicitate Dr. S.R. Sundararajan, Senior Consultant in Arthroscopy, Ganga Hospital. Dr. S.R. Sundararajan joined the department in 1997 and is working as a Senior Consultant in Arthroscopy, Sports Medicine and Foot and Ankle Surgery. He is the past President of the Indian Foot and Ankle Society, Indian Association of Sports Medicine, and is currently the Leg, Ankle and Foot Committee member of ISACOS, General Secretary of the Indian Arthroscopy Society and President of Tamil Nadu Orthopedic Association. Can we have a good round of applause, please? I request Dr. George Abraham to felicitate Dr. Sandeep Barberaris. Dr. Sandeep Barberaris is the head of orthopedics, Mumbai Medical Port Trust Hospital. Can we have a huge round of applause, please? Thank you. I request Dr. Sujit Jose, Professor and Head of Orthopedics, MOSC Hospital and Medical College, Kolanjeri, to felicitate Dr. IPS Oberoi. I invite both of you on stage. Dr. IPS Oberoi, Chairperson, Orthopedics Program and Chief Robotic Joint Replacement and Arthroscopy Surgery, Artemis Hospital, Delhi. Doctor is an expert in primary and revision joint replacement surgeries of the knee, hip, shoulder, elbow, and ankle joints. He is one of the first and among only a few surgeons to start minimally invasive reconstructive surgery, that is keyhole surgery, for shoulder, elbow, hip, and ankle problems. In addition, he has mastered techniques for managing multi-ligament and complex injuries of the knee. As we come to the end of the felicitation program, let's heartily applaud our honored guests once again. Thank you, sir. Now I invite Dr. Dhyaneshwar, Consultant Orthopedic Surgeon, Aston Ortho, for the next session, and Dr. Mohammad Hassel, Senior Consultant and Orthopedic Surgeon, Aston Ortho, Calicut, to chair the session. I invite Professor Sibin Surendran, Assistant Professor, Department of Orthopedics, Government Medical College, Kozhikode, to speak on the topic, ACL reconstruction. Get it right first time.
So, respected chairpersons, senior faculty members, my dear colleagues, a warm good morning to one and all. At the outset, I would like to thank the Indian Arthroscopy Society and Team Maitra for giving me this wonderful opportunity. Greetings from Department of Orthopedics, CALICUT Medical College. So, in my brief is to talk on ACL reconstruction, how to get it right the first time. We all know that the main pillars of ACL reconstruction, the four major pillars of ACL reconstruction are anatomical ACL reconstruction of the footprint, getting the biology correct, that you try to restore the stump, preserve the stump as much as possible, have a strong construct on either side to fix this graft, and have the correct all the deficiencies. Specifically, you are relating to the collaterals. So, if the ABCD is correct, your ACL graft is, ACL reconstruction is going to be correct. So, out of this, I am asked to talk about the most important part of this being restoring the anatomy. And if you look at the literature for failure of ACL surgery, the most important aspect is the technical error of the reconstruction of the footprint. And of that, it's the 60 to 80% of the cases you have the problem is in the femoral tunnel reconstruction. So let's start with the current concepts on the femoral anatomy. We all know that the ACL reconstruction on ACL on the femoral side is attached behind the lateral intercondylar ridge, or otherwise called as the residence ridge, and anterior to the posterior cartilage margin. And there are mainly two concepts regarding the anatomy. It can be either a double bundle or a ribbon concept. So in the double bundle, you have two bundles, the anteromedial and the posterolateral bundle. The anteromedial bundle is attached more proximally, the posterolateral is attached more distally, and they crisscross each other when you flex the knee. And if you go closely, the bony anatomy shows that the anterolateral bundle, both the bundles are attached behind the lateral intercondylar ridge, separated by the lateral bifurcate ridge. Proximally, you have the anteromedial bundle, anteriorly you have the posterolateral bundle. And going to the next concept, that's the ribbon concept put forward by Robert Smigliski. So that says that it's not a bundle, but basically a flat ribbon-like structure. And its insertion has two insertions, a direct insertion and an indirect insertion. The direct insertion is in direct line with the posterior cortex of the femur, and it goes directly, and that's the thickest bundle. As you can see, that's the direct insertion. And the other insertion is the indirect insertion. The indirect insertion means it's a fan-like fiber that extends beyond the direct insertion and attaching near to the cartilage. So these are the two insertions. Again, that's the direct insertion and that's the indirect insertion. So out of this one, which one is the most important thing? This is a beautiful paper by Sasaki et al. Which shows that you have the direct as well as the indirect insertion, and they studied it microscopically, and that showed that the direct insertion has a better, is more stronger, has better collagen, and around 80 to 90% of the fibers are attached in the insertion of the direct fibers. And in this direct fibers, which is the most important area that gives resistance to the anterior drawer. So if you see, this is the direct insertion, that's HGFE is the direct insertion, and of that, it is the proximal and posterior most part of the direct insertion fibers that gives the maximum strength in this laboratory study. And we all know about the concept of isometry. Along in the isometric concept, it's not basically the posterior and proximal fibers are most isometric. That means it is the anteromedial fibers that are most isometric. And this is an interesting paper that says that if you are using a soft tissue graft and you are putting a tunnel in the center of the anatomical footprint in the lateral bifurcate ridge, what happens is that although the tunnel may look good, but when the soft tissue grafts in a single tunnel, when the soft tissue grafts get stretched, where you fix it on the tibial side, the whole of the graft moves anteriorly, so that it goes away from your anteromedial fiber and goes more distally. So it goes to a more non-anatomical site. So soft tissue graft gets eccentrically displaced when specifically in a single tunnel, soft tissue tunnel, and you're fixing on the femoral side with an endo button. So from these studies, the ideal femoral tunnel should be high and deep. And how to identify these high and deep fibers? You have multiple techniques. The most important one is an ATP ACL footprint. The clock phase is not completely alone followed. It's basically obsolete. So the most important thing is, you can identify the ridges, the lateral intercondylar ridge or the lateral bifurcate ridge. But for that, you have to remove all the stump on the femoral side. So that's not good from the biological point of view. So what commonly we do is then look for the native ACL footprint, as was shown by Professor Abroy. So you can find it easily, and you can view it very beautifully from the anteromedial portal. So you find it and you find the mark it with the contour pick, center of that, and you can view it better if you keep the leg in a figure of 4 position. So that's showing the importance of an anteromedial. Now this is a view from the anterolateral portal. So it's difficult, you don't get a complete face-on view, but when you change it to the anteromedial portal, you see the stump, the anatomical stump, and there you can make the mark. Then there is an ACL ruler technique that's not commonly followed. You can measure the whole length below the lateral intercondylar ridge, and some come somewhere between 40 to 50% from the posterior. Next technique is, and you can use a fluoroscopy also for this, but you need a Hertel grid, something like that. And that shows that the footprint is around 30% from the posterior and superior wall. And this is one of the most reproducible technique that is, but it's not commonly used. You can use it for special circumstances like when you're doing a revision, whether when the footprint is not visible, or when you want to augment, when one single bundle is there and you want not to destroy that, you can for the partial ACL tear. You can always use a offset tamer, but this is a one-size-fit approach all. So always use it as a secondary thing to reconstruct. Once you find the anatomical point, use the offset guide to check the point, rather than using it always as prime. So what is another technique that's what I commonly use is you look for the posterior landmarks. So Dr. Oberoi was highlighting the over the top position. So how you can find out the over the top position is that you can look for the posterior femoral cortex. You can go for the end of the cartilage. That you can view if you go through the anteromedial portal. You extend the line and your insertion point is somewhat, just a minute. So your insertion point is just antero-inferior to that. So how to get there? Clear the soft tissues with the RF and go through the anteromedial portal, and that's the posterior edge of the cartilage, and that's the posterior cortex, and go just antero-inferior. That will be the attachment point. And if you have a 70-degree scope, that gives better vision for this. And you can use an offset guide to just reconfirm the position. So this is just a small video that shows that. So you have an anteromedial portal, and you can see that's the posterior edge of the cartilage, that's the posterior cortex, and so that's the posterior cortex. And this you can see only when you have going through the anteromedial portal. That's the intercondylar ridge, and that's the bifurcate ridge, and somewhere just proximal and posterior to that, you just make the tunnel, so that the tunnel covers both the anteromedial and the posterolateral bundle. So that's not blowing out, and then you can just check it again with your offset guide so that you are not going too far posterior. So that's a second check. And another guide that you can use is this is a bullseye guide, as this provided by the CONMED. So that will give you just an idea how much is the size of your tunnel before you drill the tunnel. So it comes in 8, 9, 10 diameters. And so then you can move forward and go and drill the tunnel. So all these things are summarized in this acronym IDEAL by Stephen Howell. That means the tunnel should be nearly isometric, so posterior and proximal, should be localized in the direction of the direct fibers. So that's what we are going in the higher point. Should be eccentrically located, should be anatomic, and should be somewhat like that. Should not be too high, like a transtibial, should not be too low, somewhere in between, and with a not more than 2 millimeter bridge in posteriorly. So that shows that you are high and posterior. Now going to the tibial side, so again both same concept. You have a double bundle concept and you have a single bundle concept. Double bundle is anteromedial and posterolateral, and this is the ribbon concept. Ribbon concept shows that the tibial insertion is a C-shaped structure. That means it surrounds like a C around the insertion of the anterior horn of the lateral meniscus. So like a C. So in this concept there are no posterolateral fibers. It's only anteromedial type of fibers. And mind you, if you are going more laterally, you are damaging the anterior horn of the lateral meniscus. So how to find out the tibial footprint? Again, revising the same point that was shown in the live surgery. You can take the center of the ACL footprint, that's the common one. You can go through the anterior horn of lateral meniscus or around 7 millimeter anterior to the PCL in a 90-degree flexed knee. So this paper shows that only soft tissue landmarks you may be confusing. So only taking the anterior horn of lateral meniscus may not give you a constant relationship. So they advise, this is a paper by Freddie Fu, they show that you can take two other landmarks. It's around, the footprint is around 9 millimeter behind the intermeniscal ligament, or around 5 millimeter anterior to the line joining the medial and lateral tibial spine. So once again, so you take three landmarks for the tibial side, the anterior root of the lateral meniscus, the intermeniscal ligament around 9 millimeter behind, or from the medial tibial spine around 5 millimeter anterior. So this is another thing that these are the bony landmarks. Just like on the female side you have lateral intercondylar ridge. Here you have a medial tibial spine, medial intercondylar ridge, and anterior ridge. But for this you have to remove all the soft tissues. Then only you will be able to identify. So this tunnel is more flush with the medial tibial spine. So that's a small video. So this is again viewing from the anteromedial side. That's the find out that both the spines. That's the lateral tibial spine, medial tibial spine, and that's anterior horn of the lateral meniscus. Keep your jig more towards the medial side, more flush with the medial tibial spine. And usually if you retain the stem, your pin should be coming out in center, somewhat like this. So once you make it, you should see that the tunnel is more towards the medial side, flushing with the medial tibial spine, not damaging the medial cartilage. Anterior it can extend up to the anterior ridge, that is just behind the intermeniscal ligament. Don't go too posterior, you may be impinging upon the PCL. So that's the final view. It's an oblique. So the view again from the medial view. It's an oblique graft, nicely coming through the stump of the PCL. So again, on the tibial side, you can recheck with the fluoroscopy if you have a doubt. So usually the graft should be, the tibial tunnel should be around 44% from the anteroposterior length and well behind the Blumenstadt's line. So to conclude, so AM portal viewing definitely improves your tunnel accuracy. Always try to preserve native tissue. That will improve the biology and healing. On the femoral side, you have the go to the posterior side, check the posterior femoral cortex and cartilage, and then go to that's over the top position and make out the tunnel. On the tibial side, not just confined to the anterior horn or lateral meniscus, but see the other spine, mainly the medial tibial spine and the intermeniscal ligament, which are reproducible landmarks. And always use multiple checkpoints, multiple landmarks. Don't hesitate to use including the C-arm if you have a doubt to reconstitute the anatomy. Thank you.
Thank you, Dr. Sibin, for that excellent presentation as usual. We have been asked to go fast since we are running short of time. So I would like to invite Dr. Bashir for his talk on remnant preservation in ACL reconstruction. We'll have a short discussion at the end.
Good morning. I will be talking about ACL remnant preservation. So most often we see such cases where it's just a femoral avulsion, and it's often sad to remove all these tissues which are highly vascular, specified collagen, and we are replacing it with a tendon which is said to be ligamentized, but electron microscopically it is never a ligament. So if we see how successful our ACL reconstruction are, the return to play is only 63%, high chance of re-injury 23% in young and athletes, causes weakness in about 1/3 of our patients, and high chance of OA risk. So long-term patient outcomes are often lacking in terms of neuromuscular control, dynamic knee stability, and return to sports. So if you see the latest trends, in the last decade we have been talking about double bundle reconstructions. Now we are more focused on preserving the anatomy and the biology, individualized ACL reconstructions, and also adding adjuvant procedures like LET if needed. So what is a remnant? In complete tears, it is the remaining tissue, and in partial tears, it is the remaining bundle. So let's see why it has to be preserved. First of all, it's a vascularity. We often see these vascular channels on the synovium over the ACL. So we all know it is supplied by the medial geniculate artery, and the proximal part has a greater vascularity. So histological examination has shown that ACL has a healing potential, and the new blood vessels develop from the synovium, infrapatellar fat pad, and the pseudoligamentum mucosum. So the vascularity above the synovium is very important. Also, this study has shown it is the intra-articular portion of the graft that undergoes first and the fastest revascularization. So it is the synovium which plays an important role in the revascularization of the graft. Next is the proprioception. Studies has shown that mechanoreceptors are present especially in the tibial attachment. It is present up to 3 years after injury. So they have a role in a reinnervation. And what about stability? So Crane et al. Has shown, he checked the stability before and after removing the remnants. And he showed that ACL remnants contributed to the AP stability up to 1 year after the injury. And there is no rotational stability though. So why preserve the remnant? There are enough reasons. Preserving the vascularity so that revascularization occurs fast, preserving the proprioception so that the post-op proprioception is better, and also biomechanical stability. So Crane classified into type 1 as the remnant attaching to the PCL, type 2 is remnant attaching to the intercondylar roof, type 3 to the lateral wall, type 4 is a complete rupture. And we all know the Sherman classification. Type 1 is the soft tissue avulsion from the femur. Type 2, there is a 20% femoral attachment. Type 3, 33% of femoral attachment, and type 4 is a 50%. So this is a modification of Sherman. It's a working classification. They have also included tissue quality, and depending upon the type, they have advised the repair techniques too. So in remnant preservation, we have different treatment options. ACL repair is the most top form of the remnant preservation. And next comes a single bundle reconstruction. Third is the remnant tensioning or reattachment. Fourth, remnant preservation. And fifth is the remnant reconstruction. So we do the arthroscopy. We check if it is a complete or a partial. We check for the attachment of the remnant. we assess the length of the remnant and the tissue quality. If the bundle is intact, we have to check if it is functional or not. PL bundle in the figure of 4 position, AM bundle in 70 to 80 degrees. So primary repair is indicated in type 1 proximal tears, pediatric tears, acute tears. There should be sufficient length to reach the femoral footprint. And the advantages are no grafts, no tunnels, revision is easy, but there is a high failure rate. So type 1 tears, we just put bundle stitches and repair with a rotator cuff lateral row anchors. Type 2 is a single bundle reconstruction, preserving the other bundle. And type 2, it's an augmented repair where the remnant is too short to firmly approximate to the femoral wall. So what we do is, we put a biological graft as well as repair the remaining remnant. In type 3, it is the normal reconstruction, but you have to tension the remnant so that it has the mechanical properties as well as the proprioceptive functioning. And in type 4, we just preserve the remnant of the tibial attachment. So in the graft choices, we have to look for soft tissue grafts like hamstring and quadriceps. BPT can be a bit difficult in remnant preservation, although it is advised, also it is described. So usually 8 or 9 millimeter grafts. Femoral tunnel trips, as usual, low anteromedial portal. It should always be anatomical. You can use protectors from the meniscal set. And another technique is using an outside in technique. And if it is a narrow notch, you can always do a notchplasty. Tibial tunnel is a normal anatomy you can see in the tibial tunnel. Usually the footprint is split, tip aimer, avoid anteriorization, lateralization. We use the serial reaming, start with 6 mm or 7 mm. And this is the samba dance which you can see while reaming the ACL. You can see the whole ACL dances. And if you are still not sure, you can use the intraoperative radiographs. So here you can see you are splitting the tibial footprint and putting the tip aimer and serial reaming. So you can adjust a little if you are using a serial reaming, and you have to take the ethibond through the remnant so that the remnant gets tensed. So here this case the remnant is attached to the PCL, and when we pass the graft, the whole of the remnant is preserved as well as the attachment to the PCL is also preserved. So the vascularity is preserved and the mechanoreceptors. So it looks a nice and tight graft with a whole remnant preserved. But there are downsides. Identifying footprint anatomy may be difficult. You can cause faulty tunnels like this where you can cause damage to the remnants. Cyclops is an important thing you have to look for. You should not just preserve the remnants which is loose, and it can be technically challenging. So if you look at the results, there are a lot of studies, especially from the Japanese group. So they significantly improve postoperative knee stability, and depending upon the initial graft coverage, better outcomes, and no cyclops lesion. Another study, 372 patients, 2-year follow-up, decreased graft rupture. Another study, better position sense and better joint stability and better results. And another study with second look arthroscopy, it shows better synovial coverage, better proprioception. So just one case, here 17-year-old male, here we can see the femoral attachment is almost there, although it is healed to the lateral wall. So here the mid substance and the tibial side is almost ruptured. So we have to pass the ACL graft through the remnant, and also on the femoral side try to avoid the radiofrequency in such cases and use shavers and curettes to clean the areas. And then we pass the graft through the ACL. So it's an intra-ACL graft passage, so the remnants get also tensed and it gets fixed, so that you don't have floppy fragments, and it provides a stability as well as the. So this is an intra-ACL with remnant tensioning. So another case is 18-year-old female. It's almost like a femoral soft tissue avulsion, but here you can see it's an unstable stump. But we go for the femoral reaming, and here it might be a bit difficult to pass your graft and the endobuttons. My visualization can be a bit difficult, And we can see this unstable ACL stump. You have to either take it out or repair it. So it's better to repair. So you put a all suture anchor and repair it to its normal footprint. So another case, 27-year-old male, twisting injury. Here it's also the ACL is attached to the lateral wall. So in this case, we almost it's like a PL bundle rupture. So we are not going through the graft. We are going by the side, so that it's almost like a PL bundle reconstruction. And you always have to check for the impingement, lateral wall as well as the superior. And another thing is the beer implant which has come into place. So here it is said that the ACL doesn't heal by itself because of the surrounding milieu is not there. So it's a bovine collagen with extracellular matrix. So you put it inside between the between the ACL remnant and the graft, and we infuse whole blood 10 ml into it and suture it to the ACL stump. So it has been showing to be promising results. So to conclude, not all ACLs are same. Look for partial tears. Preserve the remnants as far as possible. It can be technically challenging, so but it should never be at the cost of the accuracy of the tunnels. Thank you.
I welcome the next speaker, Dr. Jyoti Prashant, for his talk on ACL avulsion fixation.
Good morning, and thank you all. Actually, it is a real pleasure to be here in CALICUT on Sunday morning, and thank you all the organizers for giving me an opportunity. My topic is ACL tibial spine avulsion. That is how you deal it. So here you can see in MRI the ACL is avulsed and the tibial spine is pulled off. And here I'll just go through a bit of normal anatomy of the ACL. And Sibin sir has already told about the ACL anatomy, so it will be better for you. So here you can see the lateral meniscus. The lateral meniscus anterior horn is just coming and making a C around the ACL. So while the tibial spine gets avulsed, you should be careful that the lateral meniscus anterior horn is dealt with. It shouldn't be trapped underneath. Here you can see the ACL this is a normal ACL. There is no avulsion here. Normal ACL is there. And there, the medial meniscus, in that I am probing the medial meniscus, and from the medial meniscus, you can see the anterior intermeniscal ligament is coming, and it is a band-like formation, forming a band-like thing, anterior intermeniscal ligament. So these two structures should be taken care while doing a tibial spine fixation. So the anterior intermeniscal ligament should be pulled anteriorly and kept away from the fixation. Otherwise, it might go underneath and it might not cause a proper reduction of the fragment. And the lateral meniscus, see that the anterior intermeniscus ligament is coming from the anterior part and crossing the meniscus and going to the opposite side. So if you don't take care of the anterior intermeniscal ligament and the anterior horn of lateral meniscus, you might not reduce the fragment properly. And the next thing is that you should use a passport cannula and you should use 3 portals. So the 3 portals are there, you can see. And the passport cannula is so that the sutures doesn't get entangled in a soft tissue and the fat pad. Here you can see the scope is done and the fragment is elevated. And it will be like this. It will be an elevated portion only. You can push it down. You can debride it and push it down with a shaver, and still it will go up again. So what you can do is that you can again push it down and you can put a K-wire so that it will be fixed properly there. And after putting the K-wire, you can take bites through knee scorpion or other suture passing materials. Here you're using a fiber wire and a knee scorpion is used, and here a cinch knot or a luggage tag suture is used so that it will be pulling the ACL there. You can see that the fragment is fixed with the K-wire on the left side and the cinch knot is being put. Here I have purposefully not used the cannula so that you can see that the sutures are entangled in the fat pad. So ideally you should use a passport cannula, and again, this is a lasso in which you are taking, if the fat pad, if a lasso can be used, and here you are drilling the tunnel and you are crisscrossing the fiber. So that you're drilling the tunnel and the two fibers are crisscrossed and you are pulling it down. So here you can get a stable fixation. Another method just like this is that here you can see the crisscross and that will be pulling the fragment down over there. And another picture, the same thing is you can use a lasso straight, and if you don't have a first pass or a suture, that is here you can see this a lasso is used there, through and through it, you are putting through it, and you are taking the fiber wire or fiber tape through the substance of the ACL. And similarly, you are passing another one in the opposite side. So you are getting one fiber wire and fiber tape, or two fiber tapes you are passing through the ACL, and you are again drilling two holes, and you can crisscross it and pull it down. So this is another method in which you are not using a first pass or a knee scorpion like device. Here the two sutures are passing through the substance of the ACL. See that this is in the other opposite direction. The suture lasso is passed and the suture is shuttled through the ACL substance. So in all these, the suture materials are retrieved and the two drill holes are drilled and it is crisscrossed. So you get an X-like configuration with the fiber tapes. Here you are pulling it through. So the two fiber tapes are going in through the ACL substance, and you're drilling two holes, and these are through the fragment, that is the tibial spine, through the fragment you are drilling it. Actually the knee scorpion makes life more easy, but this also can be used. And you are crisscrossing it. You are taking the sutures to the opposite side to make an X-like configuration, and through the two tunnels you are pulling it down. You are probing for the tightness of the reconstructed one, and you don't see any implant because you are using just a bone bridge. So post-op X-ray looks very nice, and you won't see any implant because you're just using a bone bridge. So thank you. So this was a 5-minute demo, so I couldn't be making it faster because it's a technique. Just 5 minutes was allowed for me. So thank you for the patient here.
Thank you, Jyoti, for that excellent presentation. We would like to invite the speakers on stage for a short discussion. Dr. Sibin, Dr. Jyoti Prasad, and Dr. Bashir.
Any question from the floors? Sir, one question, sir, to Sibin, sir. Sir, if you are using a hard graft like BPT, in that case, any adjustment will be made in the femoral tunnel? Or it will be same for this hard graft and soft graft?
So that's a nice question. So what I told is mainly for the soft tissue graft. In the PPTP, you should have adequate posterior wall. So it's better to come little just not so, don't so go posteriorly, because there's a chance that you might go posterior blowout.
Okay.
From around 30-34%, you'll go up to 50%.
Yeah.
Anterior.
Yeah.
And one more question, sir. So the most of the studies has told that AM bundle will be more for anteroposterior stability and PL bundle for a rotation stability. If you go for the over the top, it's mostly reconstruction of a AM bundle.
Yeah.
So will you go for over the top still, or you will be taking the center of the ACL graft?
No, that's what I was telling. If you take the center of the ACL graft in a single bundle, you are basically, when you tighten it and say end of suspensory fixation, you are basically covering the posterolateral.
No.
So anteromedial is more important to provide the stability. So when you're making the graft with a little higher port, you are covering both anterolateral and posteromedial.
Okay.
So it will give you both stability as well as rotation stability.
Sure. To Bashir, do you use internal bracing along with your ACL, acute ACL repair, Sherman type 1 and all? Internal bracing?
No, sir.
usually don't do the ACL repairs. I don't think it's that.
Any of
advised
the
nowadays.
faculties you
So-
do ACL repair using internal bracing? Sibin, what's your?
I have not used internal bracing with ACL repair. I have just repaired it with the push lock type anchor. That's done.
Okay.
So it's advised that you can use internal bracing to has a seat belt effect. So, but it should not be tight, and it should be used. You tighten it in extension.
A question to Dr. Bashir and all the faculty here about remnant preservation. The younger surgeons here should understand that the remnant, yes, proprioception. There are papers saying that proprioception is an important thing you should be having in mind. But we have seen our seasoned surgeon, Dr. IPS, saying that no, I don't preserve the remnant. That is a very clear statement, because most of the surgeons here, or we've been doing in hundreds of ACLs, and we feel the remnant, if it is preserved much, it can affect the accuracy of your tibial tunnel. So as long as you are that accurate in placing, which we cannot blindly do 100% accurate, the remnant can be a double-edged sword. It can actually cause problems. With one, it can cause a cyclops in the front if you preserve the remnant in the front. It can, I have had problems with extension deficits. Then impingement on the side, overstuffing. These are all problems which the remnant can cause. So don't overdo it, is what I would say. And please,
It has
your
to be
comments.
individualized, and you have
No.
to. It's technically a bit demanding. So
Yeah, but
it's
see-
not advised, especially in the early stages.
Yes, Sujit said.
Yeah, go ahead.
No, the same point I also wanted to make. We already, Sujit made the
Yeah.
point, especially for the youngsters. For the at least first 100 cases, please don't do a remnant preservation, because the high chances of that we making a wrong tunnel, because you are not having enough visualization, you can make it a wrong tunnel. So that is, the whole surgery is going to be failed. Your regular ACL reconstruction always have a good chances of having success. Why do you want to do a remnant preservation? If you are in the early part of your career. Of course, in your later, if you had 100 and 200 cases, you can preserve the stump. And when you do a preserve the stump, again, the tibial stump, if you are preserving, it's good. Okay, you can preserve. But if you are preserving the whole ACL, then you have to be careful that you do not do a overstuffing. That is important. Like, you should not use a 8 mm or a 9 mm graft. If you want to use a supplement, you use a 7 mm or a maximum 8 mm, you can use it. Because when you use a bigger size graft, already you have a remnant preservation, the chance of getting both flexion deficit and extension deficit is high. And even we had revised cases of remnant preservation. I have done 3 cases so far. I have revised remnant preservation from done outside. So please, we have to be very careful when you do, should not do a overstuffing, and maybe the early part of career better to avoid, and it's not compulsory that you should do a remnant preservation. Always you preserve the tibial side. Tibial side always there will be remnants. You preserve that. But if you are preserving the whole, this thing is very tough. You do a repair with internal brace, no problem. But if again keeping the whole ACL, again putting an 8 size graft, 9 size graft is the issue. So better to avoid that.
Biology should not be at the cost of anatomy.
Absolutely.
A is first anatomy, then is biology.
And
So,
FFD is the most disabling problem, because when you do
Yeah.
overstuffing, the people comes with the 20 degrees FFD. Unless you revise it, you remove the stump, it's not possible to get off that FFD.
Especially if the anterior remnant should not always be better to shave off or
And you
less
put a-
RF, use RF.
That is because of you're putting a bigger size graft also, 8 size graft, and already the whole ACL stump is there. So that's
Totally
why-
agreed. Yeah.
So, one last question to Jyoti Prasad. If it's a skeletal immaturity patient, what is your mode of fixation, tibial spine avals?
Skeletal immature patient also, the small bone tunnels will not affect that much, because the tunnels are very small. You are just taking the sutures down. That will not affect the epiphysis. That is usually the thing.
Dr. Prince is coming with a pediatric ACL topic. So,
So interference screws, we usually use it in BTB graft. So it's advisable to use a offset jig. So if your graft size is a 10 millimeter, you make sure that you have a 7 millimeter radius posteriorly. But when you are using a soft tissue grafts, you usually use a suspensory fixation. Even in case of a posterior blowout, you can get away with a suspensory fixation.
I have it's a purely technical question to JP. You had that was a wonderful video that you showed of reattaching the avulsed ACLs. you said you're using a knee scorpion. Am I right?
Yes, yes.
So as far as I know, that knee scorpion takes only 0 or smaller fiber wires. It doesn't take bigger tapes in number 2. So my question is like, how did you use a knee scorpion for
We
taking a
needed
bite on the ACL?
shuttle a small suture and a tape through it.
Okay, right. Okay, thank you.
Thank you so much. We'll move on to the next session.
I would like to invite Dr. Sandeep Biaris and Dr. Rajit Valsan to chair the session. I invite Dr. Schiller T. Jose for his next talk on BPTB ACL, the good old standard. Gold standard.
Good morning. All of you, thanks the organizers for inviting me to share my thoughts on patellar tendon. I started my career of doing arthroscopy and cruciate ligament reconstructions with only patellar tendon bone grafts. For several years, I was only, that was the only graft I knew how to harvest, and that was the only technique I knew how to do, by which I could do cruciate ligament reconstructions for several years. Then I don't know for why or for what insane reason that I started switching over to the other grafts, because I do get to see my own patellar tendon grafts after several years due to some other reason, like a trauma or a loose body, and those grafts look absolutely wonderful to me. The patellar tendon grafts, the way it's vascularized, looks almost okay. That was a statement I'd like to make before I go into the topic. And don't worry, I'm not going to describe the anatomy of ACL at all, because this slide is put up just because it's a tradition to talk about anatomy. The only point I'd like to highlight is the load to failure, like how strong a normal ACL is, and our daily activities of living, we need only 20% of that strength of ACL. Now, the way the normal ACL is attached, you all know it's by direct, indirect fibers, and the direct attachments of the ACL are more important because there is a gradual transformation of the ligamentous tissue to fibrocartilage, mineralized cartilage, and bone, unlike the indirect attachments like the sharpish fibers, which actually is the way your graft heals, especially when you're using soft tissue grafts, soft tissue alone grafts. So the bone patellar tendon bone grafts achieve direct fixation to the bone, and the bone-to-bone healing, as you know, is far superior to soft tissue to the bone healing. Like in any other surgical technique, you know that, and you have a progressive increase in the tissue stiffness of the patellar tendon because you have the bone plugs, and it reduces the stress at the attachment of the ligaments to the bone, and the vascularity of these grafts develop much faster than the other grafts that you have, the other options. So if you look at the graft, this is what it should normally look like. You have bone plugs at the either ends and the ligamentous structure of the patellar tendon in the middle. Now if you look at the comparison of different grafts, you'll find the one highlighted in yellow. It's almost 3000 Newton meters. It can withstand that much of force. And it's comparable to most of the other grafts. Definitely the quadruple hamstrings and the double peronees are a little superior to it. But at the end of the day, if you look at the entire construct, it's the weakest link in a chain that decides the strength of your fixation. So if you look at the one highlighted in the light brown at the bottom of the chart, you find the fixation. It's only 500 Newton meters. So however strong your graft is, if you have to also consider your fixation technique. Now this is the other study where the patellar tendon fares well, and you see this, the load to failure is quite high. It's almost similar or slightly superior to your normal ACL graft. Now, specialized indications where you actually go in for this graft is when you have an ACL tear with, these are some of the examples, there are like other indications as well. When you have a medial side injury and you don't want to disturb the medial side, so go in for the patellar tendon. Revision surgery is where you have bone loss, where there is widening of the tunnels, loss of bone on the femur, the tibia. This graft helps because by taking a slightly larger or modified bone plug, you could fill in these defects. And then in athletes whom you don't want to sacrifice the hamstrings, especially the hurdlers or triple jumpers and people like that. And of course, if you are thinking of combat sports, you might prefer a patellar tendon or a quadriceps tendon, which has a much higher stiffness, and maybe you'll add an extraarticular tenodesis also to them. So steps in reconstruction of the patellar tendon graft: first is the harvest, 2 is a positioning and the fixation. And a 5 centimeter incision is made. There are several ways of doing it. You could do it through 2 incision technique by an oblique medial incision. This is how I do it in a midline incision. And I preserve the paratenon. And I mark the boundaries of the patellar tendon, take exactly the middle 1/3. And along the collagen fibers, which are quite visible, I do a freehand marking of the bone plugs with a cautery at a very low strength so that I don't burn the tissues. So I just mark it freehand. The tibial thing being much bigger than the femoral. I like to put the drill holes before actually I cut or harvest the graft. And then using a knife, I incise the graft along the collagen fibers, not going too deep to open the joint. And then finally the thing is you have to use a very fine, precise saw, and don't use just osteotomes. The osteotomes you use only to prise the bone plug off the bed, taking care not to fracture the patella. So then you separate the soft tissues in the retropatellar fat pad and free the graft from the patella. So this is what it looks like after you harvest. It's quite a liberal incision in this one, which I recorded for the video. Now the important thing is when you prepare the bone plugs to the correct size, you save all the nibblings that you get to use as a bone graft later on to fill up your defects. So size your bone plugs, and then stitching the graft, better to use a number 2 non-absorbable threads, and take care to take a bite on the graft ligamentous portion of the graft as well, so that when you pre-tension it or when you pull it, you don't pull off the bone plug from the graft. So this is how it might look like at the end of preparation of your graft. Measure your graft, try to mark the length of the bone plugs so that you don't have this intruding into the joint space at the end of fixation. Now, I'll not go into the details of this. I'm sure it's been explained already in the previous talk, but you have to get your femoral and tibial tunnels right so that there is no graft impingement and you get a fairly good stability. So on the femoral side, usually I prefer to do it freehand. I don't use offset guides, and I don't believe in remnant preservation much because there are a lot of controversies regarding that. I want to ask some more questions to the remnant preservation people, but then there's no time. Okay, then I go exactly to the center of the footprint with a curved awl and do a serial reaming on the femoral side. I don't go in directly to the 9 or 10. I do 7, 8, 8.5, 9 so that I don't cause any thermal necrosis to the bone. But the important thing is I notch the femoral tunnel with a barrel burr or an acrominizer, or you have a specialized notcher available so that it will take the screw in there without damaging the graft. Now, locating the tibial tunnel is not that easy if you have like a lot of soft tissue remnants there. But you have to understand that the attachment of the ACL on the tibia is actually a very long incision extending anterior to posterior. So identify that and take the midpoint of it so that it comes fairly in the middle of the two eminences. And the center of the tunnel is sort of in line with the posterior border of the anterior horn of lateral meniscus. But all these landmarks that you have are variable from knee to knee. So you have to take several arthroscopic landmarks into consideration before you get it right. So when I ream the tibia, I do it under a dry scopy so that I can collect all the reamings, so that at the end of the procedure I have a respectable amount of graft to fill the defect. So the final sizing of the graft, I check again if it is size the graft, and then I pass it through the tibial tunnel into the joint. So this all done in dry scopy, but you could always do it with the fluid on as well. See that the femoral tunnel bone plug is well seated into the femoral tunnel and doesn't stand proud into the joint. And then coming to the fixation technique, I always do the screws, both for the femur and the tibia. But you do have certain endo buttons specifically designed for the patellar tendon. And this is, while passing the screw, be careful that you don't damage the graft. So you have a thing called a notcher. You can again widen your tunnel. And I usually am happy with smaller screws, like 7, rarely 8, because most of the times my femoral bone plug is quite sitting well and tight inside the femoral tunnel. And on the tibial fixation side, again, you could use, I use a screw. And if there are any proud portions of the tibial bone plug, I nibble that too off and use it as a graft. And then finally, I pack the defects with all the nibblings and the reamings that I have, so that there's no bone, and just stitch the paratenon alone. I don't stitch the graft too tight. So if you want a secondary fixation, you have an option of doing a transosseous, like how it's shown here, into the tibial tuberosity. So the complications they have been describing for a patellar tendon are anterior knee pain, patellar tendon contracture, patellar fracture, quadriceps weakness. I have never ever seen any of these complications, to be honest, because I've been, if you harvest your graft carefully, whereas with hamstrings, I've had a lot of problems. People complaining of pain, medial side of the thigh, weakness of flexion. None of these with patellar tendon grafts. But only thing is you have to perfect your technique of graft harvest, how you do it, and the way you close it after you finish the procedure. So I think there's no ideal graft, but even though I've been speaking in favor of patellar tendon so much, which I still firmly believe, but you have to discuss with the patients, because sometimes patients come and tell you like what graft they want. There's research. Many of them come and ask for quadriceps graft. So, and you do harvest the graft in which you're trained properly to harvest, but you should always know to harvest more than 1 or 2 different kinds of graft. Thank you very much.
As Dr. Sundarajan has to be in theatre, will do his talk on Pediatric ACL unique challenges.
Good morning, everyone, and I take this opportunity to thank Samir, Bashir, and the whole CALICUT team and IAS for giving this opportunity. And my topic is on the revision ACL reconstruction. So, who needs revision surgery when the ACL fails? So, you have to consider many factors. You have to consider the age and activity level of the patients, and you have to consider really this patient is an athlete or non-athlete. Does he have a really rotational instability? So that is what most important, because this revisions, any revision surgery is a very big surgery, and you have to make sure that this patient really need this surgery. And many patients I have seen comes back with, even though there is an ACL tear, they will not have rotational instability. And what they say, the instability is like falling forward. That is because of the quadriceps weakness. If your primary surgery, after your primary surgery, if you don't rehabilitate them well, they'll have a lot of quadriceps weakness, and these patients might have not done any proper exercises at all. So they will say that, no, when I walk and come down in the staircases, I have instability. So that is because of purely quadriceps weakness. Even if the ACL doesn't work, I won't operate that patient. I do rehabilitate. Unless you have a rotational instability, don't come back for a surgery. So because we have to know that success of surgery of revision ACL is 3 to 4 times high failure rate than the primary ACL reconstruction, and only 40% can go back to the sports, considering the primary is around 60 to 70%. So when you have an instability alone, that is the only ideal indications, and that is the only just revision ACL, that is fine. When the patient presents you with the only pain but MRI shows ACL tear, then you have to be very, very careful that these patients, if you do only ACL reconstruction, they'll have an unsatisfactory outcome. So make sure that this patient doesn't have any infection, any chondral damage, or missed out meniscal injuries, or arthrofibrosis, or the patient had already developed early osteoarthritis. So that factors you have to consider. That patient has got if they have only pain. If they have pain and instability, of course, along with the ACL, you have to consider all other missed injuries like a meniscus, collateral injuries, or if it's an osteoarthritis with varus deformity, it has to be addressed with the osteotomy with the revision ACL reconstruction. So please go through the history. That is the most important when they come back for ACL. So we know that the common factor, the important cause for the failure is the technical, almost around 60% in the literature. Of course, other causes are again trauma or biological incorporation failure. And infection and stiffness is the other factors which patient come for a revision ACL. And the patients can have a missed root tear and ramp tears, which we talk more about, because if you don't do the ramp, if you don't do a root repair, and they can have a more anterior subluxation, rotator subluxation can result in failure. So it's very, very important that this has to be addressed when you do a revision reconstruction. When you plan for a management of the revision ACL, the re-revisions are around 8%. So you have to be very, very careful, and you can plan with a single stage or 2 stage, depends upon your individual experience. When you have, as already talked about, that history is very, very important. The same way, that same history, what you asked has to be applied for examination. So make sure that you take an alignment X-ray, patient walks, make the patient walk. So when the patient lies down, you may not appreciate the varus deformity. It applies to any orthopedic failure, any lower limb problem. You should make the patient walk and make sure that he doesn't have any varus or valgus deformity. As you always examine for your collateral ligament injury, whether it's a medial sided or a lateral sided injuries, and look for the varus valgus stress test. And of course, when the patient has got any rotatory instability, may require an anterolateral ligament reconstruction. Apart from standard X-rays, we'll show you the type of metal wear which you used and position of the pre-existing tunnels, tunnel widening and bone loss. These are very important for you to prepare for your revision surgery. So that apart from routine X-ray, and you have to take an alignment X-ray, both the coronal and the sagittal suction, because you know that if the patient has got a varus deformity, you have to address that osteotomy, and you have to do a revision ACL reconstruction. So this has to be very, very careful. And also the tunnel diameters you have to measure by X-ray. Of course, we are doing a CT scan also to do that. Now the last few years, we are also concentrating on the slope. If the patient's slope is reverse, then if the patient has got a more posterior slope, it will be a problem. So you have to reduce the slope if you want to do a revision surgery when the ACL failed. Of course, CT is mandatory because that gives more precise, accurate measurements for your tunnel measurements, so that you can decide whether you want to do on a single stage or a 2 stage. Up to 13, 14 mm you can manage with a single stage. If it goes more than 14 mm, I think it's very difficult. Then better fill the graft and come back. So when you want to deal with this case, then revision ACL, there are 3 scenarios. One is the well-positioned tunnels. Another is the slightly mal-positioned tunnels. And the third scenario is completely significantly mal-positioned tunnels. So we can go by one. So, and also the MRI is also very important, that will give you the clue about the meniscus and chondral damage in the revision scenario. So MRI is a mandatory that will give you this thing. So when the first scenario, you take the first scenario, if it is in a well-positioned tunnel, okay, you should use the same tunnel because you have no other option. If the tunnel diameter is 14 mm or 14 mm, you can still manage with a single tunnel. You can use a bigger size graft. You can use a bigger size interference screws to make and compensate that enlarged tunnels. When you have a well-positioned tunnel like this, though, you gradually enlarge it and makes it fixation. when you have the tibial tunnel issues, when I come to that single stage, usually sometimes the graft had to be too anterior, or there could be a loss of extension for particular patients. You have to make sure that you clear that whole anterior joint space to get that extension back. That is very, very important. When you do a single stage, again, problem on the tibial side, as I said, that you can make a divergent tunnels, or you can use an allograft or bioscrew as a filler on our stacked interference screws, or we can make in a lateral entry that will give you more this thing. So this is the tibial side entry. So you do a gradual removal, because femur you can escape with making an adjacent tunnels, divergence tunnels are completely different tunnel. But the tibial side, most often it collides and comes back to your original entry point only. It cannot change that. So here you have to make sure that you make a completely remove all the soft tissues. You can do a microfracture. You can make a more biology as much as possible. Use the scoops. So that will give you the and also make sure that you don't dream too much on the tibial side, because when you do all use the scoop and the other instruments, that already will make the tunnel bigger. So up to 12 size graft can be used on the tibial side. So that will give the advantage of using the like when I use, most of the cases, if you see, I will use the patellar tendon graft. The advantage of using my patellar tendon graft is that both sides I can use the bigger size, 11 size in the femoral side. I can use even 12 size in the tibial side. So that gives an advantage for me to do it in a single stage. The other tricky point which we can use is the lateral entry. If you think that your tibial tunnel is so big to do it in a single stage, you can make it a lateral entry point. The only problem with the lateral entry point is that the graft delivering, because you are going in another direction, it goes and hits the femoral condyle and the PCL. So you have to be carefully deliver, especially if you are using a peroneus longus or a quadriceps with a soft tissue graft, it is fine. But if you are using a PTB graft, then it will be a problem. But you can get a new virgin tunnel. So that is the advantage of using the lateral entry point. So the delivery of the graft is very important. So you don't use the large size at the femoral side. You can take 1.5 to 1.8 size and use the probes gently to push the graft from the medial to the lateral side. So it is possible to do that. So don't use the larger size graft. This is a lateral entry. So it's possible that you can deliver the graft through the lateral entry point. So that gives a more advantage. Regarding the fixation, you can use the femoral screw, metal screw or the bioscrew. If you are using the bioscrew, then you have to use the tap. Make sure that you are using a tap, because you are dealing with the bone to bone if you are using a bony fixation. But if you are using a soft tissue fixation, then you can use the bioscrew. But I prefer metal screw when I use the patellar tendon graft, because both sides you have the bone. And as I said, that when you make sure that you don't need to remove all the implant which was existing before, because if you are using a different method, I don't need to go and remove the old endo button or the other screws which you don't require. When you do a stage revision, when it's more than 15 mm, I think it's difficult. So better to do with some filled graft, and you can come back and do it in a second stage as a single primary ACL reconstruction. As I already said, that you don't need to remove all the implants, and if you are doing a revision, then come back after 3 to 6 months of filling the graft, then make sure that complete incorporation has taken place and do a revision ACL reconstruction. When there is a slightly malpositioned tunnel, that is the second scenario, you can make a different tunnel. So you can make a vertical tunnel, you can do a more flexion, so that will give you different tunnel. You can entry point could be, maybe you can overlap, but you can get at least another 2 to 2.5 centimeter virgin tunnel. So the divergent tunnels are very helpful if there is a slightly malpositioned tunnel. So this is how I make you can see my entry point is just go above that old old tunnel. Then you can make a slightly vertical tunnel. You can see that the entry point, you have some overlap here, but you can see that most of my tunnels is virgin tunnel. So still it's the slightly malpositioned tunnel. We can make a divergent tunnel. It's another option to do a revision reconstruction in a single stage. So here the same case which I done a PTP. Here I used a bioscrew because patient wanted only the bioscrew. So that is the revision malposition tunnels. When it's a completely different scenario, then this is the most technical failure which will happen. So no, in a young surgeon, if you are doing a ACL, please don't do this mistake, because you see the tunnel. Where is the tunnel? So this is the fresh tunnel which I made it. Here, this is what the original, the primary surgeon had done the tunnel. So this is what highest technical failure for the ACL. So in this scenario, it is easy for me to do a revision ACL reconstruction, because you are doing like a simple ACL. You make a virgin tunnel in the correct anatomical position and do the ACL technique. As I already told, tibial side, you can make all the tricks which you can make it before. What graft to use in revision? Because I said that PTB has got a lot of advantages, but many people now prefer quadriceps also because they have a bigger size graft. You can use the peroneus longus also. If the tunnel is not too big, you can use the peroneus longus. But if the tunnel is becoming bigger and bigger, I would suggest to do a bone plug so that you can get a bigger size graft. As already said, fixation, you can use an interference screw or any even the augmentation with your suspensory fixation is fine. But rehabilitation goes slowly because it's already revision surgery. You know that the chance of failure is very high. So accelerated rehabilitation is not possible. So go with slow rehabilitation. Additional procedures, of course, yes, because we know that extraarticular tenodesis is helpful, especially when there is a rotatory instability. Nothing wrong in adding in another procedure. Whenever you do a revision, I always add now with the ALL procedures. So because even the primary situations, it supports. Take home message, all ACL failures do not need revision ACL reconstruction. That is the statement which you have to take it in your mind. So the patient differentiate the pain and instability when they come back. So put up more leading questions to the patients, really what he is coming for. And pre-op planning is mandatory. And completely malpositioned tunnels, you can do a just single stage. Partially malpositioned, you can do a divergent tunnel. Still, you can make a single stage. But well expanded tunnel, then it better do a two-stage procedures. Thank you very much.
Thank you, sir. Any questions? Since sir is going for a live surgery, he can take questions now.
Yes, sir.
On the femoral side, and outside in zig is also very useful when you do a revision scenario.
Correct.
Because then you get a different trajectory to actually hit in. Your inside point can be the same.
Absolutely. That's an additional, you can use it very easily. Because you can keep it in a different position, so the tunnel automatically goes in a different direction. So that is an advantage of using an outside in jig. Yes, please.
If you are doing two-stage, how long is the second stage? I mean, how do you determine when you are doing
At least 6 months. 6 months, because sometimes the graft doesn't incorporate. You know, like you see a lot of studies.
Yeah.
In the incorporation of the graft is also a problem. So you have to wait for at least 6 months.
You take a
do
CT
the
again?
CT scan.
Yeah, CT is repeated again?
Yeah, CT has to be done after 6 months. Make sure that the graft is incorporated.
Okay.
If it is not incorporated again, you cannot do anything further. After at least you can plan better.
Okay, thanks.
Sundaran sir, one final question. We have not talked much about infection in ACL. So if the revision is an infection, would you routinely take swabs or cultures? Because all the current papers are coming up on the C acnes in late failures in ACLs. So would you, how would you deal with revision due to infection? Like 2-stage usually bone grafting, or do you go for a 3-stage surgery?
So far I have done only 2 cases in post-infection because I deliberately not covered because only the time. Second thing is, as I felt that most of the infected patients, when they come back for the revision ACL, they get the stiffness. You know, they develop arthrofibrosis at some extent because when they come to for the debridement, when you take the graft, it will be 2 to 3 months time. You know, the people give the antibiotic and by the time they develop stiffness. So the primary aim when I do an infected ACL is to remove all the implant, get back the movements. Even though they get back the movements, still the knee is not as like on the opposite side. So these patients very rarely come back with the rotatory instability unless they are a very primary athlete. And I tell them, so if you're a primary athlete and if you want to go back to the same level of sports again, then I do the revision ACL. That's why the revision ACL in the infected situations are very, very few in my practice. Of course, if I had to do it again, then I do an aspiration, send for a culture, maybe leave it for at least 6 months time. Then you plan for single stage, 2-stage, it depends upon the tunnel diameter. Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Now I invite Dr. IPS Oberoi for his talk on lateral extraarticular tenodesis, indication and technique.
So, yeah. Good morning, friends. Sundar gave a passing reference regarding lateral extraarticular tenodesis in an ACL deficient knee. In this, my presentation, I'm going to talk about LET, which is an important surgical technique which we are commonly doing now in our ACL deficient knees. so as to improve our results. When you have an ACL deficiency, pivot shift test is one of the tests which we commonly do to diagnose the ACL deficiency and also to see the severity of ACL deficiency. Because ACL deficiency does not even cause AP translation, it actually causes pivoting and rotatory translation as well. The pivot shift test which we commonly do is usually graded as a normal, which is a normal, there is no pivot, or a grade 1 which is actually like a small glide, a grade 2 which is a clunk, and grade 3 which is a very gross pivot shift which often happens. We commonly see grade 3 in a high-end athletes, and these are in patients where what is called as explosive pivot shift, which actually bothers us the most. There are a lot of articles which actually tell us why there is a high grade pivot shift phenomenon which happens. The articles actually clearly define that there is anterolateral structures which are important. These essentially include the lateral meniscus, the anterolateral capsule, and the IT bands, and these actually contribute to high grade of pivot shift which is happening in these patients. So whenever you see a patient which has got an ACL deficiency with an explosive pivot, these are 5 important things which have to be in your mind. Number 1 is associated meniscus tears. Usually it is the medial or the lateral posterior horn meniscus injury which stops the door stopper mechanism to happen, and these patients end up with high grade pivot shift result. Ramp lesions are hidden lesions which are also important lesions. Very rarely some patients have posterior tibial slope more than 12 degrees which contribute to pivot shift phenomenon. But most important reasons are anterolateral capsular injuries and anterolateral ligament injuries. All of these anterolateral structures are important, and when the knee opens anterolaterally, it actually pivots quite a lot. And when you put a scope in a massively pivoting knee, you would always find an anterolateral opening up, which is always seen because of deficiency of the structures in the anterolateral component. So what is LET? LET is lateral extraarticular tenodesis. It's a very old surgery which was essentially designed as a standalone procedure when arthroscopy was not there. But what we have realized that while doing an arthroscopic ACL reconstruction, if you add on an LET, it actually reduces the anterolateral rotatory instability and the rotatory laxity, thus protects the anterior cruciate ligament graft and helps the patient recover faster. When to add an LET in an ACL? I think most common phenomenon which we commonly see is a younger individual which are usually less than 20. These are guys which are in pivoting sports or high demand athletes, and they have a massive explosive pivot shift. I think this is the group which actually needs, in addition to an ACL, an LET. Then when you see an X-ray and you are able to see either a second fracture or a lateral femoral notch sign on a preoperative imaging, again these are the patients where LET should be added. Revision ACL, as rightly told by Dr. Sundarajan, you should add on a LET because it's going to protect the revised ACL graft. Chronic ACL tears, especially which is more than an year, often have ligamentous laxity on the anterolateral structures. They are also beneficial by adding an LET. And then there are female patients which have got gross hyperextensions. You have to protect the graft by adding an LET. So these are 5 cases, scenarios where we add LET in almost all our ACL reconstructions. Conventionally, there are numerous types of LET which has been described, but Lemaire's and modified Lemaire's have stood to time. These are simple steps of a modified Lemaire's procedure. So that's a Gerdy's tubercle here, that's a lateral epicondyle, that's a fibular head. You give a oblique incision which is centralized onto the lateral joint and take a band of an iliotibia. So iliotibial band, but when you take a band of this iliotibial crest, don't remove the proximal and the distal capillary fibers. They are important rotatory stabilizers. We just take a band of the ITB, stitch it, and then this ITB is actually brought behind and below the lateral collateral ligament and the fibular collateral ligament and attached. It actually does a tenodesis effect in these patients. We'll just try and run a video to show how exactly an LET is done. So that's the knee position you are seeing from the lateral side. We are marking the structures. That's the Gerdy's tubercle, marking the fibular head here. That's the fibular epicondylar area. That's the fibular collateral ligament or the lateral collateral ligament. Our incision is an oblique incision which is based at the center of the lateral collateral ligament. Incision is around between 5 to 6 centimeters. It's a long incision which goes down. You have to go right till the Gerdy's tubercle and expose the skin and subcutaneous tissue. Once you have done that, you expose the iliotibial band, and then ITB is harvested. The diameter of ITB is around 7 to 8 millimeters in diameter, and as it goes up, the length is around 7 centimeters or so. So from the Gerdy's tubercle, you retain the attachment, go up and harvest the ITB without actually removing these Kaplan fibers, which I told you are important rotatory stabilizers. Once you've taken the ITB band up, you can disconnect it here and take up switching baseball stitches onto the ITB. So you get a membrane or a strip of ITB which is there. The next step is dissecting under the lateral collateral ligament with help of a 90-degree artery. You do a dissection under the lateral collateral ligament, create a space between it so that this ITB is taken under the lateral collateral ligament up. So this is going to give a tenodesis effect to the anterolateral structures. So this is stitched, you size your ITB graft like this, you stitch the edges of the ITB graft, and you already made a space beneath the fibular collateral ligament. Once you have done that ITB stitches, you take a diameter because it's ultimately going to be fixed with a screw. So you should know the diameter of the graft. So once that stitching is done, you pass with the graft sizer and see it's around 6, usually between 5.5 and 6. That's the diameter. The length is around 7 centimeters or so. And now with a shuttling suture, you have to actually pass this shuttling suture, the graft under the, so make a space between the fibular collateral ligament, pass under the FCL and go towards the lateral epicondyle. So graft is then taken, passed under the FCL posteriorly from the front like this. You bring it behind the FCL and then take it up and attach it towards the lateral, close to the lateral epicondyle. So this ITB is going to give you an tenodesis effect onto the lateral side and help us in stabilizing the anterolateral structure so as to avoid severe or massive pivoting. The fixation here can be done by a screw. A femoral tunnel is made under lateral epicondyle, which is going from the lateral side to the medial side, and the graft is passed from the lateral to the medial, giving a tenodesis effect and fixing it with a screw here. So that's the closure which is seen after the LAT procedure. It usually takes between 10 to 15 minutes addition after doing an ACL reconstruction surgery. There are a lot of articles, some coming from the masters themselves. That's an article which is a robotic study which has been done by Robert Labrard, which actually shows that modified Lemayere's LET or an ALL actually improves reduces the tibial forces onto the knee in all degrees of flexion, thus protects this graft from failure. There are articles which are biomechanical articles which are coming from Robert Gatgood, and these articles actually shows that ALL reconstruction or modified Lemayere's LET procedures improves the knee stability after anterior cruciate ligament reconstruction. That's another article which is a long-term, around 2-year study where shows LET reduces the failure of hamstring autografts in ACL reconstruction. So whenever you have patients which have got a high degree pivot shift, and it's important, this patient which you are doing revisions and in patients which have got hyperextension, you can either add an LET or an ALL because these both procedures actually increase the efficacy and help in protecting your ACL graft from failures. Thank you very much.
Thank you, sir. Next, I invite Dr. Prince Shahnawaz Khan for his talk on pediatric ACL unique challenges.
Respected gurus and my dear friends, so my talk is on pediatric ACL. I think that the only thing I remember about pediatric orthopedics is what Dr. Benjamin Joseph told me one day. So that was a grand rounds day, and the child was not there on the bed, only the mother was there. So he asked me, Prince, do you really like pediatric orthopedics or my pediatric patient's mother? That was the only thing I remember about pediatric orthopedics nowadays. Okay, jokes apart, we'll start with the session. So this was what we have learned during our residency. The pediatric ligaments are stronger than bone, and expected injury will take place at the tibial spine or the physis. Because the growth plate is weak link in the knee, the traumatic complete mid-substance tears of the ACL are extremely rare. So this was a standard teaching. But look at the literature. So there is a more than 100% increase in youth soccer injuries over the last 14 years, and there is a 400% increase in youth ACL tears over the past decade. And more importantly, more than 70% are non-contact injuries, the ACL tears. So why this happens? Because we are emphasizing more on skill development rather than fitness. The core stability, the neuromuscular training should take precedence over skill development. Otherwise, the more and more ACL injuries are doomed to happen. So ACL injuries and subsequent reconstructions are rapidly increasing in athletes, and due to sports specialization as well as increasing injury recognition. More and more MRIs are being taken. More and more pediatric patients after injury are taken into the specialist care. So the function, we all know about the functions. And anatomy, everything is same. You have an ACL, 2 bundles, you have a PCL, meniscus, everything is the same in the knee as well as adults. But only thing is, the different is, what you see here is the physis. That is the only different thing in children compared to the adult people. So physis, more than 65% of the lower extremities given by the distal femur and proximal tibia physis. In contrast to the upper limb, where the more growth occurs at the proximal humerus and the distal radius. That is the reason tumors are more common in the upper limb, in the proximal humerus and distal radius, but in the lower limb, tumors are more common around the knee joint. So we all are scared about violation of the physis. When you drill holes to the tibia and femur, it can result in a ligament discrepancy, angular deformity, and a recurvatant deformity. So the clinical presentation, the child usually presents with an acute hemarthrosis. And this is very interesting. Pre-adolescence, the ACL injuries are 47, but in the adolescent population, it's more common. The ACL injuries are more common than pre-adolescence. So physical examination, the pivot shift test is almost impossible to perform in a child in an OPD basis. And the Lachman test is very effective. It's best for ruling out an ACL rupture. Anterior troyer is not that good because even a meniscal tear can cause a negative anterior troyer. So the growth spurt initiation, the 12.5 years in boys and a 10.5 years in females, and peak growth velocity occurs 1 year after growth spurt initiation, and usually it precedes a menarche in girls. So assessment of maturity, and you should know that not all 12-year-old are the same. Some 12-year-old kids may look like an 8-year-old and vice versa. So the chronological age is not reliable. Physiological age is more important. Look in the X-ray for a physis, take an X-ray of the hand and wrist, and a Turner staging, clinical and radiologically is very important. And look for a menarche, whether growth spurt has appeared, and height of the patient. If the height of the patient is less than 10 centimeters than the patient, than the parent, that means he or she has not achieved maturity. So coming to the radiology, X-rays are mandatory, and that will help you to rule out a physeal fracture, epiphyseal injuries, tibial spine avulsions and tumors. MRI is an absolute must, and that will help you to evaluate a meniscus and other soft tissue injuries and associated injuries. So you can see the X-ray, you can see the tibial avulsion, and the treatment is completely different than an ACL injury. You can fix it arthroscopically. And sometimes the hemarthrosis may be a result of a physeal fracture, and you have to rule out a vascular injury. And coming to the non-surgical treatment, it's postponing ACL reconstruction until skeletal maturity. Functional bracing, activity modification, and physical therapy are described. But I can tell you that the patient will avoid activities for 2 weeks until the swelling subsides and the pain free, then definitely the child will start running and pivoting activities. So what's the natural history of a non-operative treatment? So equally they are bad. Unaddressed knee instability is associated with additional meniscal and condyle injuries as early as 12 weeks. Bracing alone does not prevent further injury. Delayed ACL reconstruction and return to activities associated with considerable psychological effect both for the patient and for the family. And instability, unaddressed instability can result in early arthritis. There are some specific indications for a non-surgical treatment. The child should be less than 14 years, and it should be an incomplete ACL tear on a MRI. And more importantly, there should not be any instability on physical examination. So the surgical dilemma is between to balance the risk of growth disturbance versus anatomical reconstruction. So another important thing is never use an allograft in a pediatric patient, because patient in the age group of 10 to 19 years had a highest percentage of graft failures with allograft. The odds of graft rupture with an allograft reconstruction are 4 times higher than those of an autograft reconstruction in this pediatric age patients. So what are the surgical options? We can have an extraarticular reconstruction. There are fascial sparing methods, and there's a transfascial reconstruction, whether it's a partial or a complete. So we have an algorithm based on the age. So the number 1, the skeletal immature pre-adolescent patients are treated with the iliotibial band reconstruction. The pre-adolescents, the Turner 3 and 4, they are, if they have adequate epiphyseal bone stock, they can be treated with the all epiphyseal reconstruction. This is important. They should have adequate epiphyseal bone stock. And patient approaching who have reached skeletal maturity are good candidates for a transepiphyseal ACL reconstruction. So coming to the iliotibial band reconstruction, they are recommended in a Turner stage 1 and 2. Basically, it's just like sir told about Lemmer procedure. It's an ITB autograft. The distal part is attached to the Gerdy's tubercle. It is taken around the posterolateral part of the femoral condyle, and it is sutured to the periosteum here, and it is taken into the joint, and it is taken below the intermeniscal ligament, and it is attached to the periosteum distal to the tibial physis. So it's a fascial sparing. It's a combined intra and extraarticular procedure, but it's a non-anatomic procedure. It's a temporizing measure till skeletal maturity. So once the patient attains a skeletal maturity, you can go for a normal anatomical ACL reconstruction, because the ITB graft will stretch over a period of time. So this is what we all are interested in, the all epiphyseal tunnels and fixation. It's indicated in Turner stage 3 or 4. It's an anatomic technique. But there are some prerequisites. The pre-adolescents with a sufficient epiphyseal bone stock. So an MRI is a mandatory. Pre-op MRI for estimating femoral tunnel length and diameter. You should have at least an 8 millimeter diameter tunnel, and that should not encroach upon the femoral physis proximally and on the cartilage cap distally. So you should get an 8 millimeter space for putting your femoral tunnel. So it's basically an outside-in procedure. So there are some technical tips. These are the surface marking. This is the fibular head. This is the iliotibial band. This is the lateral epicondyle of the distal femur, and this is a popliteus tendon. So draw a line proximally along the shaft of the femur from the lateral epicondyle, and another line perpendicular to that. So this area, this is not safe. This is the danger area. So when you put your outside-in jig, you should not put your jig around this area. That should be distal to your lateral epicondyle. So if you put it here and drill using an outside-in jig, you are going to violate the physis. So your jig should always be distal to the lateral epicondyle. The femoral tunnel is drilled horizontally and obliquely in the distal femoral epiphysis. So intra-op imaging is mandatory. You can see the intraoperative images. And the tibial tunnel is above the growth plate. But this was described by Anderson. In his original technique, he used a cortical button here, and distally, instead of the cortical button, he used a post-type fixation distal to the physis. But the issue is that even though you drill only through the epiphysis, you avoid the physis. But this, when you use a post here distal to the physis, this can act as a tether, or it can give a tension band effect, and it can give result in a recurvating deformity. So it's better to use a cortical fixation on both sides, proximal to the tibial physis and distal to the femoral physis. So there are hybrid techniques. Adolescents with an open femoral physis and a tibial physis that is closing are good candidates. Epiphyseal, always in the femur, it's always the epiphyseal femoral tunnels. And the tibia, you can breach the physis because they are central plates, transphyseal tibial tunnels with the fixation distal to the tibial plate. So why you avoid the femoral physis? Because the femoral physis provides more longitudinal growth, and the transphyseal femoral tunnel has a more peripheral location. So when you place a vertical tunnel, it's going to affect your physis very little compared to the femoral physis. So the transphyseal technique, adolescents who are near or have reached skeletal maturity are a good candidates for a transphyseal technique, and hardware should not be placed at the level of the physis. Always soft tissue grafts, so don't use the screws when you are using a transfacial techniques. And these are some important take-home points. The central facial drilling is associated with the lower risk of growth arrest compared with the peripheral drilling. Vertical tunnels minimize facial volume injured, and drilling of less than 5 to 7% of the facies is associated with the minimal risk of growth disturbance. So again, coming back to the question, why ACL tears in children are different? We always think that the facies could be affected. It can result in a growth abnormalities, but it is very rare in a properly performed reconstruction. The facial arrest and angular deformities and limb length discrepancies are very rare in a properly performed reconstruction. But more important is the retear rate of at least 25% in patients under 14. So the retear rates are almost 1/4, more than 25%. So this is more distressing than injuring your tibial facies. So there is a study. They have divided into 3 groups. And the group 2 athletes has a mean age group of 14, had a significantly higher revision ACL, around 20% compared to the other 2 groups. Why? Because this age group is associated with puberty. So there are a lot of hormonal influences, a lot of neuromuscular changes are happening. So this is the reason why around this group, the children around 14 years of age, they are highly susceptible for a retear rates up to 25%. So another, this is the latest article, around 1,400 ACL reconstruction, and this shows only 8.7% retear rates, but most all of them were associated with re-revision surgery. But see, there is only 4.4% of a growth disturbance, and less than 25% needed a revision surgery for a facial growth disturbance. So definitely the retear, they are more challenging, and preventing retear is more important, and best treatment is not to retear. So what are the risk factors? You can see the landing pattern. There is an adducted hip, and there is a quads dominance, and there you can see a valgus here, dynamic valgus here, and you can see an angle eversion and a pronation. So there is a discrepancy. There's a quads dominance when the hamstrings are. There's a discrepancy between a quadriceps and your hamstrings. There are high chance of having a ACL retear, and the less core strength is also associated with the higher retear rates. And definitely there are high risk in females because of a high Q angle and a laxity. So injury prevention is more important. Thank you.
Thank you, sir, for the presentation. Now, next is our panel discussion. Thank you, chairpersons, Dr. Ajit, Dr. Sandeep. Next is a panel discussion by Dr. Shanawaz. I request the panelists, Dr. Schiller T. Jose, Dr. IPS O'Brien,
A very good morning. Thank you, IAS, for bringing this opportunity to CALICUT, and Maitra team, Samir, Ghafoor, for this opportunity. So we have already covered almost all points in ACL. So I will put some simple cases, and we will discuss some common issues and what we have to do it correctly. We have got an experts here. Tons of cases has been done, ACLs has been done by the panelists here. So greetings from the 2 institutions where I built up my career, and I am an alumni of CALICUT Medical College too. And thanks to Gopi sir for making me up this year, and Rajesh sir also here. So coming to the case number 1, it's a 28-year-old male, a twisting injury left knee during soccer on artificial turf. Nowadays, we have got a lot of cases because a lot of players are there playing in the turf without proper precautions. So a lot of ACL injuries has been there. It's a non-contact type of injury. His boot stuck in the grass, artificial turf. And he comes to us 3-week post-injury. And on clinical evaluation, a latchman grade 2 with a pivot shift to grade 1. That's on a glide. And he wishes to stay active. And this is the background. And with this clinical scenario, everybody will be knowing that it's an acute ACL tear without any associated varus, valgus, structure, everything negative. So an acute isolated ACL injury, let me ask the panel, if the patients come to you on day 1, how will you manage it? It's an acute injury, acute knee injury. Probably I think Sibin will take that question because he will be seeing as a medical college professor, he will duty in the ED and all. And day 1, a patient come to you. How will you take it?
If it's a day 1 injury and clinically it looks like only ACL injury, I'll just give a temporary immobilization in the form of a brace with some analgesic. And it's not a cast. Basically, you immobilize with a brace so that patient can have some range of movement gradually.
Yeah, that's a valid point. So you don't strictly immobilize the patient. Ideally, you should follow the protocol of rest, ice, and some gentle splinting. And once the pain is relieved, then you have to mobilize the patient as early as possible. Will you aspirate the...
If there is a tense hematoma and so much painful, there is no harm in aspirating.
Okay.
Not a routine thing.
Not a routine to aspirate the... Yes. That is also another point because everybody will be keen to put a needle and drain the blood from the joint and put a compression bandage or a cylinder slab and make the patient rest for about 2 weeks, and it will misfire the quadriceps, and once the quadriceps is lost, it will be disastrous.
Start on static quadriceps.
Yeah.
That's
So ideally you will start on immediately after rest, ice, splinting and analgesics, you will start on quadriceps exercises. So any difference of opinion, sir?
No, how about the investigations? Like you want an X-ray or MRI or something?
Yeah, I am just, when the patient comes to you on the day 1 in the ED.
Tense hematoma must also be aspirated. These patients might have avulsion injuries, they could have capsular injuries, they could have bone injuries, and sometimes when you aspirate, you also find fat globules coming in. So aspiration sometimes is important.
If you're aspirating, you should look definitely for the fat globules. If there is fat globules, then you have to think of fractures. So probably it will be an avulsion fracture or some intercondylar fractures, crack fractures.
The aspiration has got a role in a pediatric ACL injuries.
Yeah.
It's chondrotoxic. The hematoma, what we learn is the hematoma, hemoglobin is chondrotoxic. So if there is a tense hematoma, it's better always to aspirate.
If a tense hematoma, always aspirate. So if a minimal hematoma or minimal fluid, never put needle inside. So coming to the radiological investigations, apart from the X-ray, what all investigations will you do and what all will the timings of your radiological investigations? I think this honest audience needs some clarification regarding the timing of your radiological investigations. So I will start from Shanavas.
I'll get an X-ray
Yeah,
done.
Prince Shanavas,
Yeah,
not me.
Yeah, I'll get an X-ray done, but definitely I will prescribe MRI.
MRI. At what time will you take the MRI IPS, sir?
MRI day 1. Why
Day
not?
1.
Why not? I mean, we have to see the meniscus injury. We have to see the ACL. These ACLs might be repairable as well. And there could be a meniscal injury which is repairable. And so we diagnose on day 1 as well.
So you will take a day 1 MRI. Schiller, sir, what's your opinion?
I totally
You have
agree
been
with
here for practicing scopy for more than 25 years. So what is your practice actually?
Thanks for advertising me like that. Okay. Anyway,
when we are students in CALICUT Medical College as UGs, he was doing scopy here.
I need to correct you. It's almost 30 years, not 25. Okay.
Then more than 25 years that I have mentioned. More than 25 years.
I totally agree with Dr. IPS Oberoi because there are some rare instances where like a meniscus could be dislocated and you may have to, even if it's an acute injury and you think it's only ACL, it may be an emergency. You might have to take him in. So,
Sandeep, any difference of opinion regarding that?
No, it has to be done early for the.
Okay. So if you have a chance to take an MRI on day 1, ideally you have to look for the MRI because you have to look for any meniscus, any locked meniscus or something like that. And for chondral injuries, if you have some fluid inside the joint, it will act as a contrast and will give some vector pictures. And what is the problem with the day 1 MRI? What we usually see is that if we rely completely upon the radiologist report, there will be sprain of grade 1 sprain of lateral side, grade 1 sprain of medial side, popliteal sprain, PCL sprain, everything will be sprained. So how will you differentiate between, what is your take on that? So if you take a day one MRI, that's usually a confusion. I think everybody will be having that confusion. The reports will be coming like that. Even for a minor injury.
Yeah, I totally agree with you that the day one MRI may not have that much of clarity as an MRI that you take on a knee that is more silent and calm down after a few weeks rest. But still, it's worth taking the day one MRI to rule out certain situations where you might need an immediate surgery. So if you're not happy with the day one MRI, there's no harm in repeating the MRI later on.
So the point I want to highlight here is that you should not completely trust the MRI with some minor injuries. So you will be seeing bruises all around. Like in this picture, you can see bony bruises in the femoral condyle, lateral femoral condyle, and also in the medial aspect, medial tibial condyle and all.
These bruises are indicative of an ACL injury.
Yeah.
The grade 1 sprain, even they report also you are treating by a rise. Okay. So
Another thing is that this point, you should have a proper clinical evaluation. Even if there is MRI tells that there is lateral side injury, medial side injury, you should have a proper evaluation, proper varus, valgus test and rotary complex, everything you have to look for. And your clinical judgment is much more important than the MRI result, especially in case of acute setting. That is the one point I want to highlight. Are you agreeing with me?
No, I just want to highlight what is the problem if you take after 2 to 3 weeks once the acute phase is over? So I think Dr. IPS can.
So we were talking about a bucket handle tear. I mean, clinically, we are not very sure because these patients are in spasm. There is a bucket handle tear. Again, there could be avulsions. So there are certain indications which are helpful on day one itself to help us in identifying these lesions. I mean, again, as you rightly said, you have to actually collaborate with the clinical findings.
Yeah.
So you entirely don't depend upon it, but it just makes you wiser and you are able to operate early these patients rather than sending home and they never come back to you again.
And it could be a reduced knee dislocation, especially in older patients, female, around 40 years of age, fatty females, and you have to rule out a neurovascular injury.
So if facilities are available, acute day one MRI with proper clinical judgments. That is the point I want to highlight. So this is the 3 weeks old patient, what I was mentioning earlier. He came to me with this and this is his finding. He has got an acute ACL tear with some image signal changes here in the posterior aspect of the medial meniscus posterior horn. So what are the options? It's a 3 weeks, 28-year-old male, and acute ACL injury with a medial meniscus posterior horn tear, probably. Anybody for the conservative management? What are the Sandeep? What is your take in this case? It's a acute 3 weeks old. 3 weeks old.
Correct.
28-year-old.
So immediate is a very broad term. So the best appropriate operation would be immediate surgery, but not exactly day 2 or day 3. Anytime within first week to 10 days, I would choose surgery.
So if that patient come to you on day 1, you have an MRI on day 1 itself, and it shows that an acute ACL injury with medial meniscus posterior horn tear. Then will you proceed with immediate surgery on day 2? You will pause the patient for immediately on the day 2, or you will wait for some days, some weeks, or you go for surgery, or will you conserve and wait with some activity modification? 28-year-old male is the first episode only.
I would always like to wait.
How long you will wait, sir?
3 weeks.
3 weeks.
Or at least till his swelling is reduced and he's got a good range of movement and a fair enough of quadriceps power. Some patients, in spite of the severity of the injury, they don't have any swelling at all. They just walk around.
So you will wait for 3 weeks to get the knee, angry phase of the knee to be get down, and then you can have a proper visualization. And by the waiting period, what all things will you advise for that patient?
The first 1 week, definitely analgesics and pain modality treatments to reduce the swelling and his suffering. Then the next 2 weeks, I'd put him on quadriceps setting exercises, range of movement exercises. But if he's a patient who walks a lot, I'd rather protect his knee with brace.
Very good.
While he's walking.
Yeah. IPS, sir, any difference of opinion regarding this?
It apparently looks like a low velocity injury.
Yeah, low velocity injury.
Which you were telling is low velocity injury. as he rightly said, most of these patients are actually walking about.
Yeah.
They walk down to your OPD.
Yeah.
So no harm in actually operating them, asking them that you can be operated because they are usually silent knees and they are not aggressive. These low velocity injuries often have a femoral avulsions. So you can as well do an ACL repair in these patients.
Okay.
So don't delay it too much. Get a good quality MRI. Knee silent. Go ahead and operate these patients.
So you will be taking the patient immediately, taking a chance for ACL repair. Yes, very nice.
The MRI will give you the idea whether it's repairable.
Yeah, yeah.
That's the thing.
So, what is anybody conserve, do some activity modification, and wait for a second episode of twisting injury, and he coming back, something like that? Anybody in the panel?
No role for a constructive trial in a 27-year-old active male. Like
Yeah, that is the point I want to highlight. Many of the times, what we see is that such patients, consultants will tell that you go take rest, and you come back after a second episode of twisting injury. If you again have a giving way, you come back for surgery. So it is not advisable. The panel agree with that, I think.
It will result in a meniscal tear.
Yeah.
Buccal tear.
If you have a second episode of twisting injury, that will lead to a meniscal tear or a chondral damage, and that will be disastrous for him, and it can lead to osteoarthritis. So that is the point I want to highlight here. So prehab is the key to success, no doubt. So as Schiller sir rightly mentioned, there are certain burning points you have to be highlighted. You should normalize the range of movement, decrease the pain and inflammation, maintains the muscle strength, and improves balance and proprioception with these prehab exercises. And if you have a proper prehab, then there is a return to sports is very easy, and also the graft incorporation and the failure rates are very low.
That is always, this contusion will always be present.
That
It will
contusion,
bother
sir.
me if it is too much. But this one is a localized pivoting phenomenon which has happened. But if it is aggressive, yes, then it obviously has to be waiting.
If there is severe contusion on the tibial side, I think it will bother you, because if your tunnel goes in that way, if you put some screws, you have a plan for screws and all, then
These are indirect signs of an ACL injury. Okay, so the contusion on the femoral condyle and the anterolateral side of the tibia, there are indirect signs of an ACL tear. So if you see a contusion in this area, that means there is a high chance of ACL tear.
Okay.
So the bone marrow edema, that takes 4 to 6 weeks at least to get resolved.
So anyway, he came to me by 3 weeks. So his knees was not so angry, and his quadriceps, everything was of good power, and he has got a good range of movement. I have taken him to the OR, and this is the clinical findings. Examination under evaluation under anesthesia. So he has got the pivot shift was still grade 1 only, and he has got a latchman grade 2 to 3.
And that is why I think that the stump, you would find a good stump of ACL in this patient. You will really find a
Definitely.
good stump.
Yeah, let's see what we have. So this is the diagnostic. And you can see, as rightly IPS pointed out, there was a very nice stem, and it was trying to healing it to the roof, top of the roof. I think Gafur has mentioned that classification. It's type 2 actually. It's not Sherman type 2, Craig type 2. And his lateral meniscus is pretty normal. And on coming to the medial, posteromedial aspect, by doing the Gilchrist maneuver, by internally rotating the knee, you can go to the posteromedial portal. There you can see a peripheral tear of the posterior horn of medial meniscus. Now, what will be your plan of action? IPS, sir? This is the meniscal tear, you can see that.
So meniscal tear has to be repaired. It's a peripheral meniscal tear, and that is why he rightly said, don't wait for a second episode to happen. This would definitely have become a complete bucket handle now. This is repairable tear, you would go ahead and repair it. You are actually getting a very good medial opening now.
Yeah.
On clinical exam also and on arthroscopy also, so you don't need a pike crusting.
Actually, it was a post-pike crusted.
Post-pike crusting.
Yeah.
So you should have told us that. Because your medial opening was very good on clinical exam.
I have
Yeah.
like,
Yeah, so
if I suspect, what is my protocol is that if I suspect a medial meniscus posterior horn, especially the peripheral aspect tear, I will just have a pike crusting. What Banja has described, that magic point of Banja, the TU line, we will just put 1 or 2 18 gauge needle, 2 or 3 small nicks. It will open up bank like you can see all this area very clearly.
this is pretty unstable tear. It's a bucketing. It's actually started bucketing now. So
Yeah.
you should repair this.
Okay.
Regarding the ACL part, I told you, you will really find a good stump. Now it is up to your clinical exam whether you really want to repair that stump or augment it with a small graft as well.
So, Sibin, what is your take?
Yeah, agreed with Dr. IPS. Definitely, meniscus is in a red zone. You have to repair it. Otherwise, it will end up in a bucket handle. ACL, I think I will go for augmentation. Because,
Augmentation.
augmenting with the hamstring.
Okay. So there is no point in waiting. If you have got this type of meniscal tear, if you wait the patient further, what will happen is that he will come with a bucket handle tear, and you will also lose the chance for a proper repair of the meniscus.
Yeah, just highlighting that in majority of the times when the patient comes first time, the meniscus tears are repairable. They come later on, they become irreparable. And the main aim of a surgery is to preserve the meniscus and the cartilage there also.
So meniscus and cartilage is more important than ACL.
ACL, yeah.
We are doing ACL because we want to preserve the meniscus and cartilage.
Yeah.
So I think the options has been already discussed. So Sibin is for remnant preserving ACL and IPS is for repair. Anybody for conventional ACL, removing all that stumps and then we're doing the conventional ACL? Anybody in the panel? No, nowadays it's out. So this is the Sherman classification and treatment, as already Gafur has mentioned it, and very nicely published by Vanderlist and Diplis. This is type 1, type 2, type 3, type 4 and type 5 is the avulsion of the Sherman classification. So this comes into type 1 or type 2 like that. So in coming to the ACL graft options, we will discuss something regarding the ACL graft after this. So what will be the choice of the graft in this case?
So as I was telling, I'm going for the remnant preserving only hamstring or soft tissue grafts.
So we will you, if you're taking hamstrings, will you harvest CME or graceless in this case, or?
I will usually go with initially CME only, one graft, and see the diameter. Usually it should be adequate because it's a remnant preserving.
Panel, everybody will be agreeing. Any difference
Schiller,
of opinion regarding that? Schiller sir, will you go
No,
for PTB in this?
Yeah, why not? I can go for PTB, but the thing is, I wouldn't preserve the remnant. I will not preserve the remnant. If I'm taking hamstrings, I'll take both CME and gracillus and give me a decent ACL.
Sir, one point I want to clarify is that you told that you are not preserving the remnant. Whether you will shave off all the things of the ACL up to the tibial stem and clear it off, or you just keep it there and you put your drills and all, tunnels and all?
See, my problem with the remnant is, if you decide to do a remnant preservation, I don't think there is any existing classification or criteria which would guide you to tell you what size your graft should be, depending upon the quantity of or the quality of the remnant that you have inside the knee.
No, sir. I have shown that video.
Yeah, you showed me the video.
That ACL has been avulsed. It has been some attachments with the PCL. So if you're going in, what will you do? Will you shave off all that ACL substance and then put the tunnels, or will you keep it there and put your graft nearby the side and then come out?
No, yeah, the second option you said is same as remnant preservation, right?
Yeah, probably.
Okay. So what I told you is I wouldn't preserve the remnants, but if I had to preserve a little bit of tibial stump, yes, I would. Just a little bit enough, which would act like a sleeve around my graft, but I would not add all the tissue that you're seeing in the arthroscopy to my graft, the remnants of the ACL, because I don't know the quality of the stump or the remnant that you're seeing, the quality of the collagen. It's purely your judgment, your visual judgment, like what the remnant is worth and whether it's worth at all. And besides, you don't know the size of the ACL graft that you should match with the remnant. How do you match the quality and the size of the remnant with the size of the graft that you're going to put? Do you have any criteria for that?
No criteria.
Yeah. So that's my point.
You should not overstuff the intercondylar
Yes,
nerve.
I might, as I trust. See, if you've never had a remnant, your ACL has worked just fine. So why do you want to risk with an added remnant?
So my take is that it depends on my clinical examination. If your anterior is positive and your pivot is negative, that means your posterolateral bundle is intact, your anteromedial bundle is an issue. But if your pivot is positive and the Lachman is negative, the other way. So even if I'm going for a preservation surgery, I will take into these things into consideration.
So I will quickly finish off this case. The live is ready in the theater. After that, we will have some discussions regarding the next two cases. So the choice of the ACL graft, I think everybody will be agreeing with the soft tissue graft. And the length and diameter already we have discussed. If you are doing for a conventional, you should at least minimum 8 mm. Any doubt? So if you have any situations, if you don't get a minimum diameter of the graft, what are your bailout situations in that case?
So an whole insert procedure will help you. Whole insert, you can quadruple.
Sometimes if you, IPS sir as right morning you have shown that if you have a premature amputation of the graft where you push that stripper inside, sometimes it will happen. The graft will rupture in between if there is any vingula and all. So
there is a good incision. You can give a posterior medial incision here, and you can actually palpate and then do a graft harvest from this side also. So you can do that as well.
Some in short statured patients, if you don't get a proper sized anthropometry study shows that if the height of the patient is less than 5 feet, so there is a chance for hamstrings, you won't get adequate length and all.
Peroneus longus as a backup.
You can have peroneus longus as a backup.
As rightly said, you should be adequate in getting 2 grafts, minimum 2 grafts.
Okay. Any obese patients, do you have any choice of the graft? What is your first choice of graft in obese patient or hyperlaxities and all?
So in hyperlaxity, we add an LET always. In obese patient, depends upon morbid obesity or not. So in morbid obesity,
so BMI more than 30. So what will be your fine?
30 is still like borderline. More than 35, we will have to have an augment, which will possibly a synthetic augment.
Synthetic augment?
Yes.
Okay. Sandeep, what is the take?
Which will act as a door stopper effect.
Yes.
CQT. CQT is the choice. It's a very nice graft. So what is your take on this graft sockage in antibiotics? Anybody interested in that? Or I think morning IPS?
We regularly do.
I don't soak it, but I wrap it.
Yeah, wrapping like a normal sign. What is your choice of antibiotic? Gentamicin. Anybody using vancomycin?
No, you can use vancomycin. There's no harm. Just given
the cost is the main factor. So how will you prepare that solution sipping? Can you just enlighten the audience?
Dilute the vancomycin if you are using. I don't have the exact.
1 milligram per ml is the concentration of vancomycin that you have to use. If it is 500 milligram vial, you dilute it to up to 50 ml and then wrap it, soak it, goes and wrap it and keep it for 10 to 15 minutes. If you are using gentamicin, 0.8 milligram per ml, that is the concentration. So if you take an 80 milligram gentamicin ampule, dilute it to 80 ml, and then you can use it.
I never knew this was this much complicated. Seriously.
We just dilute it and soak it. I never knew this one.
Taking the antibiotic and you are not diluting it appropriately, and then there is no use. If you are taking 1 vial vancomycin and diluting it up to 100 ml, 1 milligram per ml for vancomycin and 0.8 milligram per ml for gentamicin. I usually use vancomycin.
Thank you.
So sometimes if the graft has been dropped on the floor, some rare instances. Anybody, probably Schiller sir, I might have some experience, I think, because 30 years.
How do you? Why? Don't destroy my practice.
One of my colleagues had it. Anybody on the panel or in the audience, anybody had that incident?
Take it from the opposite side.
Yeah, once, Sandeep has it. My colleague, in my hospital it had happened. My colleague had it. That's why I'm asking. So how will you bail out that situation? Will you throw that graft into basket or you take another one?
I would use the same graft. I'd use the same graft. Only thing, wash it thoroughly with saline.
Yeah, you can wash it. That's the point I want to highlight. Every theater will be having this 4% glutaraldehyde solution. And 4% glutaraldehyde means there are hand rub. Clorox hand rub is there, 4%. You can dilute it in normal saline, wash it for 90 seconds, and you have a proper vancomycin soakage for 10 to 15 minutes. Gobi sir is with the mic. I think you will be firing me.
That is too much risk we are going to take. Too much risk we are going to take.
Just falling down on the floor, immediately you are taking it.
No.
But incidents that happened, but there is no infection rate. So the panel is for you have to change the graft. Okay, the literature is like this only. I have searched for the literature and we had one experience also. That's why I go back to this.
But you cannot generalize it.
Okay,
You
we
cannot
can generalize it. So that is the point. So if you have followed the graft, you take another graft.
What will you do? What will you do if it is multi-ligament surgery? You have already taken from opposite side. So that was the case
Only
which-
I think before starting the case, you have to instruct your staff nurse that if it happens, I will take you to the table and take your graft. Then this will not
So it happened with me.
Sorry.
I only
We will move to the discussion later. The live is ready. I think Sundar is waiting in the theater. So panel, please, you can go down and we will have the
Thank you.
lives.
Thank you. Thank you, the panelist. So next is a live surgery. I invite Professor Sibin Surindran and IPS Oberoi to chair the session. Dr. Sibin. So this case is a multi-ligament injury. Surgeon is Sundarajan sir. The 54-year-old male patient, fuel pump employee, was brought to the hospital with a history of road traffic accident, hit by a two-wheeler. He sustained injury to the left knee, effusion presence, skin puckering on the medial side of the joint line. RM was restricted, no distal neurovascular deficits. So this is the clinical picture. There's a puckering of skin on the medial side of the knee. So this is the X-ray. And we took an MRI immediately, and you can see the MCL has been incarcerated into the joint. And there is a complete rupture of ACL as well as PCL. This is the clinical examination, the stress valgus and the anteroposterior laxity. This is a posterior sac. So we went ahead and repaired the MCL. The MCL was seen as a band. It was inside the joint, and it was repaired with a staple. And all suture anchors were used to repair the posteromedial structures. So he was immobilized in a long knee immobilizer with a PCL support. Gentle ROM exercises were started. And this is the present X-ray and the AP stability now. Over to you, Dr. Sundar sir.
Hello. Sundar sir, hello.
Hi, Sibin.
Yeah, Sibin sir, Dr. Sibin and Dr. IPS Oberoi sir.
Okay.
Yeah. So I think we have seen the case history. You can start on.
Yeah, so we are doing is the second stage. I think already you know the history.
Yeah.
Dislocation and reduced. Medial MCL was repaired because of the impingement. It is got inserted into the joint. So now we are doing it a second stage, and I think you can see the clinically the posterior anteroposterior movement. Can you see that? Yeah. So
how long after the?
This is 2 months after the surgery.
Okay.
I think it's good enough that they got the movement so early, but sometimes it is not easy to get back the full movements like this in 2 months' time. But this case, I think, good rehabilitation, and
okay.
And what happened that this patient also has got a still MCL was repaired, still has got a grade 2 laxity. Can you open it? So can you see the arthroscopic view?
No. Seeing
can you
out.
show the arthroscopic view, please?
Yeah, now we can see. Yeah.
You can see now?
Yeah, grade 2.
Okay, so that is the laxity still MCL. This is expected for any MCL repair. So you should never expect that once you do an MCL repair, it will be a rock solid. So always this expected. And the meniscus looks very good here. Cartilage looks good. For a 54 years old, he's not arthritic guy. So it's arthritic joint. It looks very nice. Good figure of 4.
Okay.
And coming to the lateral compartment, again, the meniscus looks okay for me. Already we did the probing. And that the middle horn and the anterior horn all looks fine. Okay?
Agreed, sir.
So we'll straight away go for the plan is to do a PCL and ACL reconstruction. and reassess the medial laxity. Most often, once you do the PCL reconstruction, I think our laxity should come down.
Yeah.
And if it necessary, then we can do a MCL reconstruction because it is opening on only 30 degrees flexion. Extension, it is stable. So if it requires, we do a superficial MCL reconstruction. We have taken the grafts already, peroneus longus from the same site for the PCL and prepared the graft. And also for the ACL, we took the opposite side hamstring graft. So we got the size of around 9 in the femur and 10 in the tibial side for the PCL by peroneals, and 8 in the femur and 9 in the tibial side for the ACL. That was 5-strand hamstring graft.
Just a question, Sundar, why not the hamstring from the same side?
Because we thought, because already the MCL was repaired, no? So probably there will be some scarring will be there.
Okay.
So, and also I thought I kept it reserved for, suppose if the patient requires MCL reconstruction.
Okay, you
I
would
will use the CME.
use that CME. Okay.
Yeah.
But there is no contraindication of taking the graft from this side.
No contraindication.
Yes,
No,
yes. I think
because
that's
of
the point important.
Yeah, because of
that there is-
scarring, the struggle,
I understand.
we thought of avoiding it. Otherwise, we might have taken from there.
Understand.
And we can see that is the complete ACL. It's completely avulsed from the femoral side, and the PCL is completely empty to the shaver. So we'll clear the joint space, clearing the stump. As I said that already, that I'm not especially for the multi-ligament injury, I don't do remnant preservation. By maybe ACL we can do, but for the multi-ligament injury in the time situations and the other factors, we can take out the grafts and do the straight away PCL and ACL reconstruction. Actually, when you demonstrate PCL and ACL reconstruction, always is easy to, not easy, it's technically challenging when the ACL is intact.
Yeah.
When ACL is not there, I think probably it will be easier for you to reach the posterior surface of the tibia.
Absolutely.
Because when the ACL is intact, you have to be very careful that you have to go between the PCL and ACL, between PCL and the medial tibial condyle. Then you have to create a path and take out the septum. Then we'll reach the posterior part. But here, because the PCL and ACL is torn, probably it's going to be a bit easier.
So when
But
the
anyway, lot of
PCL and
scarring
ACL
is
is
there.
torn,
Sorry?
often there are some associated injuries to the ligament of Humphrey and Westberg. So the posterior part of meniscus is sometimes very unstable.
Absolutely. In this case, we couldn't find any ligament of Humphrey is not there. But if it is there, always you should preserve that.
Yeah.
That is very, very important, because that is one of the important stabilizers of your posterior horn of the lateral meniscus.
Yes.
So whenever it is intact, we should be careful that you are preserving that. And especially when you have these both PCL and ACL, can you anterior? Yeah. So you can ask the assistant to give an anterior translation so that the space between the capsule and your posterior tibial surface, you get some space. And also, if you have a soft shaver, that is good to use.
Yeah.
And instead of the aggressive shaver, and make sure that your blade is facing all the time in the bony side, not in the capsule side. You can see this is the blade.
Yeah.
I'm trying to face towards the footprint of the PCL, and make sure that you don't turn. The chance
So
of getting
in such cases, when ACL and PCL is torn and you are actually able to see from the front itself the footprint of PCL.
Absolutely, that is the point which I want to make.
Yeah.
Some surgeons, they do PCL only with the 2 portals.
Yeah.
That is possible in this situation.
In this situation,
In
yes.
this situation, not when there is a ACL is intact, you will have a tight space. You can see already I'm in the footprint.
Yeah, you can really go to the footprint right
hold the
now.
shaver.
Yes, exactly.
So you can see that already I'm in the footprint only.
Yes.
I'm preparing the footprint, and still some footprint is in the back. So you have to go at least 2 centimeters below the posterior tibial articular surface. And if you are worried about using the shaver, you can use the wand. Still, it is a good choice of the instrument. And you can see that is the entire footprint. You can use the wand also. Can you give me the diathermy? Yeah. So most of these, when you have a PCL and ACL, you'll be able to reach through the
notch.
anteromedial portal itself. can you push that? Keep it here. Yeah, thank you.
There's stump, yeah.
You can see that. You can take out that footprint.
And I think posterior release is important, especially in patients which are chronically coming and they have a fixed posterior subluxation.
Correct.
So sometimes this is very important to reduce the femur, the tibia under the femur.
Yeah, this case it's fine because
this is okay. It's flexible.
Because, only 2 months time, that is fine for this case. But otherwise, because these patients will have a fixed, going for a fixed posterior deformity. In that cases, if you release that all the posterior capsule, they'll have a good movements. You can get a more anterior translation.
Yes.
As you see that already we are crossed the capsule there. Can you give some more shaver here? No, not
so,
just I removed some more stump is there.
Yeah.
I remove that stump. And use in the shaver, you better use it in the low speed. That is also important. Once you do the remove the stump, most of the preparation can be done through the anterior itself.
Yeah.
Mainly the posterior medial, which we use for mainly for the tibial tunnel preparation, because you can see and directly enter through the. So that is the posterior medial compartment. As you see, because this patient had already MCL tear, we can see that there is a big is a laxity is there already. You can see that still the torn tissues are seen. That means, so I'm trying to do the posteromedial portal. You can
Sundar
see that.
sir, what is the location of this posteromedial? Is it at the level of the joint line, above?
It is above the posteromedial joint line. So you have to feel the medial joint, posteromedial joint line, and go 1 or 2 centimeters above and proximal.
That's very important. Yeah.
And also it varies from depends upon the patient's thigh size, isn't it? So sometimes we have a big thigh, you may need to go even 3 centimeters beyond what you feel the posteromedial joint line.
Okay. So taken.
And use the guide wire as a direction guide for your knife.
Do you use pump for these cases or?
No, I'm not using a pump.
No, you see.
I was using PCL pump for PCL when I started my PCL maybe 15 years before. Then I stopped because we know that we don't require that. Okay, so I use the 6 mm cannula.
Yeah.
You don't need to use the cannula, but the cannula always helps for you when you exchange the scope, when you use the instrument. It is easy instead of struggling. You can directly use the cannula so that you can come quickly and finish the job. Okay?
Yeah.
So I will go my scope, I will move the scope to the posteromedial side and see how well I prepared the tibial articular surface. Then we will decide whether you need some more preparation or we can straight away go ahead with for our tibial preparation of your PCL.
And in such cases, when you have actually removed the posterior capsule up, your high pressure pump can cause a lot of extravasation into the calf.
That is true.
And cause compartment syndrome. So the pressure should be very low.
And even if you no need to prepare.
Actually.
Even you no need, even all the PCL injuries will have some posterior capsular injury.
Yeah.
So that's why you have to be careful.
Very careful.
So we can see that already I'm in the posteromedial portal, and you can see that is the PCL where your stump has to be there. You can see the tibial side has stump here. Can you see that?
Yes, yes. Low down.
Yeah. So you can use this kind of scoop sometimes. What I'm using is I think this is also from the Smith & Nephew only. This scoop I like this scoop very well because you can use it especially in the chronic cases.
Yeah, to elevate the posterior
to elevate the posterior capsule because here already I released almost. Can you give us some anterior translation? Slight anterior translation. Yes. So you can see that, and because that gives you more space when you create your tunnel. That is also very important. Can you give me the jig? So I'm going to use the tibial jig, and you can see that is the almost tibial articular surface, and we have to make sure that we are going almost at least 1.5 to 2 centimeter
down.
1 minute. And your jig has to be in the center or slightly lateral.
Lateral, yeah. That's
We
what
should
I
not
said.
come too medial. If you come too medial, then the chance of getting impingement in the femoral condyle is very high. And you can see that is the markings of the
Jig, yeah.
your entry point. You can see how deep you are going. Is it okay?
Yeah. Is it the popliteus fibers that you are seeing?
Sorry?
Popliteal fibers are there?
Yeah,
Popliteus,
yeah. Yes, yes.
That's another landmark.
Yeah, because, yeah, correct. Because already we opened up everything. And here we are going to make a tibial entry point. So the most important point here that you keep your, between the jig and your reamer, your handgun, at least keep 7 centimeter. The approximate length of the tibial tunnel for the PCL will be around 7 centimeter. Depends upon the, of course, size of the patient. But you can keep approximately 7 centimeter and make sure that you are going in the same trajectory. And my associate, Dr. Terence, is doing the drilling. And I am watching, okay, entry, that's good. Can you see that?
Yeah.
So that is the advantage of using the medial portal for your visualization. And you are able to see the guide wire entry here, okay?
Yeah.
Now I will use the PCL scoop now. Can you give me the PCL scoop in the hand? You can do a serial reaming. You can start with 4.5, 6, 8 like that. But here I am going to use the 8 size reamer first. Then probably we'll go for a 10.
Your graft size is 10?
Yeah.
The graft, what is the size of the graft, sir?
Your hand can go slightly down. Your hand can go slightly down. Because what happens when your assistant puts the hand on the popliteal fossa, that obliterates the space. You know?
Yeah.
When they push the tibia, they had to push the tibia slightly distal
down
than the
calf
popliteal fossa. Yeah, you can see I'm guide wire is coming out, but I'm still holding with my scoop. You can see the reamer has come out. 1 minute. Yeah. Okay. It's okay. Take it out. Again, bead pin and 10. So the size of the graft is 9 in the femur, 10 in the tibia.
Is it advisable to over-ream little bit on the tibial side?
Over-reaming?
By 0.5 to have the
We can do
easy
it.
passage.
Yeah, mostly because we can use the, suppose if that graft is so tight in the tunnel, you can use the same size of the screw. So usually I don't go blindly like a +1 or +2. So it depends upon the, yes, gone. Okay, take it out. 1 minute, put it in the hand. Yeah. So and also other important thing is that you can use the hand. 1 minute, I will use the suction to show that. Okay, you can see that? Yeah. So the other option is that you better come to the posterior cutters once reamed, that you know you touched that. You can use the hand reamer. Don't use push with the button. Use it with the hand, and you can do a slowly. You can rotate. You can see that and see it. Take it out. And we can use the shaver or the van to clear the entry point. But I don't have the control of the shaver blade. 1 minute. No, don't do it now. Anything. Always doing this is a bit dangerous because your assistant is doing. Yeah, can you do that? Yeah, please. Oscillation mode.
Clearing the mouth.
Okay, give the diathermy. And somebody has put the diathermy and somebody should put the finger. So it is important that the water leak, somebody has to give the anterior tibia, and one guy can put the hands on. Don't go too close. Don't make sure that water is there. Water opened up. Can you press the button? Yeah. Yellow. One minute. The water is not enough. Yeah. 1 minute. 1 minute. Water pressure. Normally you should have a good, can you press it now? Yeah. You can see it now?
Yeah,
Better?
yeah. Now it's clear.
Yeah. This is just for the, you don't need to do all the time. Okay?
Yeah.
But
For easy
sometimes when
passage.
the stump is, stop. But always better to clear that stump at the entry point so that the graft passage will be smooth. Press it again.
Also in PCL, the graft is going to go acutely over this edge.
Correct.
So it is always important to really make it nice and clean.
Yeah.
So that there is no aberration to the graft during the passage and as well as long term also. So it's an important step that we need just clear at least the roof part.
Correct. So you can see the tunnel now.
Yeah.
Okay?
Yeah.
You can see the tunnel well now. So your already entry point was made. Okay?
Yes,
Right.
Sundar, seems pretty good.
Yeah. So I will stop with that. I will put a, you have a stopper, the corkscrew for the, you don't know? You don't have that. Oh my. So somebody has to put a finger. Because the important is that you should have that plug for the PCL tunnel.
Yes, yes,
When
yes.
you want to do the next stage, because that is going to have a lot of water leak. So for making a femoral entry point, I make a lower anterolateral portal.
Okay.
Can you show the outside picture?
Yeah, it outside is seen, yes.
11 size blade.
Yeah.
11 size blade. And you can see that that is the high anterolateral portal.
Yeah.
And I'm creating a lower anterolateral portal.
Okay.
I'm making a single tunnel because you know it's any multi-ligament situation. We most of the time we try to do a single bundle to save the time.
And also the graft is actually, you need more graft if you want to make double tunnels.
Yes. So, can you give the shaver blade again? So it's very important to, especially when you do a PCL and ACL, or you should have a good clearing visualization. So clear the fat pad.
Yes.
It's very important. Instead of struggling, better to create a good space so that you can see it better.
Yeah, because tibia has a tendency to go posterior subluxation.
Yeah.
And every time that fat pad will come in front of your eyes.
Correct.
So better
So-
to remove it. Yeah,
Yes.
like this. The fat is coming right in the front of your eyes. Yeah.
Yes. Can you give the van?
And this is all scar tissue.
Yes,
So
scar
you really need to remove all of that.
Because we cannot preserve this as a remnant. Normally
Yes.
the PCL we try to preserve the remnants.
Yeah, but in this case there is no
this
remnant
case,
actually.
leave the van. So in
There's
this
no
case
remnant.
it is not possible because it's all a scar tissue. As you said, it's completely ruptured.
Yeah.
Because all the multi-ligament situation mostly you see like that. But whenever you do an isolated PCL, but you will have always good stump.
Yeah, you always try to preserve that
Yeah.
part.
You can see that I'm trying to clear the soft tissue so that we can see make the entry point. Because we are going to use only the single tunnel here. Okay. Still stump is there, good, reasonable stump, not too much. Most probably that is going to be my entry point.
Okay.
So I clear all the lateral side, also the medial side stump, so that straight away we can go and make the tunnels there. Can you see it now?
Yeah.
Yeah. So what I use the 6 or 7 size reamer for making an entry point, and through the anterolateral. Can I give a slight flexion of the knee? Yes, enough. And close the water with the finger. Can do a. So I'll just make an entry point. So that is the your anterolateral bundle entry point. Okay. So I'll try to keep it as a center of that footprint and trying to make it entry. So when you make it a single bundle, you try to go as high as possible, so that your aim of doing the single bundle is to prevent the posterior translation. Okay, enough. You can take out. So what we had used is that 6 mm reamer. in the hand, free hand. So it's a free hand technique, so that that gives you a fulcrum when you do the entry point. It doesn't move here and there. And also the 6 mm reamer can be kept in the center of your anterolateral footprint. Okay?
Yeah. So what is the knee flexion during this reaming?
Knee flexion around 90, more than 90.
Hyperflex you? Just like
normally, not a hyperflexion,
but
90,
okay, 90
because
degrees.
I didn't, usually I do it in 70 to 90 degrees.
Okay.
But here I couldn't get the proper trajectory. So I did some more flexion to that for that. Huh? So
Okay.
again, I'm clearing the fat pad some
pad.
more for the better demonstration. Okay?
That's usually needed for PCL because the fat pad comes in front.
Yeah. Because you are making so much
Anterior
entry
tunnel,
point.
yeah.
Are you happy with that entry point, Sibin?
Yeah, sir. Perfect.
If you say, I will change it.
no,
Okay?
no need.
Okay.
Yeah.
is the authority from CALICUT.
Thank you, sir.
I cannot overboard.
Sabir is the authority here, sir.
I cannot
And
overboard.
Ghafoor.
I cannot go overboard over Sibin's word. So I'm using the 4.5 reamer. I'm going to use the adjustable loop for my fixation on the femoral side. If necessary, we can use a hybrid fixation with the screws. Okay?
Yeah.
And also it has got a measurement, as you see here. Okay.
Yeah.
Depth gauge. So I was not very sure about the piercing the opposite cortex. But you can use the reamer here. Depth gauge. Go about and feel that, and it is around 40. Okay?
Yeah.
Guide wire. Direct 9. Guide wire. And I'm going to use the 9 size.
So Sundar, you always do a reaming inside out, or sometimes do you do outside in with
Whenever
a flip cutter?
whenever I do a double bundle reconstruction, I do outside in.
Yeah.
Because you definitely need outside in, because you are creating 2 tunnels. Especially for your posterior bundle, you cannot make it through this inside out. We have to make only outside.
No, that is true. But even when you are doing single bundle, can you do with a flip cutter from outside in?
Yeah, you can do it.
Yeah. Because sometimes the knee joint is very, very small. Some female patients, it's very, very small.
Yeah.
And so possibly it's sometimes much easier to do from outside in.
Yeah, correct. So it's a 20, more than 20, 22, 25 almost. Okay. So that's more than enough. So you need at least 20 in the femoral side.
You can play better.
Can I give me the shaver now? So both the tunnels for the PCL is over. So I'm going to create the tunnel for the, hold this. For the ACL, we will make the tunnel.
So what's your indication for double bundle PCL?
Double bundle?
PCL.
So whenever I do the isolated PCL, I do double bundle because you have a time.
Okay.
You can do it even for this multi-ligament scenario. The only problem is the site, the grafts availability
and time. Yeah.
And your time.
Yeah. Got it.
That is very important, no?
But all isolated PCLs you are doing double bundle.
But all of us know that clinically it doesn't make huge difference.
Okay.
But we know that biomechanically that is very strong. Good. Definitely double bundle is good.
So what is the minimum graft size for PCL? If it's single bundle minimal graft size that you want. Diameter of the graft?
At least 9.
And length of the graft?
At least 10.
At least 10. Okay, sir.
Today we got only 10. That's why I told 10. Of course, 10 is at least, you require at least 10. Because you need at least 35 mm in the tibial side for your screw fixation. Correct? No?
Yeah.
So, are you happy with the tunnel now?
Yeah, good.
The PCL, you can see the
good.
close to the articular surface.
Yeah,
high, that is fine.
Stabilizing the articular cartilage.
So now we will prepare the PCL tunnel. Sorry.
ACL
tunnel. So there are many surgeons prefer the different sequence. Some of them will prepare the femoral side first, go to the tibial side. It doesn't matter at all, in my opinion. Whatever you feel, if you are comfortable, you make. Anyway, you have to make an anatomic tunnel, that's all.
Yeah.
But anyway, during fixation, you should fix the PCL first.
Yeah.
That is what important.
Putting the tibial tunnel leads to water loss. That's the only thing. If you put initially.
Correct. You're getting out of focus is going all the. It's better. You can see better now.
Yeah.
So can you give the femoral jig? So we are using what is the offset of this? What is the offset of this guy? 6 mm. Okay, doesn't matter. Can you do the flexion now? So I think you can see the ACL footprint already.
Yeah.
So enough. For the enough. Don't two. So you can see your posterolateral portal starts from here. So your entry point should not come too low and too anterior.
Yeah.
Wait. And you make most of the anteromedial bundle, and maybe slightly you can come to the posterolateral bundle.
So majority in the anteromedial portion.
Yeah, majority should be in anteromedial. If you
Anteromedial,
go
yeah.
high, that will not fail. If you come low in the anterior, the chance of failure is high.
Yeah,
Okay,
yeah.
ready.
Take it.
Are you happy?
Yeah.
So, okay. So, this is okay for this entry point. Go.
How much is the offset guide, sir?
This is 6 mm offset.
Diameter is 8 millimeter.
Diameter 8
Yeah.
the femoral side. So, that's fine. That means you get 4. Still you get 2 mm posterior cortex. Huh?
Yeah, that's perfect.
Okay. Guide wire. So, put a 9. Anyway, you are using an adjustable loop here, so even slight posterior cortex bridge doesn't matter.
So, means regarding PCL graft length, if you are using a button, I mean outside, adjustable button on both sides,
You can have small.
what is the length of the graft needed? I mean,
So there is a question, if you are doing an all inside PCL, how much is the length of the graft needed? Sundar sir?
Again, depth cut, please. Sorry, what is the question?
If we are doing an all inside PCL,
Yeah.
in suspensory on both the sides, how much is the minimum length of the graft needed?
Again, because you require at least 2 to 3 centimeter in that tibial side. So plus 3, 2, 5, at least 8.
Yeah, 7 to 8.
Yeah.
7 to 8 millimeter.
Yeah. So
centimeter.
this is only a 32. So we can keep ACL, we can mark it for 20. Okay. This is already 8, no? Not done, no? Okay. 4.5 only I put. Okay. Directly 8. Yeah. So I will go for, because tibial length we have around 9, no? 10. So we have, so it's a 5 stance graft. So we have no need to worry about the length here. I can go 20, 22, like that.
So you need to hyperflex the knee, or is it 90 degrees? Okay.
This is around 120.
Okay.
Can you show the outside view?
Yeah.
Can you see that? Outside view. Can you see the flexion now?
Yeah.
Yeah. So it's around more than 120. So I crossed up to 20. Okay. 20, 22. It's fine.
How much minimum length you need for ACL, sir?
At least 1.5.
On the femoral side, 15 millimeter. Yeah.
If you are, suppose you are having a 6.5, you are using a 4 stand, only semi-T, at least minimum length which at least 1.5.
Okay.
But always good to have at least 1.8 to
20, yeah.
Yeah. So most commonly I use 1.18 mm. Okay, because most of the cases I use 4 stand semi-T. I will get a 7 size length. So I can manage with 7 centimeter length with the 18 mm in the tibial side, femoral side. Then you will get a good length up to the aperture on the tibial side.
Okay.
So you can see that's fine. Okay.
Yeah. Looks
the
good.
posterior cortex is intact. So now I will go for the tibial side. So tibial side already I think, I don't need to demonstrate too much because IPS had beautifully demonstrated about all the entry point and the fixations. The only thing is you can see the limb is externally rotated. So you have to be careful that you do the internal rotation. You should not go too lateral. Yeah. Can you give the jig please now? So that is the anterior horn of the lateral meniscus. Can you see that?
Yeah.
Yeah. For the youngsters, for them to make an entry point, your 2/3 of the ACL corresponds to the to the anterior horn of the lateral meniscus. Okay. 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 Drill. Yeah. This is the tip aimer.
So tip is at the level of posterior horn of the posterior border of the anterior horn.
Posterior border of the anterior horn of the lateral meniscus. Drill. Okay. Yes. It took a long time back. Can you see that?
Yes, sir.
Yeah. So now we are making the tibial entry point. The first 7. So don't dream directly 9 because this is a no. Take it out. Yeah. Why you are?
Sundar, it is slightly coming lateral. Slightly.
Go.
So we now I think better. Because the 8 mm reamer would have gone to the cartilage. Now it
Yeah,
seems to
take-
be. It's
yeah,
still-
slightly
still-
on the lateral side.
Yeah, slightly on the lateral side.
Yeah.
So maybe you can do a 4 mm and then just shift it
Yeah, yeah.
gently.
Take it out. 1 minute. Yeah, go ahead. So I'm trying to adjust, going on the more medial side. We'll see whether I can make it. Okay. That is more on the more. We take it out. That is more medial. That is not correct. Take it out. Yeah. Do it again.
Keep the guide wire then.
Yeah. Do it again.
So is there a specific reason you're using a point reamer, or would you actually use a footprint reamer?
I use
Aimer, sorry.
I use always footprint.
Yeah. Footprint is always good because it gives you a nice impression where the exit point is going to come.
Here we have only this one.
This okay. That's okay.
That's why I'm using this. You can use this also. I mean, the footprint always gives you nice idea because you are going to keep it the center of the footprint, and you know where you are entering and all those things. That's good. Give the sound size reamer. Give it to me.
So there is one question. What is the angle of the guide? Jig, ACL jig.
Sorry?
Angle of the ACL jig.
Usually I keep around 55.
And for the PCL?
PCL is around 65.
Okay.
So here I am adjusting bit. Can you see that now?
Yeah.
I made a slight adjustment when the last entry point.
Yeah,
but we
last
don't do
entry
it.
point you just gave a slight.
Slight
medial side.
But,
Yeah, so that.
But
it
for the
lean-
youngsters, please don't do it. Use the guide wire. You can use the other method is you can use the guide wire and keep it in the. Yeah, somebody has to keep the.
Yeah, so you put a guide wire and then just give a small medial
small,
side
you
pressure.
can hold with
So every time the reaming is on the medial side more.
Problem. Give the knife. I will make a slightly more entry point. Knife, please. You don't need to worry about the incision here. Can you give me a blade again? 11 blade. So don't struggle. Take it out because you'll have again struggle when putting a screws. So I'm making some more extension of the incision because Terence is struggling with that. Yes. Now put the guide wire. Yes. Correct. So you always adjust like this. You can adjust like this. You can go posterior. You can come anterior.
Yeah, you can hold with an artery
Yeah, you can
wherever
hold
you
with
want
artery
to go.
percept. You can see that.
Yeah, yes.
So if you want to go on the lateral side, you hold it like this, ask them to ream it, you will get extra 3 mm. Same way like this, same way like posterior, same way anteriorly. You can ream now.
Okay, sir.
So I'm holding it now. I'm
More medially.
going with the 9 size now. Okay, take it out. That's fine. So almost all my tunnels were made now. So we'll ready for the graft passage. Can you give the suture retriever with the, so whatever it is for the passage? The already is cleared well, so I don't need to do much here. What is this? No, hold it in the, give it in the tip. So some of them usually might have done this once after the tibial tunnel is done. Okay?
Yeah.
You close the water and do the anterior tibial translation. So, no, not close the water means not in the arthroscopy for the PCL tunnel. Okay? So you try to, you can see that?
Yeah.
I think already thread is there. The one way of doing is that you can, if it is very low, you can take it through the posteromedial portal and bring it up. In this case, you can see that I could bring it through my anteromedial portal itself. But in general, normally use the posteromedial portal, then you bring it up, then you bring it here. Because when the PCL is intact, the space is, when ACL is intact, the space is very limited.
Yeah.
Because already we discussed before, because this case is loose joint, you are able to enter from here itself. Give a switch it here. Okay, I'm taking through my low anterolateral portal because I made the tunnel through the anterolateral portal. Then I'm taking through the PCL tunnel. So always the swapping the scope. I'm now I swapped my scope to the anterior side. You can see that.
Yeah.
Careful. Hand, turns your hand. Okay. Outside view.
Yeah, we are seeing it here.
You have the open. Open is not there. cut it up. Cut it up and tie it up. Cut it up. No. Give the scissor. Cut the loop. Then what you can do? You can pass one thread. Then you tie it up. So this is not going inside because it's a very small.
Small aperture.
Yeah, because it's a looped one. It's not going inside. The other technique is that use the single strand. Bring it up and tie it up. Terence has got a poor visibility. He needs glasses actually. To mask his age, he is not wearing.
You're making me more nervous.
We could see his hand trembling. I mean, in the picture, it's clear that he's missing the hole.
Leave it. Take it to the hand. Yeah, now we tie it up. So now he is tying that. So one more. Tighten it. Yeah.
Better one more because it tends to open up. Yeah.
Tighten it well.
And then check it that it just does not open up.
Go. Okay, good. So done the job for this. I need the rod now. Rod. So the most important step is that, because it's a killer turn, to avoid the killer turn.
Yeah, you always put
always use this rod
behind.
Okay.
And it would just help us in levering it out.
That helps you to lever it out.
Yeah.
Okay, you can see it now. 1 minute. Yes, you can see that now.
Yeah, it has to be over there.
That is where you hold this. Terence, hold this. Can you give me the graph? Can you clear the entry point? Nibbler? So always the entry point of your tunnel, whether you do a ACL or a PCL,
has to be
always
cleaned
clear that
nicely.
entry point so that you don't struggle when the graft goes in, because some soft tissue sometimes can obstruct it. Can you give me the nibbler and on the retractor? Show the entry point if possible from the outside view, so that when I clear it, you can see it. Yeah. You can see the lot of soft tissues. I don't know whether you can see. Nibbler.
Yeah, we need to really clean that area up. We need to see the hole nicely here. Because graft passage has to be smooth.
Actually, yeah, I can see it now. Tunnel well. Okay, graft. One minute. Yeah. Open it up, somebody. Yeah, you don't need to give that much. Leave it. Yeah. Now take the thread out. Hold this. Now hold this. And come, hands should be closed like this. So you have to make sure that when delivering the graft, wait. So your assistant or nurse should not hold it here, because if they hold it in a distension, then the chance of coming out is very high. So make sure that they are coming very close to that. Yeah, go ahead. Yeah. So I can see the. Wait, slow. Go. Maybe you should have made a small incision there. It's okay. It will come. Not coming? Still a little. Hold it here. Okay, it's okay. Nice. Make sure that you make incision slightly. 1 minute. So when you have this kind of situation, when you move, make an incision slightly away from that, okay? Don't go.
Yeah, that knot is coming in between.
Yeah, you should not cut the knot. Yeah, use the artery.
And fish it out.
Yeah, so when you have this situation, you have to use the artery and take it through that. If you try to incise there, then with the chance of damaging the threads are very high. Use the probe and take it out. Probe. You can use a small retractor also. Give a small retractor. Yeah, you take it through the probe. Smaller one. Yeah. Yes. Yeah, take everything. Wait. Leave it? Yeah. Wait. Make sure that all the thread has come. Yeah, take that thread out. Okay. No, take it the other side. No? That all the thread has not come, I think. Okay. All the 4 threads are there. Okay. Go ahead. Okay.
Yeah.
Sorted out. So the graft, we are going inside. We can see the button coming in.
Yeah.
So you can see how I'm giving the levering out.
Yeah.
I'm taking the graft backwards like this.
Away from the killer turn.
I'm delivering with my steam and pin.
Yeah.
And 1 minute. Yeah. Go ahead. Yeah. Go ahead. You can pull the even just that blue button, or you can go ahead everything together. Go. Some more. Wait. Yeah. Okay. Almost the. Hold this. Okay. I will try to pull back. Only the guy who is pulling will feel that
tug.
clip.
Yeah.
I cannot feel it. Leave it slightly. Yeah. It's done. Okay.
Yeah.
You can see that already done.
Yes.
Yeah. Now I can pull the graft. So the white tapes. This is what we are using. Today is a rigid loop from the Mitech company.
Yeah.
Because they want me to tell that. Otherwise, Samir will not get full amount.
So this white loop will make the loop smaller and the graft will start moving up.
Yeah.
So it's a rigid loop, but it's also variable loop actually. The name is rigid loop, but it is variable, adjustable loop.
Pull the alternate. Yeah. Okay. One more pull. Okay.
Yeah, that's
Okay,
overall.
enough.
Table is
Good.
long. He
That's-
says 10
tighten it.
centimeters. So.
Yeah. Tighten it. So you can see the nice vertical graft. Okay.
Yeah.
That's enough.
On the tibial side, you still have graft outside, or is it nearly gone?
No, definitely it's inside. Only half of the tunnel is filled with the graft.
Okay.
Because it's a 10 size only.
Okay.
So probably I have to go. I will always use a hybrid fixation on the tibial side.
Yeah.
But here it is snugly fitting, so I no need to worry about it. For the tibial side, once you fix the graft, you can see pull tibia comes anteriorly like this. Okay.
Yeah.
Now I will pass the ACL graft, then we will start fixing the tibial side on the PCL.
Yes.
Okay. You can remove the rod. Don't remove the. Give the bead pin, please. Or any water is not there. But give the bead pin and one more thread for the ACL graft passage. Put that knot. Do the hyperflexion. Get 120 degrees flexion, which we need to flex the knee. Yeah, please. Enough. Whatever the flexion which we did, the same thing only. Okay? Not more than that, not less than that. And you can see my entry point of the ACL.
Yeah.
Can you show it outside view?
Yes, it's down quite lateral.
Yeah, you can see almost in the middle of
the thigh.
Okay.
Yeah.
If your entry point is too low, that means you are too anterior.
Yeah.
That is going to fail. And if the entry point is here, almost at the top of the thigh, that means your tunnel is very vertical.
Vertical, yes. This is the right point.
This is the ideal entry point in the middle of the thigh. That means you are okay.
Yeah.
Go ahead. Go some more. Yeah. Take it out. Take it inside. Okay. 90 degrees. Grasper. For the tibial tunnel. Okay. Ready? ACL graft is ready. Please bring the graft. Okay, we are using the same rigid loop. Okay, go. It's enough. Go.
Yeah.
Go. Should have made an incision. I think this will not come.
Always there is a problem with this.
Down there. Yeah, you should use always fiber wire.
Yeah.
When I use a fiber wire,
it would glide out.
It will slide, comes easily.
Yeah. When you have an ethibond, it just becomes a knot, big thick knot there.
This is very thick.
Yeah, so again an incision on the
That's
side.
why I stopped using ethibond in my practice. I never use Ethibond for anything.
Yeah.
Otherwise, you don't need to make this entry point.
This is, yeah, next, yes.
Okay.
But this is a clever trick. Away from the thread, make a small nick
Yeah,
and then
so that,
fish it out. So you don't cut the thread.
Correct. It's more safer.
So this
always
means
the
this
bait-
is
bait-
this
bait-
means this has happened to you more than once.
Sorry?
This means this has happened to you more than once and you know the trick now.
No. Very rarely it happens because nowadays I use only fiber wire, but it happened before. It happens once in a while, definitely.
Yeah.
Cut with the knife.
That's why you changed to fiber wire.
Yeah, that's why I changed to fiber wire. Cut one power.
Too much fibers.
You took only one. That is the problem. Probe. Always to see the bailout situations in the live surgeries than the. This is a very
Button
important
is
trick.
no. Suture.
Go all together. Okay, so I think all of you know what is adjustable loop. Go ahead.
Yeah.
So you
Yes.
can see that the tape which is in the center is holding the graft. The threads in the both the sides is holding the button. So we should not pull the white alone, otherwise that will get a problem. Pull some, leave it.
Flipped, huh?
Yeah. So the other important thing is the mark. So the mark is not there in the entry point. That means your entry is not correct. Here it's
Yeah.
fine because already I'm feeling that firm point.
Flipping, yeah.
And when you pull it, if there is any bungee effect, that means you are out of the tensor fasciolata. Don't pull it. So if you go out of the tensor fasciolata, you will have a big bungee effect. Okay?
Yeah.
That is very important. So when assistant pulls with so much enthusiasm, it can come out of the skin also. It had come many times.
Yeah, it's a common thing.
Yeah.
And it's quite common with a variable loop because that's a large loop.
Correct, yes.
So you can actually pull it out of the skin.
Yeah, correct. So here, go, tighten it. So you had almost 22. So that looks very good here, okay?
Yeah.
You have done the PCL, you have done the ACL. So now we'll go for the fixation on the tibial side first, tibial side of the PCL.
So now the Sundar big point is when you have an ACL and PCL both are deficient.
Yeah.
And you are now going to fix the PCL. How to ensure that you actually don't fix it in anterior because you are going to do anterior.
Absolutely.
So
that is one of the very important question by IPS because you can, when you do a PCL alone, when you fix the PCL first, the chances that you can do a too much anterior translation and fix it in sublux position. That had happened to me when I started the career. And you have to be careful that you had to put a finger breadth here. You can see the outside view. You can put a finger breadth. So it should be around only 1 centimeter from the femoral condyle to the tibial condyle, anterior subluxation. If it goes more than that, then it's
more.
That means you are doing it more. And also you can arthroscopically also you can visualize if you want to.
So maintain the normal anterior tibial step of
Yeah.
1 centimeter.
And also you see the another complication which we escaped today is the staple. You can see the staple.
Yeah. Just escaped.
Myself and Terence were discussing before that if it comes in the way that we may need to take it out, but luckily it was okay. Okay, you can see that that is the entry point. So probably we have the around more than 4 centimeter inside. Okay? The tunnel size around 6 centimeter, maybe 6 to 7 centimeter. We can fix the two-way, whether you can see through the posterior medial portal and fix it up. So I'm going to use the 11 size graft because it's a nicely snugly fitting graft. So I'm using one size more. Can you, somebody pull the graft anteriorly? So probably, Terence is going to fix the screw. You can see the PCL graft nicely now.
Yeah.
Pull the tibia anteriorly. So you can see that now. Give the guide wire for the screw insertion. So we are using the 11 size Milagra screw.
So how much is the length of the screw?
Length of the screw is 35.
So you want to come way up to back of the tibia?
Sorry?
So the screw comes up to the back
Yes.
near the aperture
Yes,
posteriorly?
yes. The tip has to come in the entry point.
Okay, okay.
எவ்வளவு இருக்கு? Say give a 30. So they have only 30.
Okay.
11 into 30.
So which means you're going to use a button in the front as well.
Yes, I'm going to use the
suture disc or something
yeah,
like that.
correct.
Yeah.
They are going to use the screw. Give the 10 into 35. Make it faster. 11 into 30. Yeah, sorry. There are 200 people are waiting for your screw.
So Sundar, and lunch is between you and them.
That is also true.
So what is the flexion of the knee you keep for
The
PCL?
flexion is around 70 degrees.
Okay.
Can you make faster bit? And you put an artery forceps here. Yeah, go inside. Take an artery forceps. So when you use a screw, always the thread. Sorry. Go inside. Yeah. So you can see that outside view. Thambi.
Yeah.
Yeah. So
Milagro.
what happens? You have a control of your guide wire. Otherwise, it will go too much inside. You can see already has
Posteriorly,
gone.
yeah.
Terence has pulled up. So I am going to hold it in my hand, and Terence is fixing with and make sure that 1 minute. Hold this. I make sure that you are not translating anteriorly too much. Okay. You have to push it to go. Sometimes it will be very tight to go. So you have to push it and go. Yeah. Go. It's okay. Yeah, it's coming almost. Come on. Yeah, it's okay. No, go. It's okay. You can see the sound. You can see the screw tip now.
Yeah.
Okay.
Yeah. Just
Yeah.
visible.
Yeah, that's good enough.
Good.
Okay.
Yeah, fantastic. Yeah.
So that is 30. Okay, take it out.
So Sundar, have you done a double screw fixation sometime on the tibia?
TBL side double screw.
One screw goes back and
Oh,
then no.
I have not done because I use the hybrid fixation. So I never done that. IPS, I never done that. And we can see now the tibia looks good here. It's completely stable. Okay. Maybe we'll check it whether it fixed in correct position. Maybe a slight, yeah. You can see that slightly it's anteriorly. You can see that? Terence has given too much force, so I may need to take out the screw and put it again. Put the guide wire again.
And this is the most common problem which happens, and
Correct.
that is why I asked this question. When you have a multi-ligament, especially both ACL and
Guide wire,
PCL,
guide wire.
there are chances of anterior translation and fixing an anterior
So you
translation.
cannot go blindly again. So you have to always see that. Put a screwdriver directly. Yeah, you can see that. Yeah. Put the screwdriver. It doesn't matter. Okay, it had happened even the ACL we do that because sometimes when they take it up. Hold this.
Guide wire is, yeah.
Artery? No. Yeah. Put the artery. Yes. It doesn't matter always, okay? Always redo. Very rarely I have done it for the PCL. For the PCL, ACL I have done that, removing the screw and putting again. Okay, that's okay, good issue. Yeah, that's okay, yeah, that's okay, good. Okay, hold it, hold the artery. In the PCL, no? Yeah, no. Leave it. Do the internal rotation.
So doing this, will it reduce the perch of the screw? Do you want to upsize again or the same screw?
Always one size is more is good. You have a tool also. No, when we are redoing it, as you are doing. Yeah, we are. Always one side is more, it's good. Okay. Yeah, it's okay. Because it was very tight fixation. So I think the same size also will do the job. Can do internal rotation.
And that is when you have a variable loop on one side,
Yeah.
on the tibial side, you don't need to actually pull it hard too much.
Yeah.
You can tighten the graft from the femoral side.
That's a good point.
Remove the
Yeah.
screw,
Remove the scope. Put it inside. From the other side. Yeah. This time I am very clever. I'm going to check it again. Okay, that is fine. Yeah, looks fine. Yeah. Okay. I'm not overdoing it. Now you can bring the scope. Post-operative bottom. It's always better to check it. Yeah. So posteriorly. Right, like this. Not come. Hold it. Already has gone.
Yeah.
Okay.
Yeah.
Okay. Take the scope. So take it. Now I will check it again. What I will do, usually I do the hybrid fixation. Yeah, this is better now. You can see that.
Yeah, yes.
So now I have to fix the ACL. This is fine. We can see that lateral meniscus just in front of the femoral condyle, and this is what very important, because you should not do an anterior subluxation like what happened in before. So you should be very careful. Okay, so I'm going to fix the ACL now. So I'm taking the scope out. And can you show the outside view?
Yeah, we can see. Yeah.
Keep it 20 degrees extension.
See, always fix the ACL.
Before that, I will show the PCL hybrid fixation also. Give a 4.5 drill.
And once you have put a PCL, the medial opening should have reduced.
Sorry?
The medial opening should have reduced by now.
Yeah. We'll check it again.
Yeah.
So you're putting on, tying on the bone, isn't it?
I need a tap also, 4.5 tap.
Oh, screw. Okay.
Is it in the forward?
So you're tying over the post.
Yeah, tying over the post, correct.
Yeah.
Very blunt.
Hard bone or drill bit is blunt.
Do you have a tap? No, 4.5 tap. Tap, please. Always I use the tap because the bone is strong. The post will not go. What's the size of the drill? Okay, that's fine. It's okay. I went through and through. It's fine. So usually it will be 35 to 40.
Yeah, the proximal tibia, yes.
Yeah, proximal tibia will get a 40 at least.
Sir, what's your take on hybrid fixation on the femoral side
40.
also? Some of the articles now say it's doing hybrid fixation on the femoral also.
ACL, no? Sorry?
Hybrid fixation on the femoral side for PCL.
Yeah, that's why whenever I always, if it is very loose, that sometimes when because of the direction, and if the graft size is not matching exactly what you have measured, no?
Okay.
Then if there is a gap between to prevent that bunchy effect, you can always use a hybrid fixation. You can use the small size screw like 7 mm.
Okay.
We can use it always. So this is the suture post. You can see that.
Yeah. It's clear.
So I make at least 2 rounds. Then you tighten up so that you are safe. Just as an additional security for your graft. Knife. Knife, please.
So there is no need to tie it, or is it enough? No need to tie it. Okay.
Artery. 20 degrees of flexion. Sorry, extension. Bring it. Yeah. So fix the ACL now. Retract. Support the tibia. Retract. Retract. Yeah. Can you give the, what is the size of the 9? Huh? So can you give a 10 into 30? 10 into 30. Can you see the outside view?
Yeah. Sir, the ACL screw you put behind the graft or anterior to the graft? Is there something like that?
I usually go posterior to that. I mean, distal to that. Because when you go more and more proximal, your bone is more and more cancellous.
Okay.
So the fixation of the screw will come down when you go more proximal because you are in the metaphysis, it's a more cancellous bone.
Okay.
So I try to go posteriorly as much as possible. And also you can do some adjustment. Sometimes when your ACL graft is, even though all your adjustment, you had malposition, you can use the direction of the screw to change it.
To reposition it, yeah.
Yeah, so suppose if it is the medial side, use the screw on the lateral side so that will push the graft at least 2 to 3 mm.
Got it.
So that is one technique which you can use it.
Otherwise, always it is posterior.
Always I try to use it posterior. So I am using the 10 size screws, the 9 size graft. I am using a 10 size. That's the knee. Okay, we have a final view. Can you give the probe?
Yeah,
Probe, please. Probe. And you can see that I am trying to do a posterior translation or anterior translation. Can you see that?
Yeah. It's very stable. Looks
very stable,
yeah.
and we fixed it in the correct position now. There is no anterior translation. You can see the nice PCL graft. Almost is very nice for this tunnel, and also the nice is in a ACL is in a very good tension. If you want, you can do a tighten again. Some more tighten the ACL.
Can you show the medial side, sir?
That is the advantage of using the
adjustable
loop. You do the extension now. Enough. Do the extension. You can see the extension. There is no impingement. Go ahead. Yeah, that is the full extension. Okay.
Yeah.
That's a
looks
good space.
fantastic.
Flexion.
That's good. So the medial side, can you show the laxity? The medial laxity, is it gone?
Yeah, we'll see that. Okay. Still you can see it's around 4 to 5 mm opening. Normally that's okay, but this is okay for this patient because this is not a big laxity.
Yeah.
So he doesn't require any ACL reconstructions. So it's almost 40 degrees of flexion and doing the external rotation. He's trying to do even external rotation, but there's not much opening. And you can see that space is completely closed. Any other questions, Sibin? I think almost we have finished now.
Yeah.
Any doubts?
Any doubt?
Any questions?
So thank you, sir. Thank you for the wonderful presentation. Fantastic, sir.
One last
question.
Sir,
one question
Sundar
from
sir.
Dr.
Jyoti Prashant here, sir. Sir, do you use a augment, that is, do you use a fiber tape for PCL rather than in ACL? Because to prevent a posterior sag or delayed loosening, laxity.
Like internal tracing.
Yeah, some additional synthetic material in the PCL just to protect from the posterior sag and elongation.
I have not used in my practice at all.
Yeah.
So whatever you use, the posterior laxity which you are going to get, it's not because of the PCL alone. So we are not replacing the entire posterior capsular injuries. That's why this problem comes, like MCL. When you replace the MCL, we are not a medial sided injury. We are not entire medial sided injury. We are not replacing. We are replacing only a superficial MCL.
Yes.
So that is not going to compensate the entire medial side. That's why the patient, if you see the post-op, if you take a stress X-ray, any medial reconstruction, even do a repair, they will have some laxity.
Yeah.
And in adjustable loops, actually, do you absolutely trust them? Or there is a documentation that there is 2 millimeter loosening in the late phase of when using adjustable loops. So that is why all inside using 2 adjustable loops have gone out now. So do you always trust adjustable loops?
The last 10 years I'm not having any issues at all.
Thank you, Sundar. It was a wonderful demonstration. Thank you very much.
Thank you for the opportunity.
And please join for the lunch, Sundar.
Thank you. Thank you.
Yeah, thank you, sir. Thank
Thank
you.
you, sir.
Thank you, chairpersons. So the lunch
you,
will be
everyone.
served behind. We will not be having a formal lunch break. So I invite chairpersons Dr. Gobinathan and Dr. Srihari K for the next session.
Supporting rest of the board.
I invite Dr. Sandeep BRS for his presentation on
Thank you,
arthroscopic
everyone.
PCL reconstruction.
Thank you, madam.
Very good afternoon. Greetings from the Indian Arthroscopy Society and our Executive Council. So this is my fond memory of Kerala. So I started my PG journey from Kerala. I did my post-graduation in orthopedics from Kerala. This was me in 2007. And this was our last visit to this beautiful city of Calicut when I came for IASCON 2018. So when we think about PCL reconstruction, so there are key issues which are required for patient selection. So the indications being isolated symptomatic acute grade 3 PCL, then it can be considered when you are doing along with other multi-ligament reconstructions, just like we saw a while ago. Then if you are treating meniscus body or root tears, then if there are any acute displaced PCL bony avulsion fragments, and patients who have got chronic symptomatic PCL tears. So these are the ideal indications when PCL reconstruction is being considered. So that's how I position my patient when I'm doing PCL. So I'm well versed with both TKR position also and leg hanging, but PCL, this is what position I prefer, because in case I need to use C-arm, so I get very free access under the table, and that's how the knee is positioned. The choice of graft is CME, gracilis, and also peroneus longus. I use it for PCL reconstruction. So before I start my surgery, so whichever system I'm using, I always calculate the tibial tunnel beath pin like this. Now you can see here, the length is around 14.5 centimeters till the bullet. Then on the table, when I have positioned it, I again calculate and that it's like 0.8 centimeters. So I add this up, it comes out to 15.3 centimeters. I fix up anywhere between 15 to 15.5 before for the tibial tunnel. So that's, we have seen a very beautiful surgery. So I'll just run through this video. So once you put your scope in, you can see scope is in the anterolateral portal, and you can see the battered PCL. So I'm clearing out the synovium, and you can see the PCL is torn, ACL looks little wavy. Then I'm trying to create a area underneath PCL so that I can get access to the posterior medial part of the knee. So then gradually you expand it, then you enter into the posterior medial compartment. So now I am in the posterior medial compartment. Then I pass a needle, 18 gauge needle, come from little superior aspect. That's my needle coming. Then with keeping, I always keep the needle and I use the knife to take my portal. So with the 11 number blade, which is tied very securely, you try and make an incision into the capsule, pass Wissinger rod. Then over it, I put 8 or 8.5 mm clear cannula over the Wissinger rod. So once it is secured, so things become little easy. So you don't have to struggle, because many people, they do manage without even putting this clear cannula, but I always try and put this. So my posterior medial portal is secured. Then from this, I use my radio frequency device and start clearing out. So you go right up to the champagne drop. You can see the Sharpies fiber. Then here you can see the remnant of PCL is still there. So I have gone almost 20 mm below the tibial plateau. So once it is cleared out, next step is to pass a jig. So I'm putting my tibial jig here. So you can see the jig has been positioned around almost 1.5 to 2 centimeters below the tibial plateau. Once it has been positioned, then I start drilling. So as I have already fixed my length, so I'm not worried about that. So once it reach closer or once I get stop, I remove the discontinue the drill bit and start tapping with the gently with the hammer. So now you can see the drill bit has just come. Now I am tapping it. So I am engaging that drill bit pin within the slot of the PCL jig. So then start rimming over that. Sometimes if it is graft is too thick, then I do serial rimming, or otherwise I prefer. Then while passing, I use this device. That's a broken first pass mini. So that is like I pass the thread and I just fire it so that it comes in front of us. Then you can very well easily take it out, because once your jig is out, then everything posterior capsule and all falls over the tibia. So you can see that I'm shuttling the then with the help of grasper or ice tongue, I just take it out. I have parked it in the posterior compartment. Then start clearing the tibial footprint. Femoral footprint for the PCL. Now I have shifted my scope into the anteromedial portal and working from the anterolateral portal. So RF is coming from anterolateral portal. So I usually use this reamer as my guide. So I am keeping the reamer there. Then I am passing the bead pin. Once bead pin is passed, so I drill up to 20 to 25 mm with the help of this reamer. So that gives me socket for the PCL in the femoral. So the ideal point is at the roof of the femoral condyle. So that's a roof point. Then once this now here it is 9 mm reaming is done, then I take the 4.5 mm reamer to complete my tunnel. Then later on, next is that's my tunnel view from the anterolateral portal, tibial femoral tunnel. Then I pass the another thread of different color into the femoral tunnel. Then I create a virtual cannula and both I bring it out through the anteromedial portal. So once they are in anteromedial portal, I start passing the adjustable loop in the along with graft into the tibia first. So now here graft is going into the tibia. My scope is still anteriorly. I have not yet moved in the posterior. So if situation demands, I do go posteriorly. Now I'm shuttling the button into the femoral socket. So now button is going in. Now button has flipped. Then I start pulling the thread and tightening it. So it's the same adjustable loop which you saw just a while ago. So that's it has come up to the mouth. You have to be very patient while doing this, because in case there is a chance the threads give away, then you need to repeat all the procedure along. So that's my PCL is in position. Then I come into the posterior medial portal and view the PCL. Then I again view in the tibial tunnel also to check the length, how much length I have got, and if I can put the screw or if it needs double fixation. So as I mentioned these two things in my, this is the way sometimes you have to stop the fluid. So use this device so that it flips in the superior portion. So suture management becomes little easy. Then you can very well take out from with the help of grasper or ice tongue. And that's the way when we pass the screw, you always make sure your wire is well outside. And then whenever you are passing the screw, that's the point when the tip is visualized. That's the end of the screw fixation into the tibia. So the key points, the measurement which I do before the surgery and use of this broken first pass mini. So I'll go to immediately the PCL avulsion fixation. So whenever I'm doing PCL avulsion fixation, my checklist is C-arm, 8.5 mm clear cannulas, then fiber tape, wires, loose endo buttons, then special instrument. So I'll come to this when we show. So here, I'll skip through all the previous steps. So once you have created, remove the septum, that's the fragment here. And there is attachment of PCL. So this particular is the used for AC joint cannulated drill bit. So I have got this bullet made where this can allow it to use it with the help of my regular ACL jig, so I don't have to worry, and that's how it can be removed, so it becomes cannulated. So while drilling, you use it as a drill guide, and then once drilling is completed, you remove the inner K-wire or that trocar, and then it becomes a cannulated. So which allows you to push the put the chia wire inside. So now I'm buttressing with that different jig onto the PCL fragment. And while doing so, once it is done, I always check under C-arm. I confirm that my reduction has already been achieved, and that's the direction of the drill guide. So drill guide, sometimes it may miss the hole. Then I pass the chia wire through the cannulated portion. Then chia wire is parked into the posterior medial cannula and shift the scope anteriorly. Then I load fiber tape along with endo button, so that it is pulled in, and I pull it out anteriorly over the tibia, so that it has been pulled out here. You can see that's the view after it has. I have confirmed that it is pressing the PCL fragment, or in case I need to change the direction. So that's the picture. Then I again pass another endo button with a sliding knot, like which we use in the shoulder. So this is one of the case which I did with this. That's his patient CT scan and MRI. That was post fixation of this avulsion. Then another patient had got a multi-ligament ACL, was also torn. So that was doing again the same maneuver, and the patient which I had showed just now, the same. Thank you very much. I would like to take opportunity to invite you all for ISCon 2024 in Bangalore. Thank you.
Very quick questions to Dr. Sandeep. He is going to operation theatre. I invite Dr. Sujit Jose for his presentation on meniscus. You can ask from the podium.
A quick question about where to drill the tunnel. Where do you place the tunnel for the endo button? Yes, because your bony fragment there.
Yes. So my aim is I always put my guide, and I confirm that fragment is getting buttressed. Then I come through the fragment, not alongside. I try and come through the fragment only, PCL fragment. The bony fragment.
Do you take separate bites on the PCL
No.
tissue?
So usually the fragment is big, because we know by CT scan and MRI how big it is. Sometimes then I do have taken bites, but I just showed the one with the big fragments.
Let's proceed.
Good afternoon. I suppose people are coming in after the lunch now. So my task here is to describe meniscus repair techniques. There will be a separate session by Dr. IPS Ebroy on the root and ramp lesions. So to understand why the meniscus is important, the hoop tension and the load transfer is to be in our mind. The vascularity is all on the periphery, as we all know. The middle area is where the red-white zone is, where you are a little confused whether to go on a fresh tear in a lateral side meniscus tear along with an ACL reconstruction. You can even think about repairing a meniscus with augmentation procedures like refination. We'll come to that. So the meniscus gets its supply from the geniculate arteries, medial and lateral. Meniscus, you have to understand, has the function of stability. So a torn meniscus, as was described by the surgeons here, you shouldn't wait for another injury to happen. First injury, the patient may have a stable knee, slightly stable knee. The ligament may be only grade 2. Why? Because of the break stop action of the meniscus. The medial meniscus, posterior horn, lateral meniscus pushes the femoral condyle until they tear. So if the patient is allowed to do sports or run or jump or twist the knee, the meniscus is going to tear if the ACL is completely torn. So there is merit in getting the MRI done as ASAP. No point in waiting. In older MRIs, maybe the clarity wasn't that good, but 3T, the present MRI machines give us a very good view, especially if there is fluid inside. So day 0, or day 1, you can think about evaluating or finding out if there is a meniscus tear or an ACL tear. So the appropriate patient selection is important. Document the tear, look at the repairability, the geometry of the tear. Longitudinal tears are repairable. The radial, always assess if it's complex, think twice. Healing potential, biological manipulation, where is done. ACL reconstruction itself is a biological manipulation. Associated surgery, yes, the recovery time will be the same, so do both together. Preferred, patient preferred. Yes, long-term outcomes are good with meniscus repairs. Steps, you debride the tear, local synovial, meniscal and capsular ablation to stimulate proliferative response, suture placement to reduce and stabilize the meniscus tear. So tear pattern and repairability, longitudinal tears repairable, horizontal potentially repairable depending on the type of tear you have, radials, they are potentially repairable. Bucket handle tears are absolutely repairable as long as the ends are not torn off. Parrot beak tears or complex tears, you may not be able to repair, especially if the substance or the quality of the tissue is not good. So zone-wise, what are the repair techniques? The outside in for the anterior horn, inside out for the body, and all inside for the posterior horn is the dictum, but it's changing a bit with the newer developments that are coming in, so we'll come to that. So why 3 techniques? You're viewing from the anterolateral portal, and the needle can pass posteriorly, but it can injure the vascular structure. So posterior horn, you think about all inside repair devices where you take 2 punches and insert the anchors, and the thread which connects it compresses the meniscus tear. In the body part, again, you have the saphenous nerve there, but the needle passes there. You may have to make a safety incision or be careful about the nerve structure. It can be very nagging to the patient as well as for the surgeon if the nerve gets entrapped in a stitch, so you have to be careful there. You cannot go any further anteriorly because that stops there, so you cannot go any more medially. So is the reason for a outside in repair for the anterior horn of the menisci, whether it be lateral or medial. So that's a displaced bucket handle tear, quite fresh. You should be able to reduce it, and it should stay reduced when you take your probe off. That is when it's repairable, and that's involving the posterior horn body, not much into the anterior horn. That is where you think about, we already had discussions on pike resting, how to do the maneuvers and techniques to do that. That's the posterior horn, all inside repair. We have multiple devices, multiple companies, and the companies are all interested in how many use. I recently heard about a surgeon who used 34 such devices in one meniscus. So that'd be like killing the meniscus, but you have to be judicious in use, and the newer generation devices don't fail as the older generation ones, and it's quite simple. Vertical sutures are always stronger and more stable than horizontal stitches. Advantages: it's less invasive, no extra incision required, less risk of neurovascular injury, decreased operative time, hardly takes a minute for that repair. The braided sutures are less rigid and safer when they are contact than monofilament, more rigid suture like a PDS or something like that. And those are the studies which have come now. And 2-point fixation construct allows adjustable compression across the site, and you can tension it according to what is required. Disadvantages: the learning curve is high. You may lose a couple of devices, and they are very expensive. And anchor protrusion and soft tissue inflammation can happen if you don't adjust the length of the needle where you want to place them. If you go far more towards the skin, it can even catch the nerve there. Lower mechanical strength compared to the knotted devices maybe, and the expense is the main disadvantage. So that is an inside out repair where you have cannulas. You can either use a double cannula. I use a single cannula and a needle with the threads attached to them, which is very, very versatile, and you can place the anchor exact or the thread exactly where you want to be. And the first needle passes in, there is a thread attached, and the second puncture is made with the same cannula in a different place. And I use a smaller incision. I always use a suture retrieving device to go underneath, go up to the capsule, elevate it with an artery, and fish it out from there. That's the safety incision, which is safer to use, especially when you're starting meniscus repairs inside out. You protect the nerve and you are comfortable. Inside out meniscus repairs, the advantages are it has got the highest mechanical strength because the needle which goes in is only 1 millimeter or 1.1 millimeter, but the needle which goes for an all inside devices is around 2 or 1.8 millimeters, which makes a bigger hole, and the anchor has to go in. So this makes the smallest hole. You can park multiple sutures, and the cost is much less as well. Less traumatic. You can place multiple sutures. Its advantages are the neurovascular injury, and safety incision is often required. So that is an anterior horn repair where you have this multiple kits, or you can use a 18 gauge spinal needle as well. But the repair kits like the meniscus vendor has the loops and the lasso type loops which can come in to fish out the suture, or you can use a PDS to shuttle the suture. It's quite cheap, like 205 a wire cost, that's it. And there is no vascular or neurological injury concern here as well. And you can place quite well in the place, the area you want to place the thread with. And that's the shuttling. And you have to have the arthroscopic knots, the Duncan or whichever sliding knot you're comfortable with. Compress it and cut it off, as simple as that. That's an anterior horn repair outside in. So advantages are it's cheaper, no special device required, less risk of neurovascular injury. Disadvantages, suture shuttling and handling is required, but that's not a big deal for us arthroscopic surgeons. We've been doing multiples elsewhere as well. So arthroscopic knot tying is required. So the newer devices, they can bend up to 70 degrees. So even the anterior horn, if cost is not a concern and you want to go faster, you can even use the all inside devices, the air device, the fast fixes, the true span, and the fiber stitch. So that's a meniscus repair. That's like a zipper lesion. That's a lateral meniscus. This was done just 1 week back, actually 4 days back. My cousin's daughter, she's a basketball player and an engineer. So it was a complex type tear, but 22-year-old female with an ACL injury, lateral side, and we used. I wanted to preserve the popliteal hiatus. That's stitched with a meniscus scorpion. It's a beautiful device you should have when you're doing meniscus surgery. And the peripheral rent outside or posterior to the hiatus was repaired with an all-inside technique. So you have retained the meniscus. I didn't want to transfix the meniscus to the popliteus, which I feel has to slide. The meniscus scorpion is a beautiful device. Even the first pass mini is inferior to a scorpion in a meniscus because it's very flat and it won't injure the cartilage much. So radial repairs, again, the results are varied. You have to be careful, but the results are not bad when it's quite fresh and you use good repair techniques. These are the suture configurations you could have. The last one, the C, is the strongest configuration where you pass vertical sutures as a ripstop and horizontal compression sutures. These are the various suture configurations which can be used. And that's again a lateral meniscus radial tear. This guy had a ACL tear when he was 14 years of age. And the surgeon who saw him said that let him attain skeletal maturity. And that was the biggest blunder that the patient and the surgeon did. He went and played and he had a big osteochondral lesion on the medial femoral condyle. There was a parrot beak tear on the medial side, no alignment problems. Those are horizontal stitches which we placed, and we have repaired the radial tear of the lateral meniscus. So that's a root lesion. I'll just mention the method I do: 2 tunnels and repair over a disc, and this will be described better by Dr. IPS. 2 cinch loops and fixation there, and you get a good tight repair. So pearls and pitfalls, preparation of the tear is very essential. Enhancement techniques like debride, upgrade, or refine, that is multiple puncture holes on clots, can be used to augment the repair, reduce the tear accurately and maintain the reduction during fixation. Anchoring stitch or a spinal needle can help in maintaining the reduction. Hybrid techniques are always useful. You should play around and have a good mental 3D picture how you're going to arrange the fragments and repair. But meniscus is better repaired. Don't sacrifice the meniscus if there is an option to preserve it. Accessory portals improve fixation. Perpendicular placement, grab the circumferential fibers always to compress the inner edge may not be that strong. Rehabilitation, you protect the meniscus repair for 6 weeks, absolutely not non-weight bearing, and no active extension and flexion, because the muscles, when they contract, they pull the periphery of the meniscus back. So only passive movements up to 90 degrees allowed. So newer techniques, meniscus allografts, synthetic materials. So meniscus usually tears can happen during a ligament injury or in a lax knees when the meniscus tears. So the break stop mechanism should be in your mind. Repair techniques vary with the zone, and preservation is the key. Thank you.
Thank you, Sujit sir. Next, we'll welcome Dr. IPS Oberoi for his talk on meniscal root and ramp repair.
Thank you. Yeah, that's okay. That's okay. Yeah, so we come to the hidden areas of the knee or hidden lesions of the knee. These are the root and the ramp lesions. I think these were understood very late in our arthroscopy practice. Initially, we always missed the root and the ramp lesions. So what is the ramp lesion? A ramp lesion essentially is a meniscocapsular detachment in the posterior horn of medial meniscus, and it is pretty commonly seen in ACL deficient knees. Up to 17% in ACL deficient knees, especially chronic ACL deficient knee, you do have a ramp lesion in the back of the knee. Whenever the ACL knee has a ramp lesion, there is always more pressure on the ACL graft if you don't do a ramp repair. And also it is important that when you have a chronic ACL knee, there is always a pressure on the medial meniscus resulting in ramp lesion. So it is either way. If you have a ramp tear, you will have a lax graft. If you have a chronic ACL deficient, you might have a ramp lesion. Diagnosing a ramp lesion is difficult because of the simple reason that we do an MRI to diagnose a ramp lesion. And because MRI is done in extension, the ramp is reduced and you may actually miss the ramp lesion. So sensitivity is between 0 and 77% because in full extension, the meniscocapsular separation is reduced. So to diagnose it, you always have to do what is called as an intercondylar notch view or a Gilchrist view. You have to take your telescope between the femoral condyle and the PCL to the back of the knee, and here you see a lesion in the back of the knee. So that's a peripheral capsular lesion in the medial meniscus, especially this is called as a ramp tear. So always when you do have a doubt in a chronic ACL deficient knee, always do what is called as a Gilchrist maneuver where you take the scope behind and see for the ramp tear. We also do sometimes what is called as a needling test, which is making a posterior medial portal. So you make a posterior medial portal, put a needle or a spinal needle, make a small stab incision, use a probe to palpate the posterior meniscocapsular area, and that is a lesion there in the back of the knee. That's a ramp lesion. So ramp lesions are practically common, especially in chronic ACL deficiencies. When you have a small ramp tear, all you need to do is just debride it off. There are vascular areas, it heals very well. A small ramp tear without gross excursion, which is stable up to 1.5 centimeters, heals well with just refining. But when ramp tear becomes up to 2 centimeters, when it is actually moving anterior and posterior, which is an unstable ramp tear, you would actually need to do a ramp repair. To do this kind of ramp repair, our telescope is gone through the Gilchrist view in the back, in the posterior medial area. That is the capsular part of the ramp tear, that is the meniscal part of the ramp tear. Always it happens that the capsular parts tends to fall down. So you have to lift it up with help of a curved suture passing device. So there are lassos which are called ramp lassos. You can go down, lift the posterior capsular part of the up, and then take the second bite onto the meniscal part. So you actually lift the capsular part, come to the meniscal part, so you are able to pass a suture in between and then tie a knot on towards the capsular side. So this is a suture which has been passed. You tie a knot towards the capsular side so that you are able to reduce the ramp tear. Sometimes the ramp tear is big. You may need more than one stitches. So one stitch and then another one stitch, and then you are able to repair the ramp in this manner. So that's the second ramp. Stitch and you tie the knot towards the capsular side with knee at around 90 degrees of flexion. So that's a ramp repair which has been done. We see patients sometimes when the ramp tear is very extensive, very big tear, and just repairing it, seeing from the front and working from the behind might not be possible. And in those cases, we have to actually shift our telescope to the back of the knee, which is posterior lateral portal. So we have made a low posterior medial portal, and then we make a high posterior medial portal. And that is a ramp tear which is down. It's a large ramp tear. To repair this ramp tear, which is extending right from the capsular area all the way towards the medial side, you should have two medial portals, a high and a low. And our telescope is shifted from the front also to the back, creating a transseptal view. So I'm shifting my scope to the back. See how big the ramp tear is. And now we have two portals on the medial side. The lower portal essentially is to pass the suture, and upper portal is for suture management. I'm looking from the lateral portal in the back of the knee. So it's a completely posterior arthroscopy of the knee. You are passing a shuttle going up, suture goes into the high posterior medial portal. Then you again pass a shuttle from the low posterior medial portal. That's a second stitch, go up, and all the time your telescope is in the back of the knee. So scope is in the back of the knee on the posterior lateral side. Suture management and suture passage is from the posterior medial low and posterior medial high portal. So three portals, two on the medial side, one on the lateral side, and one by one you start passing sutures. So this is done when the tear is very large, very extensive, and you just can't repair it from the front. So these are three sutures one by one, and each time you tie a knot towards the capsular side, starting it from the lateral side going medially. So that's the scope in the back of the knee in the posterior lateral part. That's the first knot onto the capsular side, cut it, go to inside, second knot on the capsular side, and then cut it, and then the third. So this is how an extensive ramp tear can be repaired. If you have an extensive ramp tear, you have to actually shift your scope to the posterior lateral portal to see, and then you have two working portals in the back to repair it. So ramp tears are pretty common, and you should not neglect these ramp tears. Surgical tips essentially are placing the sutures every centimeter between. These are simple vertical mattress sutures. As I told you, start working from the medial to the lateral side and tie the sutures in mid flexion, and knot is always on the capsular side. Important point is when you make a posterior medial portal, and I think Dr. Sundararajan also showed you, there is a saphenous nerve and a vein. So transillumination will help you in making a posterior medial portal. And when you do a ramp repair, always brace these patients, limit their weight bearing to 50% and motion till 90 degrees for 6 weeks or so. By 6 weeks, they heal pretty well. So in final protocol, if you have a small tear, which is up to 1.5 centimeters, which is not moving too much, which is stable, just debride with shaver and refine it. If you have a moderate size tear up to 2 centimeters, which is excursion with grossly and unstable, you can go cross notch, Gilchrist view, and do one posterior medial portal and do an all inside repair. But when you have a very large tear up to 2 centimeters or more, which is unstable, the view is called transseptal view, where you put your telescope in the posterior lateral portal, and on the medial side you do have two portals and you do an all inside repair. Always brace these ramp tears, protect it in the post-operative period. These are important lesions. You should not miss the ramp tears, because whenever ramp tears are there, it puts excessive load on the ACL and ACL may become loose. The other important hidden lesion are root tears. I think root tears are also very, very important. You do have a medial root and a lateral root. Most commonly root tears are the medial roots, which are degenerative tears. With an ACL, we commonly find a lateral root tears, which are also commonly seen. The two roots are important because they actually create hoop stresses, and they actually make the meniscus sit nicely on the tibial condyle. Whenever a root is torn, the meniscus tend to extrude out of the joint. And that is why a tear which has got a root tear actually behaves like a meniscectomy and the meniscal hoop stresses are gone, which leads to compressive forces and early arthritis in the knee joint. So kinematically speaking, as I told you, when you have a root which is torn, it actually behaves something like a total meniscectomy. And so it's important to identify a root and repair it. Now, how to define a root tear on an MRI? When you have a sag view, normally inside in front of the PCL, you always find a meniscal root right anterior to the PCL. And when it is missing, this is called as ghost sign. So when you have a PCL, you don't find an anterior root here on the PCL, in the front in the meniscus. This is called as ghost sign. That's an indicator of a root tear. Also on an AP view, when the meniscus is extruded out under the medial collateral ligament like this, these are high suspicion patient when root might have torn, leading to meniscus exclusion. So when you see a meniscus extrusion or a ghost sign, always suspect a root tear in such patients. I think repair of the root is important. As we told you that root repair is important. That's a cadaveric demonstration of a root repair. You go on and into the Gilchrist portal and see that there is a root tear here, and that's a root which is unstable. All you need to do is take bites into the root, create a tunnel or a socket, and pull the sutures of the root into the socket going down back. What is important is to identify whether the root tear is degenerate or a traumatic tear. Traumatic tear, you are able to take bites nicely. The tissue quality is good. But when you do have a degenerative tear, the quality is really very bad and the repair does fail almost all of the time. So it has to be traumatic root tear rather than a regenerative root tear. There are special zigs which are available with different companies, which are giving you anatomical reconstruction of the root, exactly the point from where the root should be there. So this is going over the top, and there are markings here which will guide you exactly where the root is going to come. So this is how a wire is coming. It's something like a zig, which is like an ACL zig, but it's a root zig. And here you are going to use a small reamer called as retro reamer, from where you can go in and make a small socket inside the knee joint. So from the midline, we go around 30 degrees or so. But whenever we are doing an ACL along with root repair, you can move this root zig medial or lateral to see that both the tunnels don't come close to each other. Once zig is in place, you hammer this and then slowly pass your retro reamer so that it exits right under the root here. So retro reamer creates a socket. We usually use between 5 or 6 millimeter retro reamer, and it goes inside like this. So it's a flip cutter, and it is going to go inside. We're going to drill it in, and it goes under the root gate. The advantage of root zig is you can then remove the root zig like this on the side, and you can able to see where exactly your retro reamer is going to come out onto the tibia. So it comes out here. You will flip it and then do a small retro reaming to create a small socket. So we do a retro reaming to create a small socket. Once the socket is made, you can pass in a suture into the socket so that you are able to, that will be a pulling suture. So you unlock the retro reamer, take it out, clean the tunnel, and then through this you pass a beath wire with a suture which can be loaded, or a shuttle relay which can be loaded, and you can take it out from the anteromedial portal. So you already have a socket and a small tunnel which has been made. Now next step is taking a bite into the root. So this shuttle is taken out with help of either a grasper or with the help of a probe. So we take with a probe, we take this shuttle out, and then you have to take the bite into the root. So there are anti-grade suture passing devices, something like a knee scorpion, which will help us in taking the bite into the root. Pike crusting does help us in opening the root area, and this will be very helpful for us to see and take a bite. We always pass a small cannula, something which is called as passport cannula, which will help us in moving our instrument in and out. So that's a scorpion, which is a knee scorpion, and it's got a suture with a loop. So we'll go with a single bite inside. So we have loaded the knee scorpion on the scorpion needle. It's a small diameter scorpion, so it does not bother much when we do an arthroscopic procedure. The shoulder scorpion is a larger one. It is going to hit it. So this has got a loop, and we have loaded it onto the scorpion. And that's how we take the scorpion inside the passport cannula. Go towards the root take a bite into the root, and create a luggage tag configuration or a suture snare. So we take a bite, the needle exits out. You have to be very sure that the needle doesn't hit the articular cartilage. And then when you are going to pull it, it goes into the loop and creates a snare. Once snare has been pulled out, you can use one more suture in addition, because one is usually not enough. In a degenerate condition, you might need to put 2 or 3 of these luggage tag sutures like this. And as you're going to pull it, that's a second snare. So it creates a nice snare. The cutout of the snare is not, it's very good. It does not cut out like that. And then you're going to take maybe another one, 2 or 3 bites. I think 2 or 3 bites are usually good enough. And these 3 bites are going to hold the root nicely. And because these are thin sutures, these are 2, 0 or number 0 sutures, you have to put at least 3 of these sutures into the root. And now all of these 3 are shuttled into the shuttle relay, which we have already passed, and is pulled down on towards the tibial side. So we pass all these into the loop of the shuttle relay, all the 6 sutures, because these are snares, into the relay, and we are going to pull it out through a tibial tunnel. So this is how, as we pull it out, all these sutures go in, and this is how the root is going to come out and sit nicely onto the rough part of the bone. So that's how a root, and finally you can actually stitch it here on a button or a post. So to conclude, root lesions are also very, very common. They are often traumatic with an ACL deficient. Atraumatic are commonly seen in arthritic knees. You should have a high index of suspicion, especially reading an MRI, and arthroscopy will help. Operate when the root is not degenerated. I think that is important. You will see root tears very often. Don't operate if it is a degenerative tear. If there is a medial varus, just repairing the root is not enough. You might need to add on unloaded osteotomy. So root tears and ram tears are very common. These are hidden lesions which you would know, you would like to see, because I only see what mind knows. Thank you very much.
Thank you, Dr. IPS. Are there some quick questions to Dr. Sujit Jose and Dr. IPS Oberoi? When you establish posteromedial and posterolateral portals as posterior-posterior triangulation, you establish posterolateral portal first or posteromedial portal first?
So posteromedial portal first.
And then?
So through Gilchrist view, we make our posteromedial portal, and then finally shift to the posterolateral and then to the high posterior.
So you put your scope in laterally, see the light and put the incision?
Yes, a small needle first, then a small stab incision, and then a mosquito, and then open it up.
Okay.
Trans-illumination helps us in avoiding neurovascular injuries.
Regarding the root repair, Lateral describes 2 tunnels, small tunnels, and tying over the bone bridge. Is it a single tunnel enough or 2 tunnels?
So I usually do a single tunnel because it's a 4.5 millimeter tunnel, and I usually use either a small root repair button or a post, like Sundar was showing, a post fixation. So I don't use 2 tunnels. Our tibias are very small, and especially when you're doing a root repair along with an ACL reconstruction, there's hardly any space to do two tunnels and an ACL tunnel as well.
You use a fiber wire or fiber tape for the root repair?
So initially we used to use fiber wires, now we use tapes.
If it's grossly extruded, you do any centralization along with root?
I've not done too many centralization. The knee joint has to be really healthy so that you are able to put your meniscus back. So when we see the root is reducible, we just do a root repair. But if the extrusion is too much, more than 3 millimeter on an MRI, then we put a centralization stitch. I don't use anchor. I just make a small tunnel, take a bite and just pull it down. So it's a centralization stitch. So it does not allow the root to again fail.
In a degenerative meniscal tear with a slight varus knee, whether need to do repair also or just HTO is enough?
So there is a lot of controversy regarding that. But I think when you're doing an HTO, you as well go ahead and repair the root. Just doing an HTO and leaving the root doesn't make sense unless and until it's too degenerate. If you think you can repair it, we do have HTO plates where you can actually repair the root as well. So if it is repairable, repair the root and add an HTO to unload it. But if it is totally degenerate, just do an HTO and leave it like that.
My question is to Dr. Oberoi. It is an addendum to Sameer's question. So in case of a concomitant medial meniscus posterior root repair along with an HTO, open wedge, then what will be the sequence?
So I mean, like ACL, I always make a tunnel first I see that the root is repairable or not, pass in suture, make a tunnel, then keep a small reamer inside, and then start my procedure regarding osteotomy. Yeah.
In how many degrees of flexion you tighten these root repair tags?
Around 20 degrees or so.
Why is it so?
I mean, like ACL, we always tie it around 20 degrees or 30 degrees, not deep flexion.
So, sir, you use any fibrin clots or PRP in your meniscal repairs? Is there any recommendation for that?
There are people who use it, but my experience is almost zero with fibrin clot. But PRP, yes, I've used for many. I don't know how it works. There is no level 2 or level 1 evidence, only level 3. So possibly post-operatively, you could give after 3 weeks or 4 weeks. That's what I practice, not regular.
And safety incision you use for all inside out, or?
I don't use a safety incision. I use a small incision, and actually I'm in. Yeah, what I do is you have to be careful. I've never burned my hand yet. I'm publishing a series now. We are in the process of doing that, of a mini incision, and you have to go all the way up to the capsule. You make a skin incision and you dilate and go to the capsule, suture retriever to retrieve out. So even bucket handles we do like that. So we can elevate it. We have a small retractor that we use, or a hook we use for the carpal tunnel. We use that to lift it up, and up to the capsule we can open and we can pull out sutures from all directions. So even 3-4 sutures we pull out to the same incision. So a small nick is enough. So we are in the process of getting that done now.
In chronic root tear, where there is a severe extrusion of the meniscus, a root repair will not bring it back. You cannot centralize it. Even if you put an anchor, it will not come. Is there any trick of releasing meniscocapsular cicatrix? There is something, a contraction between the meniscus and the capsule.
Yeah, so there are 2 techniques to do it. When you have a root which is extruded, and the meniscus which is extruded, you can do a meniscotibial release, which is under the meniscus, so it starts floating, and then you do a meniscocapsular release, so which is actually creating a ramp kind of lesion. So you do a meniscocapsular release, and then you can centralize it. But again, you do it when the knee is not degenerate. When there is extrusion, you are able to reduce it, but you find that centralization stitch and the meniscus root will put a lot of pressure, then do these releases.
Along with alignment correction.
Along with alignment.
Can I ask a question there? What is your threshold of doing an HTO with a root repair when the patient is having a physiological varus, not much of cartilage loss there, maybe a grade 1 or grade 2 change, but you're doing a root repair, you want to offload it. Do you offload it that often?
No, I think anything more than 5 degrees excess to the physiological varus is something where we would. HTO is a big osteotomy surgery. I mean, you have to really take it very with pinch of salt. So normal varus plus 5 degrees is the.
So, sir, what is your take on the morning live surgery case? Because there was a root tear. So, would you recommend doing an unloaded morning live surgery case?
Mine. Yes. No, I think that kid, I don't know. There was root tear, but the meniscus was actually gone. So the whole root was broken, and then there was an absolute
gap.
So I don't know prophylactic HTO. I'm not really sure about it. He's 45-year-old. We have seen patients with physiological varus with partial meniscectomy done and ACL reconstruction. They actually,
but this
unloading would not help it.
But this will be exactly like a total meniscectomy. It will behave like a total meniscectomy.
It is actually behaving like a total meniscectomy. So I don't know whether HTO itself is going to help it or not. Because there is no meniscus, which hoop stresses are still not going to get restored.
Okay. So, but it's unloading the middle compartment.
Yeah. So right now the degeneration was very limited. Obviously, you're not going to do it. You're going to watch these patients. Maybe 4 year, 5 year down the line, if he starts showing any arthritic changes, you can unload it. But not at 45.
Not with if the scanner shows there is more than 5 degree excess over and above the physiological varus. Even if the knee is not arthritic at this point of time, it is recommended.
So that is why in our protocols and every time we have been talking about it, in all ACL reconstruction, whenever a chronic ACL tear comes to us, if you suspect, you always do a scanogram.
So the ACL, Anwar, ACL, the problem is the patient comes with instability, not for the pain. So because you think that osteoarthritis will develop after 10 years, we no need to do any osteotomy. But the root repair scenario is totally different because root tear is because of the degeneration. You know that is the starting point of the osteoarthritis. We see many patients with the root tear with absolute normal cartilage. They are the starting point of the arthritis. That means this is a process of osteoarthritis. In that cases, then we are worried about the varus. If it goes for more than 5 degrees, If it is a grade 1 and 2, then we do an osteotomy. But ACL, the patient comes for just instability, his cartilage absolutely fine. He may take 10 years to 15 years to develop an arthritis. Then at that time, we can try on offloading or this osteotomy or that treatment for that purpose. So history is not concerned for about his pain now. He comes for just instability, so you address that problem. Later on, we explain. You have done an underwent meniscectomy, you may get arthritis in the future. Then future you may need an osteotomy.
Thank you, Dr. Sundar. We are already crossed the time limits. Thank you for the speakers for the excellent presentations. Thanks to organizers for
Now we move on to the next session. Next session will be chaired by Dr. Janice MC and Dr. Rajneesh R, Senior Consultant Orthopedic Surgeon, Baby Memorial Hospital. I invite you, sirs. Next topic is based on arthroscopic PCL reconstruction, PCL avulsion fixation. I invite Dr. Sandeep Barberaris on stage.
Dr. Hassel. Dr. Sandeep is not here, I suppose. Okay, okay. So next talk will be by Dr. Hassel, approach to multi-ligament injuries. Welcome to you, sir.
Good afternoon, everybody. So, I'm left with a topic which is decision making rather than approach in multi-ligament injuries of the knee. So this is one of Argentinian soccer player. So this is for all our football players. So this is how normally multi-ligament knee injury happens. These are considered low velocity injuries, but the issues in multi-ligament injury, when we are about to take a decision, these are the dilemmas that we normally come across. Whether to operate or go with the conservative management. Whether the early or a delayed surgery is recommended. What about doing it in single stage or staged? Open versus arthroscopic. And what are the situations, scenarios when we have to do repair, where reconstruction is preferred, and when to do realignments. The basic dictum is all multi-ligament injuries are not knee dislocations. It can be the other way. So, few statistics, knee dislocations, approximately 0.2% of all orthopedic injuries. It can be an open or a closed injury. Management is different in both. And spontaneous reduction happens in 20 to 50% cases. And this is very, very important as this may lead to a missed diagnosis. Associated injuries are very common, up to 44%. Bilateral knee dislocations are extremely rare. So as I told you, even the sports injuries are considered low velocities, and only the high velocity injuries are motor vehicle accidents and fall from heights. So sports, trampoline jumps, martial arts, missing steps are the other modes of injury. And in ultra low velocities, it's mostly seen in morbidly obese individuals following a slip and fall. So this is one classification which just takes into account the mechanism of injury and the direction of dislocation. Doesn't help us much in the long-term management except for the immediate reduction of knee dislocations. So it can be anterior, posterior, medial dislocation, lateral dislocation, or rotatory, depending upon the mechanism of injury and the amount of or the different structures that can be damaged. So the one which has got an anterior dislocation, you do give a traction and elevation of the distal femur to reduce this. And when there is a posterior dislocation, give a traction and extension of the proximal tibia. And when you have a translatory dislocation, you give traction and respective translation as required. And when there is a rotatory component involved, you do traction and give derotation. And once you do the closed reduction, immobilize the patient. And if it is highly unstable, do a external fixator as well. as Dr. Sundarajan sir was clearly mentioning about protecting the vascular structures, whenever you do reduction, avoid force against popliteal fossa. This is the classification which we all need to understand and we need to follow. This is a shunt classification. 5 types: KD1, KD2, KD3, 4 and 5. KD1, for easy remembrance, multi-ligament is defined as anything 2 or more injuries. So KD1 is either one of the cruciate and one collateral. When it is bicruciate, means 2 ligament involved, it is KD2. KD3 is both the cruciates and one of the collaterals. So 3 ligament involved. KD4, it is pan ligament, both cruciates and both collaterals. KD5, when it is associated with periarticular fractures. In KD3, when both the cruciates are involved and one of the collaterals, so it can be KD3M if it is the medial side injury. It can be KD3L if it is a lateral sided injury. When it is associated with neurovascular injury, it can be KD3MN like that, or KD3LN. If it is associated with vascular as well, it is labeled as KD3C like that. So since its associated injuries are very common, you need to have a look at this, the basic A, B, C, D and E. So once you are done with it, from an orthopedic perspective, you see whether it's an open injury or a closed injury, whether it is reducible or irreducible. Associated neurovascular injury, you have to document it before and after the reduction. So this is the most important thing when you deal with multi-ligament and knee dislocation, the ankle brachial index. So there are some hard vascular signs, some soft vascular signs. Hard is when you are dealing with pulselessness, motile or cool limb, when there is associated popliteal hemorrhage or popliteal hematoma with thrill and bruit. So if it is there, there is no doubt you have to have a vascular intervention immediately, and once it's done. Or if your patient is having only soft vascular signs, that is asymmetric pulses, paresthesias, or peroneal nerve symptoms. If it is there, you have to get a CT angiogram or an arteriography immediately. Or if you are doubtful on this, get the ABI done. If your ABI is more than 0.9, that means it is normal. You can observe the patient for 24 hours and the pulse needs to be checked and documented every 2 to 3 hours. If the ABI is less than 0.9, that means it is not normal. You have to have a CT angio or arteriograph. So we all know this, the highest of the systolic pressure is taken into account. Highest of the ankle pressure divided by highest arm pressure. If it is more than 0.9, it is normal. Less than 0.9, be worried, get the CT angiogram done. So this is about the acute knee dislocation or multiple ligament injuries. Once you are done with the clinical evaluation, reduction, if it is presented in front of you without a spontaneous reduction, do a detailed radiological evaluation, immediate MRI and vascular studies. And the emergency treatment is, if it is an irreducible knee dislocation, go for open reduction, collateral ligament and capsular repair. If it is open knee, do the debridement lavage along with collaterals and capsular repair. Get the soft tissue cover and protect it and X-fix. If it is associated with a vascular deficit, get the intervention from the vascular consultant, do the vascular repair. If possible and time allows, do the emergency collateral or capsular repair and protect in an X-fix compartment. If it is associated, give importance to that, get the release done. Extremely unstable, always protect, reduce and protect in an X-fix. Unstable or unstable fractures associated, do an open reduction, internal fixation of the associated fractures. So when you come across irreducible knee dislocations, which are quite rare, but it can be possible because of the interposition of the soft tissue structures into the medial compartment or the intercondylar notch. It can be your MCL as shown here. It can be an entrapped bucket handle piece of meniscus, or it can be an interposed vastus medialis obliquus, capsules, etc. Once you are done with this, do go for a secondary survey. We are all masters in it. So we do a good Latchman, pivot shift, posterior drawer, valgus varus stress test, dial test, reverse pivot and common peroneal. Once you see the dimple sign, which we saw in the morning case, they have demonstrated that when there is an incarcerated medial structure, if a Latchman is more than 3 mm, indicates anterior stability very well. then if there is a gross pivot shift or an explosive pivot shift, which we have already discussed, in that case, be watchful for root, ramp, PLC, MCL, or an increased slope, especially more than 12 degrees of posterior slope. You have to do the imaging X-rays, especially stress X-rays, CT angio, and USG Doppler. So about coming to the management, whether you can conserve or do operate in every case. All ML case doesn't require. With the permission of the chair, I'm going to overshoot a bit. Okay, this for among the conservative management prior to 1990, cast application was common. Late 1980s, the popularity of surgical management increased. Stiffness was common in almost all cases of conservatively managed patients. So that's how you do the conservative management. So it's about in low demand patient, when there is no much laxity and the MRI doesn't show much bony changes, the bone marrow edemas. There are cases where you can negate the gravity induced changes when you can give a PCL brace and do a good rehabilitation. And what does the study say about non-operative and operative? There was 132 surgically operated cases versus 74 non-operative. In all the studies, it has improved outcome with surgical treatment. If you compare the IKDC pattern, it was 58 versus 38. Return to work was 72% in surgically operated cases. Return to sports was 29%, which was quite less in non-operative group. So arthroscopic versus open. No doubt about this. It's all about historical importance. All cruciates are only arthroscopic nowadays, and collaterals open, or even the PLC now. There is a recent trend towards arthroscopic correction of the PLCs. So the only point is arthroscopic definitely is associated with less pain, but the study shows similar results in open, similar operation time, but increased pain with open techniques. Whenever we talk about early and delayed intervention, it's about acute and chronic. The time frame is less than 3 weeks is acute. Anything more than 3 is considered as delayed or chronic. So in less than 3 weeks, you have less soft tissue scarring, better tissue quality for you to do repair, or you consider augmented repair. And alignment is never considered an issue when it is less than 3 weeks. More than 3 weeks, tissues are relatively compromised, difficult to repair, and you need to consider alignment as a separate aspect. So early intervention versus late intervention. The early surgery of multi-ligament knee injuries may yield better results than delayed surgery. So whenever you intervene when less than 4 weeks, Lysholm scores are far better, and return to sports, return to normal, especially is much better in early intervened cases. When you deal with collaterals or the posterolateral corner, whenever you come across avulsion or peel off kind of injury, repair is a possible option. And when you come across mid-substance tear, repair plus augmentation in less than 3 weeks. More than 3 weeks, always consider reconstruction. So now coming to all KDs in different aspects. KD1, when there is either one of the cruciate or either collateral, do single stage ACL reconstruction or PCL, whichever is damaged, and do an MCL repair or augmentation, or repair with augmentation with PLC repair or reconstruction in a single stage. In KD2, that is bicruciate, 2 options, single stage and stage 1. So about this ACL, PCL simultaneous, we have just seen a beautiful demonstration by Sundarajan sir. And if you're planning staged, you can do PCL first and late ACL reconstruction after 3 months. When you're seeing KD3M, in one stage, you can consider doing altogether ACL, PCL reconstruction. If it is less than 3 weeks, consider MCL repair. And the advantage is you can start early rehab in a hinge brace. If you are planning 2-staged in KD3, you can do ACL, PCL single stage, and then add on late MCL reconstruction if there is persistent medial instability. If it's primarily a medial sided instability, you can do PCL plus MCL and then late ACL, depending upon your and your surgical team's expertise and the time constraints. Similarly, in KD3L, the lateral structures are damaged. Single stage, you do ACL, PCL, and PLC together. When PCL is tensioned, because in multi-ligament, mostly we do single bundle PCL, and the PCL is tensioned at 90 degree. PLC tension in mild varus with internal rotation, ACL tension in full extension. And if you are doing staged in KD3L, then do PCL and PLC first, late reconstruction of ACL after 3 months. Pan ligament, KD4, single stage ACL, PLC plus ACL with MCL repair or augmentation. If you are planning 2-staged, PCL plus PLC plus MCL and a delayed ACL. Another option for if you are planning stage is PCL, PLC first, ACL, MCL and second stage after 3 months. So what are the preferred graft choices? For PCL, it's a CQT, BPT or peroneal. For ACL, you can use all the 3 options. PLC, the preferred one is hamstrings. MCL also the preferred choice of hamstring. Different tensioning patterns. MCL is done in 30 to 60 degrees of flexion. The point that we take into account is where it gives a maximum length and best against mild varus force. LCL against a mild valgus force. LCL is done, the tensioning is done at around 20 to 30 degree flexion. PCL, predominantly anterolateral bundle, when it is done at 90 degrees of flexion. And a posteromedial bundle, if you are doing a double bundle PCL reconstruction, is done at 30 degrees of flexion. ACL at 30 degree, or if in a multi-ligament pattern, it can be done in a full extension as well. So very important, the important part is you need to know what all are the tunnels coming on the lateral femoral condyle, what all tunnels coming in the medial femoral condyle. So especially you need to know that the FCL tunnel and the popliteus tendon is directed 40 degrees anteriorly and the ACL goes in a posterior direction so that the tunnel should never converge. So whenever on the medial side, you should be more careful if you are planning for superficial MCL and POL as different tunnels and then going for ACL tunnel. So the superficial MCL and the POL goes anteriorly. MCL goes 40 degree anteriorly and POL should go 20 degree anteriorly. And your PCL anterolateral bundle and PCL posteromedial bundle should be directed posterior. Similarly, there are 5 tunnel options in the tibia. You need to know where the superficial MCL comes proximally and superficial MCL distally. It's around 7 mm distally. ACL, your conventional tunnel. PCL, little posteriorly. If you are following a Lapre technique, where should the posterolateral tunnel should come around? And then you should have an understanding about the meniscotibial ligament as well. So that's the chronological order of the last few slides. The chronological order of tensioning. You need to do the central pivot mechanism is based on the PCL. So you need to tension the PCL first, then PLC, then ACL, and finally your MCL. So regarding reconstruction and repair, it's all about PCL repair has got 100% failure rate. You can only have the option of PCL reconstruction. On the medial side, repair versus reconstruction. Repair 20% failure rate, reconstruction 96% success. Stage versus single event surgery, 92% success when you do it in a single stage versus 62% staged. Similarly, when you come across bony abnormality of a sagittal plane deformity or a coronal plane deformity, you need to get the bony correction as well, especially when you deal with a neglected multi-ligament injury associated with malalignment. So when you plan surgery for a delayed multi-ligament, you need to take care of the situations where you come across. There are, at least in patients, we are more prone to DVT, where we follow the Wells et al. Criteria. So alignment, if it is normal, straight away go with cruciate to collateral reconstruction. If it is abnormal, do a coronal and sagittal correction. Once the realignment is done, then go to the collateral and cruciate reconstruction. So regarding slope, if you come across a PCL, a chronic PCL deficiency, increase the slope. A chronic ACL deficiency, you have to decrease the slope. So every 10 degree increase in tibial slope gets the anterior tibial translation by 6 millimeter. So when you come across a difficult scenario where the knee is going to be stiff after a delayed presentation of multi-ligament, if it is associated with fixed posterior subluxation, if there is no fixed posterior subluxation, correct the alignment and go with ligament reconstruction. If there is a fixed posterior subluxation, when there is a delayed presentation, correct the subluxation, get the tibia underneath the femur, achieve good range of motion, and then only proceed to correction and reconstruction. If the knee is stiff, then do an open or an arthroscopic adhesive lysis, especially the posterior capsular release, get the tibia anteriorly underneath the femur. Then, if there is posterior subluxation, correct it and then do alignments, correction, and the ligament reconstruction. Just a small word, this is my conclusion slide, in different chronic knee subluxations. And when you rehab, just one point, if you do repair, protect it, go slow. If you do reconstruction, you can go little early and fast with your rehabilitation. Whenever there is repair plus augmentation, that also you have to have aggressive rehabilitation. And if you are going with a stage procedure where you have already achieved range of motion, you can slow your rehabilitation. Sorry for overshooting. It's such a big topic. I hope I've reasonably covered the basic points. Thank you so much.
Well done, Dr. Hassel. It's a very good talk, extensive about it. But can I ask you a question about the new classification? Because the Schenck classification was there in 1992.
Okay.
The main problem was that the patellar tendon was not included. So a new classification has come up by Ganga.
Yeah.
Where they have included patellar tendon and the chronological order in which how it should be repaired.
Okay.
So that may be a little bit advanced. So sir may be talking about it most probably.
Yeah. It's a panel discussion which is coming on multi-ligament. How we can classify it better. But this is how we take it for the communication purpose, which all ligaments have been damaged in that particular case.
Okay. Any questions from the audience? This may be discussed with the panel. Okay, right. As time is short, let's...
Just one question. If you have a multi-ligament knee with collaterals gone, with the ACL, PCL, you will always go only collaterals initially, or you will PCL with collaterals? How's the...
Single stage is preferred if the knee is not angry. There is adequate soft tissue. This thing is okay. Go ahead with a single stage surgery with collaterals plus cruciate.
Like the previous case that we have done, no?
ACL, PCL together.
No. I'm asking, suppose in the day one, that case, that had an MCL peel off along with ACL and PCL.
Okay.
So if it was done on day one, is it advisable to do a PCL along with MCL?
That's how the literature says single stage gives you better results. The problem is about the time constraint. If you can finish off in a 2-nicket time, if you are yourself, your team, your theater is well experienced and get to do all the ligaments, even if it's a 4 ligament reconstruction, literature says you can do that and you can go aggressive on your rehab as well. And that should be the first choice.
Okay.
If not, collaterals first and then reconstruction.
One of the problem is during the first few days is the fluid extravasations. We had seen it tried on PCL, within 10 minutes I found that calf is swollen. And I abandoned doing a dry scopy and completed. That is one of the problems, especially when you go to the posterior part of the knee, the initial within 10 days.
Because PCL is the main pivot. Because if you don't repair, there is high chance that it will sag and your collaterals may again sag.
Correct.
That's what I was asking. Thank you.
Thank you, sir. Now I invite the panelists, Dr. Shanavas KP, Professor Gopinathan, Dr. IPS Oberoi, and Dr. Sujit Jose to join on stage, please.
I know it is difficult for Hasil to finish multi-ligament injury in 10 minutes. This is okay. Last week I was in Bhubaneswar. I was to talk in 6 minutes for the multi-ligament injury, but I spoke for only 6 minutes. But anyway, just I talked about the only concepts. It's not impossible for finishing in 15 minutes also. I mean, it's very difficult to understand everything. The multi-ligament injury, because it's a big subject, so it's not easy to finish. I was told to do it's a PCL and multi-ligament injury. When Basir spoke to me, he told both PCL and multi-ligament injury. So I thought 1 or 2 cases of PCL, then we'll go with the multi-ligament injury. I think just we'll go with just concepts. It's a 22-year-old male, businessman, history of injury, road traffic accident. I think we know all of you that road traffic accident is the one of the dashboard injury caused the PCL injury. So this patient presented with painful, restricted movements. That is the X-ray normal is normal. That is the common scenario which you see. This patient had a PCL tear. It's a mid-substance tear. So I'm not talking about the other thing. So how will you proceed? Anybody will do a conserve or anybody will operate? Just quick answer, because I know all of you know the answer, but just for the.
Even on the X-ray, the TBS is anteriorly translated, so there is an ACL injury as well. Okay. So ACL and PCL. So I would like to see the other images, the coronal axis.
Yeah, ACL was not completely torn. Okay. Sorry, I was putting only the PCL image here. That's not completely torn. So think about it, it was only a PCL mid-substance tear.
So do a stress test, see how much subluxation is happening, and then decide. I mean, if it is grade 3, then operate.
Yes, same. Stress views is subluxating. You have to go reconstruct.
It's only a 2 weeks time.
2 weeks time.
Yeah.
No issue. Pain is subsided.
Meniscus.
Meniscus is normal, except some you can see this some
condition, signal
changes. That is a degenerative changes. It's not a trauma. That is not a big tear or something like that.
I will take this as isolated PCL.
Yes,
injury.
that's isolated PCL mid-substance tear.
Okay. Then when the knee is calm, then you reconstruct.
So the problem is to conserve or operate. That is the problem. So even in a isolated PCL injury, of course, before, as he said, that everybody has to be reassessed again. So only the mid-substance tear, probably we can think about a conservative management. That's what this case is about. I'm not talking too much about this. So isolated PCL injuries is still possible. It's around 20 to 40% in the literature. And PCL laxity allows the tibia and meniscus to sit posteriorly. That's why there is very less damage to the menisci. So not like ACL. So when you have isolated PCL, you will not have much meniscal injury. So you don't need to worry about that when there is a meniscal about the PCL. And PCL will not give a rotational instability. We know that it's a unidirectional, especially when it's also isolated PCL. We are talking about only isolated PCL. There is no rotational instability. So these cases can be treated sometimes conservatively. There is literature also had shown that this is one of the paper which was published in Arthroscopy, where they published 38 patients with grade 1 to 2 injuries.
That is what I said.
Yeah,
So
yeah.
that this is grade 1 and 2.
Grade 1 to 2
Grade
injuries.
3 has to go.
Yeah. So what I'm talking about is that, see, in this series, 2/3 had a complete continuity and they had improved very well the laxity from almost 2 to 10 mm. So grade 1 and 2 can be treated conservatively with all the PCL injuries. Even sometimes in the mid-substance tears, if you immobilize properly with the posterior supporting brace, make them non-weight bearing for 4 to 6 weeks time, most of the mid-substance tear heals very well. Tibial side avulsion or a femoral side avulsion will not heal. So mid-substance tear, they have a very high chance of healing with the conservative management. So you can reassess the patient after 4 to 6 weeks time, after removing that posterior supporting brace. Then if it is again grade 3, then you operate. But most of the time, it will be like grade 1. If you're a grade 3, it can come to the grade 1 to 2.
But we should remember that PCL is also a medial stabilizer. Even though it does not give rotary stability, it is a medial stabilizer also.
I know, I understood that, but there is no medial collateral injuries. We no need to worry about. We are worried about only the posterior translation here. And these patients, they heal very well. Because the PCL has got a high healing chances compared to the ACL.
Compared to ACL.
The problem is healing in elongation. And
Yeah.
that is why your concept of PTS base is very, very important.
That is very important. So some patient walks on the day 2, day 3 and comes back in walking, then that patient is 100% it will elongate. If your patient comes to you on a day 1 or day 2, then you are protecting the knee without weight bearing and the posterior supporting brace, they heal very well. So this is the same case. You can see that.
Sir, will you have a subjective criteria or objective criteria to assess your healing of PCL?
Degree of?
Whether you have subjective criteria, you just clinically assess, or you have some KT arthrometers or something to assess your healing of this?
I do only clinical assessment. You do the Lachman's, you know. Then if you are worried about it, do a stress X-ray. Yes, all the other panel points out.
Kneeling stress X-ray, right?
You can use a stress X-rays, then compare with the opposite side, and if you feel that if it is more than grade 2, then we do operate. If it is a grade 1 and 2, we don't need to operate.
So depending on MRI, we cannot say that it has completely healed. Sometimes you see that PCL is completely intact, but the knee subluxates.
Yeah.
So this happens usually. The MRI person or the radiologist says that PCL is intact, very much intact.
And that is why stress X-ray is very,
That's
very
why-
important
that's
for
what I'm
PCL.
saying.
That is why I asked that question.
Clinical Lachmans and stress X-rays supports you. That means that will not say lie to you. So you are assessing clinically. And you are doing the posterior translation. You know that it's a grade 3 or grade 2. And also you are confirming with the stress X-ray.
Sir, many of the times when we clinically evaluate, there we can also go wrong. Your grade 3 will be my grade 2.
No, it's not like that. It is
So
not
if you uses more force to Rajnish, if you do is it was grade 4 also. That is what happens.
That should not be the message to be conveyed to the people. It should be everybody has to have the same grade 2, grade 3 means the same assessment only. You can vary 1 or 2 mm difference will be there, but we cannot have a grade 2 and grade 3. We cannot.
But stress X-ray.
Stress X-ray will not tell lie. I mean, even that's why you compare both. Do the clinical test. That's why you are doing a stress X-ray.
That is why I pointed out there should be some subjective criteria and there's some objective criteria. Objective should be stress X-rays and subjective should be our clinical assessment.
Both has to be combined.
Even this well-healed PCL could be healed in the maximum length. Elongated.
Maybe it will be a non-functioning PCL.
Healed in the longest position, elongated position.
The message is not that elongated position or normal position. PCL has got a capacity to heal well, and most of the mid-substance tear can heal very well with the normal laxity. That's what I'm trying to convey.
That's correct. Compared to ACL, PCL heals
very well. That's what I'm saying. The idea is that isolated PCL don't operate immediately. That is the message I want to convey.
Provided the bracing is the best.
That's why you have to continue that. This patient was treated with posterior supporting.
Really an MRI finding, not a clinical, because it's only grade 2.
Yeah.
So MRI finding for PCL, you can go conservative.
Anything which you have to go a clinical radiological correlation always important in orthopedics. Whether it's a PCL or a ACL, anywhere it's very, very important. So you are going with all the 3 factors, you're confirming that patient is stable and you are not operating. That's all. So the message is that anything with the mid-substance tear, we don't need to worry. You can treat conservatively. You reassess the patient after 4 weeks, 6 weeks with your clinical examination. So if you are doubting, clinical examination itself will give you a clue most of the time. Unless it's suspecting it's a grade 2, then you do a stress X-ray, then confirm it. Then if it's grade 3, then you operate.
Patient compliance is also important. Using the brace. Patient compliance. If the patient does not use the brace, he throws away
the brace. All the multi-ligament injury,
we are sending them home, no? The compliance of the patient, how he uses, that's also very important.
We have to explain to the patient. Any patients you are putting a brace, you are giving a counseling. You have to do a strict non-weight bearing. This brace has to be worn all the time. That we have to explain. We will mobilize the knee after 4 weeks. You do a reassessment, then we start moving the knee. So of course, the counseling is very important for any patients is very, very important. It's not only applied for this because we are dependent on the braces for all those our ligament injuries.
Do we have Indian-made posterior supporting braces? I know the brake braces which are quite expensive, 30,000-40,000.
We also put some hard. We don't have the good ones.
A pad under the calf, and when you bend, ask the patient to bend in prone, not in supine.
Yeah,
so that'll
even
after reconstruction.
After 4 weeks also, this post-op rehabilitation of the PCL also, what he says that after 3 weeks you have to do a prone bending to avoid that posterior sag. That's what important. So the posterior supporting brace is very important. It is not available. So we usually manually make it. Even though there is some company that comes with the soft support, but that is not enough because that compresses always. We have to use a slightly harder. Not very harder, that will not create any problem. So you can make it a strap on that and you can use the posterior supporting brace. So for all the PCL operated case also we use the same thing.
So with the brace, the patient removes it and daily moves the knee, or
no. You should not remove it for at least 3 to 4 weeks time.
So can we give a cylinder, a slab or cast like thing?
You don't give a brace. Yeah, if you pay for the posterior support.
For the posterior support.
But it will not work. The leg will hang down. Even in the plaster.
You give a posterior support and how do you put a tube cast? How will you make it? You have to keep it in the knee flexion and do it.
No. I mean, in the cylinder slab, you can put more pad on the calf area. Will it support? That's what I'm asking. The patient.
I don't have any experience on that.
Okay.
Can you ask the patient to mobilize in prone position?
After 3 weeks time.
Not before 3 weeks.
Not before.
IPS, what is your?
No, I think strict non-weight bearing, no mobilization for 3 to 4 weeks.
We already worried about the laxity. You try to conserve as much as possible. As long as PCL is concerned, always slow rehabilitation. Even if you operate, we never make the patient weight bearing for at least 10 weeks time. Okay, we make a strict non-weight bearing for 6 weeks. We start prone bending and the 3 weeks time. After 6 weeks, we do assisted knee mobilization. End of the 10 weeks only, we make them full weight bearing walking. Even for operated PCL, because we know that these patients can go for a laxity. So you cannot do an accelerated rehabilitation in the PCL.
So in operated case, you give the same brace? Supported.
I'm talking about the operated case only. I'm talking about this rehabilitation.
No, same brace, the supporting
Yeah,
piece.
yes,
Supporting
yes,
brace.
yes, same.
Sir, in tibial avulsion cases, what is the type? It's the undisplaced type of tibial avulsion. Can we go conservative?
So in the PCL avulsion, whether you operate or non-operate, the decision taken on day one. We don't wait for the get the laxity come down. Anything with the type 2 or type 3, if it is separated from the bone, if the gap is around 3 to 5 mm, always we operate.
Only in the mid substance you can go for conservative.
Yes, mid substance only I'm talking about. I'm not talking about the tibial avulsion or a femoral avulsion. I'm not. Only mid substance. The heel with laxity, that's as all everybody suggested that if you put the brace properly with the supporting brace, they can heal very well. The laxity also can come down. That was the idea. So this is a 24-year-old male patient, anterior knee pain for 9 months following direct hit. Again, it's a dashboard injury. Okay, clinical examination is a posterior sac positive and posterior dryer positive. I don't have all the videos. And also quadriceps active test is one of the important tests which you can test for all the chronic. They're very sensitive to specific tests for the PCL. So a quadriceps active test, I have a video, but it is in a different this thing. So this is a stress X-ray which we are all talking about. So any PCL patients has to be, when they come back later on after 4 weeks or 6 weeks, you can take a stress X-ray. Then you know it is how much it is translating posteriorly. You can see that ACL is intact. This is a complete PCL tear. So of course, we know that we had to examine for both posteromedial and posterolateral insufficiency for these kind of patients. So radiological assessment, when they come, it's chronic. We know that these patients require a stress X-rays and also alignment X-ray. Here we talked about any chronic case, they can come with some varus deformity. So it's very important to take an alignment X-ray. And this is the radiological grading. I think any difference of opinion? When will you decide about this is one of the nice article from the Laprade group where they published about where you talked about the subjectivity and this thing. This article is a good and a good radiological measurement which can differentiate you which is isolated PCL tear, which is combined injury. If anything is up to 8 to the 11, you can consider still it's a grade 3 isolated PCL. Anything goes more than that, then you should suspect patient might be having the rotational instability.
What is your technique of taking stress X-ray in the anteroposterior direction? What is your technique?
Now we are doing with the kneeling down.
Kneeling?
Yeah.
Kneeling.
With kneeling down with the X-ray.
Single leg kneeling.
Previously, we take with manhole pressure, but again is subject to, it can vary from subject to subject. I can put this much pressure, other guy, radiographer can put a lot of pressure. So the kneel down is more, that is there are good articles are there to prove that the kneel down is the more specific and sensitive test for the stress X-rays.
Laprade has described this very nicely, how to push in the limbs and all.
Yeah. So that is a good this thing. So this is one of the, anything which goes more than 12, then you should suspect that it's not an isolated PCL. So that is what the article says that. Okay, for isolated PCL, I think what is your graft choice, whether you do a single bundle or double bundle? Start with Sujit. Vehicle.
A single bundle with CME quadruple if it's an isolated PCL.
Yeah.
With a multi-ligament, I went think about.
So this patient is only a 10 mm translation, no collateral injury. So it's a grade 3 PCL. So
yes, grade 3
we are planning for
PCL,
operation.
you can do a double bundle.
Double bundle.
But if you have multi-ligament, then you go for a single.
Graft choice. You can finish it.
So peroneus also or CQT, not hamstring usually.
Biomechanically, double bundle is more stable, but I will go for single bundle.
But if you look at the literature, there is no concrete evidence to say that double bundle is superior to single bundle, even in PCL. So single bundle is enough. Peroneus is a choice, and all the studies which you talk about are in vitro studies, like cadaver. What Laprade has described is in cadaver. So most of the studies which talk about double bundle is in vitro. In vivo studies are very few. So there is no advantage of double bundle or single bundle, even in PCL.
That is absolutely true. Where clinically there is no evidence because all the functional outcomes are same, whether you do a single bundle or a double bundle. like a ACL, like a PCL also, it's same. But biomechanically, we know definitely it's a double bundle is superior. Because
It's not replicated in human beings.
Let me finish it. So we know the anatomy of the PCL. You know, anatomy starts from the 12 o'clock to 6 o'clock position. You try to recreate the anatomy. We don't know whether how much it is effective in the long term. We don't know, but we know all the midterm functional outcome is same whether do a single bundle or a double bundle. We don't know, but you try to recreate the anatomy. That's all. If possible, if you're doing a double bundle, is not wrong. That's what I'm saying. That we try to recreate the anatomy. So you can do a single bundle. I think that is more than enough because we are talking about more of. That's why when I did live surgery also, I was talking about the posterior translation. That's why you make when you do a single bundle, you are making an anteromedial bundle, anterolateral bundle, so that you are stopping the posterior translation. Here we are not worried about the rotational. That is more than enough. But double bundle always creates the anatomy. But even I don't do double bundle for all my cases. As I said, only in isolated cases I do a double bundle. Yes, IPS asked me. I use the outside in jig, especially when I use a double bundle. So it's always good to have a outside in jigs to use a double bundle because in the inside out, when you make it, you cannot make it two tunnels through the same hole. It is not possible. So always when I do an outside in technique, I use this jig. So that helps you. That the upper one gives your anterolateral and the lower one gives the posterior tunnel. So that's what it creates. When you do a double bundle, you see the anatomy is recreated. But as I said, functionally it may not make any difference. But I don't know. But if you do a double bundle, naturally you try to preserve the remnants of the PCL. You try to recreate anatomy. But as I said, in multi-ligamentous injury, nothing is there. Whether you don't have remnants, you don't have any meniscocapsular ligament, but still you try to create single bundle, still they also do survive. So we don't know.
What is the differential fixation at the tibia? How will you fix the two bundles in tibia? In which angles and what is the implant used?
The angle of the fixation, because
Yeah,
in the tibial side,
anterolateral bundle and posteromedial bundle,
it's only anatomy. As I said again, it's a tibial side. It's a single bundle. So you are going to fix it the same 70 to 80 degrees of flexion.
So you used a tenodesis graft, allograft here?
Two CME.
CME.
Yes. Because it's isolated PCL, so I took a CME for the boy. Usually, most of my isolated PCL, I do a CME on both the sides. I take a double bundle, I do it. So that's what I show this. Anatomy is so big in per PCL. If possible, we can try to do double bundle. But we are not saying that you should not do a single bundle. Because I done a single bundle live surgery just now. So it's just another technique. Just we are trying to show that.
If you have done for more biomechanical stability, ideally you should tension the two bundles in two differential type.
It's not possible because otherwise you have to create two tunnels for the tibial side also.
No. You can your fixation point. You should use some staples or suture post. Actually, you should not put interference screw in the tibia. You can tension the anterolateral bundle and put it in 90-degree flexion.
Yeah.
It's suture the same technique.
We fix it
and
only,
posteromedial in 0 degree.
So you have to put a 0 to 30 degrees.
Yeah.
When you put a screws, we do it on that same way in the femoral side. The tibial side you cannot differentiate because it's only a single bundle. So here it works as a single bundle.
Yeah, the point is when you tighten all in 80 degrees, it is just like a single bundle only.
It's just a bifurcated single bundle.
That's why I'm saying it's just you are recreating the anatomy. It's not going to work as a single bundle, or we are not talking about rotational instability or anterior instability. That is only for the ACL. When you talk about ACL, you are talking about the bundles which creating the rotational instability. But in the PCL, you want only one direction stability. That is a posterior translation, sagittal correction you want. So in that it doesn't make any difference whether you sequentially, differentially tightening. It doesn't make any difference at all.
Single bundle as good as a double bundle.
Yeah, that's what I'm saying. So conclusion is that double bundle PCL reconstruction definitely has a superior biomechanical outcomes as per the literature. It is not my statement. And clinical outcomes related to the single bundle reconstruction. You can see that clinical outcomes is same. So recreating the anatomy during PCL maximize the biomechanical stability and clinical outcome. So there is literature support for everything. Okay, if you want to do a double bundle, you have a lot of papers.
The same paper. It's from Lateral, I think.
Again, it is a cadaveric study, I think.
Cadaveric study.
Cadaveric study, not in vivo study.
I'm telling it's a biomechanical advantage only, not a clinical advantage. Clinically, it is same. So it's only because under fixations, you do a single fixation or a hybrid fixation.
Hybrid fixation.
For both the sides or only one side?
Tibia.
Any difference of opinion? Femoral side double, because I see Many surgeons routinely now use hybrid for femoral side.
But I use usually interference screw for femur side also.
Interference screw?
For femur side. And hybrid fixation like this for tibia.
So my fixation is femur is a screw, so I don't use a suspensory device.
Yeah.
The PCL, the interference screw goes much inside, and I use an emergency fire to confirm that. And outside you have a tunnel. So what I do is I make a 2.5 drill hole on the side of the parent hole, and I tie over the bony bridge. So that acts as a secondary fixation until the PCL is healed.
PCL. So mostly we use a hybrid fixation in the tibial side at least, like the suture post or whatever you anchor, whatever you want, you can use it. So we'll go to the other scenario. It's a 31 years old female. She had a twisting injury at home and fall. This is the dislocation. Patient presenting with the dislocation like this. So it is not uncommon to have a patients, females with a low velocity injury like a twisting injury and have a dislocation like this. So this was reduced, of course it was reduced, and this is the MRI picture. This patient's MRI shows the ACL tear, PCL tear and MCL tear.
So KD3M.
Yes, it's a KD3M. How will you proceed?
Vascularity and all right.
Sorry?
Vascularity.
Yeah, pulse is okay. No neurological deficit.
Immediate post reduction, is it stable or unstable?
Yes, it was stable.
Meniscus, can you show that?
No, meniscus is normal.
So only to bicruciate with medial
It's a
side.
very low velocity injury, so meniscal injury is very rare.
So single stage female.
Stage surgery.
Yeah.
Sujit?
Yes, single
Single stage. Okay. So this patient was reassessed after he was given a posterior supporting brace. Naturally, there's a posterior supporting brace given. And this patient was immobilized for 4 to 6 weeks, non-weight bearing walking. As I said, regular PCL protocol. Then we started knee bending after 3 weeks. After 6 weeks, we put on a hinge knee brace and mobilized. It was around 8 weeks or 9 weeks. This is the reassessment of the patient.
The MCL was avulsed from the femoral side.
Femoral side, yes.
Was it, had it been TBL, would you have given conservative?
Which one?
No, no.
TBL side avulsed from the MCL?
But anyway, the message is to reassess the patient clinically.
Yeah, so
yeah, tibial side avulsion definitely has got a poor healing capacity. Even the mid substance, anything with the femoral side, they heal very well.
Do you have stress X-rays at this point?
Yeah, in these cases, we need a stress X-ray to really see that the healing is complete. Usually it's a scar tissue, you are not very sure. You are gently doing it because it's your own case.
Yeah.
But when you
that is the one.
Patient to walking, climbing stairs, going
No.
down.
This
So
patient
stress X-ray, I mean,
this is a 10 weeks time. I'm telling this patient. This is a 10 weeks old injury. Patient came by walking only. Already patient is doing a staircase climbing. Clinically, it's a grade 1 laxity. So anything it's a more than grade 2, we can take a stress X-ray and see again you want to do a subjective, objective, all those things. But when you have a clinically, when you have a stable laxity 1, you don't need to do a stress X-ray. The patient walks well and there is no medial lateral instability.
Dial test. How is a dial test like? Is it?
Everything is normal. Everything is normal. So what the message is that all the low velocity injuries, there are literature is shown that all the low velocity injuries can be treated conservatively, which when Hasil also presented, he showed that. So low velocity injuries, especially this is a just twisting injury at home. What happened? The magnitude of injury doesn't happen like what you have it in a bigger injuries, high velocity injuries. The low velocity injuries, only the cruciates and the MCL has gone. But when you have a high velocity injury, you are having another capsular, oblique popliteal ligament, all other extra structures also is getting torn. So that's why that patients, if we immobilize them, even the patient comes back, we get that laxity. We try to recreate the anatomy by doing the ligament reconstruction. There is a role still you can consider these patients for a conservative management. Reassess the patient. Of course, we are not operating any patients. Any multi-ligament injury, we don't operate on day 1. I think that message has to be conveyed. Second thing is we don't mobilize the knee immediately on day 1. Again, you put the patient on a knee brace, allow the knee become quiet, bring the patient after 2 weeks time, start moving the knee, then get back the knee movements of more than 90 degrees, then reassess your instability. Then you discuss about the surgical pattern and do the surgery. So that is the idea. So reassessing the patient clinically is very, very important.
If PLC was got if PLC was also injured in this case, what would have been a protocol?
Sorry?
PLC. Now it is PMC, medial side. If it is a PLC also.
Again, reassess the patient after 4 to 6 weeks time. Even
You
it's
think, and you think PLC and PMC heals similarly? Or
Sorry?
is it
See,
healing of
any injury KD3 or a KDL, your protocol is same. You are not operating on day one, correct? No. You are going to patient putting on a brace. You want the knee to become quiet. You want to get back the knee movements before operate. So we operate on a day. I mean, like Hasil said, the emergency indications to do surgery within a week or 10 days time is only in irreducible dislocations, open dislocations, and vascular injury. Only these three require a immediate surgery in a multi-ligament situations. Otherwise, anything with the KD3, if you feel it is stable, you put on a knee brace, you get back the movements, then you do the surgery for your cruciates and the collaterals. So that is due to prevent the arthrofibrosis, and also you know clinically how they are after 6 weeks or 10 weeks time when you get back the movements.
What is the range of movement of this patient at that time, 6 weeks time, or for when he comes for follow-up?
Sorry.
90.
Huh? Sorry. This patient already has got a more than 100 degrees of movement, so they all do very well.
Fine.
MCL will heal, PCL will heal. Do you think ACL will heal?
ACL?
MCL will heal.
ACL even doesn't heal, doesn't matter. Because in the multi-ligament scenario, you should not think about it as an isolated ACL rotational instability. They are not a sports person or something like that. That's why when you do a two-stage procedure, like when the patient comes back, if you say that suppose you have done a PCL, if you want to do an ACL in a second stage, no patients will come back for ACL, because by the time the knee will become an inherent instability because of your long immobilization, they will get inherent stability. No patient comes back for ACL. That's why if you are worried about the timing when you do a multi-ligament situation, even if you don't do a ACL, it is fine. You do a PCL and collaterals in a single stage, they all do very well. So this is another patient of 29 years old, pain and giving way, right knee, 1 month duration. That is the PCL tear. That is you can see the meniscus root tear. So this is one of the common scenario when you have a multi-ligament injury with the PCL can have a root tear also. So in acute situation, so medial meniscus root tear mostly is a degenerative. When it is in acute situation, it's mostly because of the PCL, or in a multi-ligament injury, you can have an acute PCL tear. So here MCL, PCL and the medial meniscus root tear. So this patient had a posterior sag because of the MCL. He had a grade 3 valgus opening. So basically this patient got a PCL, MCL and a root tear. So how will you proceed? Because you know it's all medial sided injuries. Root tear is on the medial side, MCL is medial side. Your PCL, you are going to put a tunnel on the medial side. Any technical tips? How do you proceed with that? Start with Sujit, or do a single stage or two stage?
It can be done as a single stage. Yeah. Only thing, the root tunnel has to go to the lateral side. PCL, you have to go from the medial side of the tibia, anteromedial tibia. So the root tunnel will almost be nearby. So you can go to the lateral side and exit there and use an endo button to fix it there.
Any different technique?
So you're planning to reconstruct PCL, MCL anatomical reconstruction, or your?
It's a femoral side avulsion.
Femoral
so
side
repair.
Femoral
side avulsion.
Repair
so
only.
All the femoral side avulsion, you can repair it very well. They all heal very nicely. Okay. Anything with the mid substance, always you augment with the graft. Like
so only problem is here with the PCL tunnel and the root tunnel.
PCL and your
root tunnel.
Medial meniscus.
And PCL, the femoral tunnel, if you can put it outside in, so no problem. You can change the angles and put it outside in.
For the femoral side.
Yeah, for
tibial
femoral
side. We are talking about the tibial side also. You have a root tunnel and your PCL tunnel. They are very close by. That is the only. Technically,
you can take it different angles, no problem.
You can make a different angle. You can go to from medial to lateral side. You can adjust your jig and go out of this thing.
Or else you can also have an all inside repair of that.
So another option is the root fix anchors.
Yeah,
now,
all inside root fix anchor you can use. You can bravely put the PCL tunnel nicely.
If you are worried about the tunnel collision, the root fix anchor has come now. That works very well. So no need to worry about the tunnel. You make that first root fix anchor. And then go to the PCL tunnel, then you don't need to worry about the collision. So that's what I want to convey the message. Of course, so you should not forget that any PCL tear with multi-ligament injuries, always you look for a posterior meniscus root. So that is the idea. It's not very uncommon to have this kind of root tear. Of course, you already the techniques have been described before. That is the root tear. We do it in a single stage. You do open up or do a MCL in a single stage. So the single stage is possible in all the stable KD3M or a KD3L. Anything goes for a KD4, I also do in a two-stage procedure. What about the KD4? Because the time is up, just we'll finish with this discussion. What is your decision when you do a single stage, when you do a two-stage procedure, IPS?
So in this injury you're saying? In this injury or in KD4?
No, not this case, I'm talking about this case.
Yeah.
I'm asking the general question because the time is up for the next cases. I'm asking when do you do a single stage in multi-ligament scenario, when you do a two-stage procedure?
Almost it's single stage in almost all the cases in my center.
Even
Almost
it's a KD4?
Yeah.
KD4 is unstable?
Yeah, but we put a fixator then.
But that you don't do, you put a fixator, come back, bring it
Come back and then do the repair.
At the time, do you repair the collaterals? You don't do.
No, I don't do anything then. We just reduce.
Any difference of
If it is unstable, you have to put a fixator for 6 weeks or 3 to 4 weeks. Then you have to have a gentle manipulation or mobilization. After attaining a good range of movements, then you can do everything in one stage. Whatever able to repair or augment, you can repair or augment, especially the medial side. Lateral side, definitely you have to reconstruct. And both cruciate also you have to reconstruct.
Sir, how early is the single stage? How early after the injury?
How early after the?
Injury is a single stage.
3 weeks.
3 weeks. I mean, after 3 weeks,
after 3
go
weeks,
for a
the
single stage.
ligamentization, the contracture of the soft tissues will happen. So there is no, if anything you can repair, but you have to augment it. Otherwise, arthrofibrosis will be there.
So the femoral side avulsion of the MCL will be repaired and it will be augmented.
No, femoral side avulsion you can repair. If it is a good quality tissue in this substance, you can assess it and you can staple it and fix it.
Even after 3 weeks?
Even after 3 weeks. If it is contracted, if it is not coming to that point, then you have to repair it or staple it and then augment it.
But you cannot apply this principle to every patient. When it is highly unstable, there is a Stenner-like type lesion, even though it is a closed injury, you see that ligament is subcutaneous. And if see that the meniscus is extruded, those things has to be addressed. And then you put the fixator. Once you put the fixator, at 3 weeks you can reassess. When you get some range of motion after removing the fixation, say 90 degree, then you can go for PCL or else posterolateral side or posteromedial side, whatever you see. So first you can repair the ligament, repair the meniscus, put the fixator in correct position, and then if possible you can do PCL at that time. But the disadvantage of that PCL reconstruction would be extravasation. So better you reconstruct the ligaments and then the meniscus.
Yeah, that's what I say, that all the KD4 most of the time are very unstable.
Yeah, two-stage
and many patients will have a completely displaced meniscus.
Yeah, that's
so you cannot just put a external fixator for all the cases.
All
because
the
even
it's only
you
case
have to be
based.
carefully look for all the displaced meniscus. Because I have done a few cases where even the dislocated meniscus, you can just put back, you put an external fixator, even you don't need to do a repair meniscus. By the time it heals well, when you come back for the second stage
But
surgery.
you have to open. You have to open now. Just putting a fixator in alignment is fine. Just putting a fixator in correct alignment is not enough.
Which one?
No. When it is dislocated and unstable, just putting a midline fixator and leaving the patient is not good. You have to open it, correct it, and if possible, you repair the ligament. First stage, then second stage.
That's what I'm saying. You reduce the meniscus, you do the external fixator, make it as a stable knee. Even if it's even if the meniscus is reduced without repairing, they can heal well. Because I have seen very second stage surgery, when you go in, they all heal well by the time. The meniscus, you don't need to do anything. Just do a reduction, make the knee stable, they all heal well. Because most of the time, they're all meniscocapsular avulsion, not like other cases of bucket tendon tear which you see in a white zone. Usually, there will be a meniscocapsular separation with the displaced. Just you have to reduce it, make it a stable knee, then put on external fixator. Then by the time, again we do the reassess the patient, because some patients will have a lot of knee stiffness in unstable situations. They can go for a knee stiffness. You will not be amenable to do any surgery in 3 months, 4 months time. So many patients require even arthrolysis to get back the knee movements. By the time when you get a 90 degree, they will not get more than 90. Once you just started doing arthrolysis, that means they're very stiff knee. You get a 90 degrees movements, there will be stable knee, and you may not do any ACL or a PCL, because by the time the knee is very stiff.
They won't come back also if you suggest surgery.
Not necessary, because before we do all these ACLs, PCLs, we had done the same thing 15 years before. They get a 90 degrees movements and we'll make it as a stable knee. I think it's a time up.
Yeah,
Thank you very
thank
much.
you.
Thank you.
I think Dr. Sundar and Dr. Sujit is leaving. So big round of applause to Dr. Sundar for a wonderful live surgery and a very good panel. And I invite Dr. Gobi sir to give a small autograph appreciation to Dr. Sujit and Dr. Sundar Rajan. And also Dr. IPS is also leaving. Please come here, sir. Please give a big round of applause. Please give one of the basics, how to do a perfect ACL reconstruction being shown very well. Thank you, Dr. Sundar.
Thank you, sirs. Next is a live surgery session on ACLR plus meniscus, which will be led by Dr. Sandeep Barberaris. I invite Dr. Khayas Omar and also Dr. Samir Ali to moderate the session.
So this is the third case. ACL reconstruction plus meniscal repair by Dr. Sandeep Barberaris. So this history of road traffic accident 5 months back, sustained injury to the left knee. So the anterior drawer is positive. Stress valgus varus negative. He has full range of movement, minimal pivoting. The X-rays looks okay. MRI shows a full thickness tear of ACL, and there is a signal change in the lateral meniscus. Over to you, sir. Live.
Dr. Sandeep, can you hear us? Dr. Sandeep?
How old is the patient?
Dr. Sandeep, can you hear us?
We can hear you.
Yeah, I'm Dr.
Hello.
I'm Dr. Samir and Dr. Khayas here.
Yes, Dr. Samir, good afternoon.
Yeah, good afternoon. Yeah,
Yes. Am I audible?
Yeah, yes, audible.
Can you see the outside inside picture?
Yeah, sure.
Yes, so see this gentleman, so what we have done so far, so we have prepared the femoral footprint.
Okay.
And then patient had a lateral meniscus flap tear here, which I have removed. And then patient has got a lateral meniscus tear. You see?
Yeah.
So plan is to repair lateral meniscus, all inside, and ACL reconstruction. We have harvested semi-tendinous graft also, semi-T.
Okay.
Yes, so we are going to go ahead with the meniscus repair. Spatula.
How will you decide whether to do a conservative meniscus or just leave alone or do a repair?
Now, see, there was already flap tear from here to here, which we have already excised at the beginning. Now, whatever is left is a peripheral rim with and which is also not healthy. So we cannot leave it as it is. If it would not have been so unstable, I would have just debrided and left it. So I'm going to do all inside. So that's the all inside device which we are going to use. Can you see?
That's a true span.
Yeah, true span.
So what is your viewing portal and what is your working portal now?
My viewing portal is a anterolateral portal, high anterolateral portal, which I had taken initially, and I'm working from the anteromedial portal. So always I put it in such a way that it should not damage the cartilage. So I put it while pacing down. Remove the spatula. Yes, so once it is in, I rotate my handle. Please lift the foot. Lift. internal rotated. Yeah, very good, excellent. So it's a very I'm just going to pour behind the popliteus. So I have put it in the capsule. I'll fire, taking out. So many a times I used to face a problem that it used to get pulled.
Yeah.
So you can see here what I have done. I'm holding it pressed till it comes out. You can see the spring there. Now I have left. Once I know I'm outside it.
Okay.
Still I pull out little bit and then I'm going to take it has literally ragged edges, but I think this is a young patient. We should give a chance to repair. Initially when I saw the MRI, I thought it is just a grade 2 intrasubstance signal.
It's anyway complex tear, right?
Yes. And I am very much fond of inside out.
Did you do the rasping before?
Yes, already done. Hold this.
It's a white or red-white?
It is white, red zone.
Red zone.
Yes.
Something like
Probe.
a red-white zone, right?
So many companies, they don't they say, okay, you can just pull it as it is, but I don't do that. I am always to prevent that cheese wiring. I always press my probe and I do this procedure. I don't rely. So Dr. Amarnath here is holding the scope. I am holding the probe in my right hand. So whatever is repairable, I'll repair, and rest of the no, don't move. I'm going to resect it out.
If you want to put a single stitch, will you put at the superior surface or on the inferior surface?
So both superior.
Because many of the times, especially in the medial meniscus, if you put a superior surface, you can see that the meniscus will flip up.
Yes.
So my personal opinion is when I do a meniscus, medial meniscus, especially if it's a single stitch, I usually try to put it under the meniscus, one into the meniscus, one into the capsule. So that will be very well flat on the tibial surface.
So here, because it was very much stable, so main thing was I just wanted to give it more stability so that it heals. It should not cause bucket. So now you see I'm pulling the thread, but it's not still coming. So I have put both in the top. So now second, all inside I might put in the inferior now.
Is there a horizontal component?
There is no horizontal component. These are just uneven edges. Bit horizontal tail. Yeah, okay, very good. Second, spatula.
Suppose this tear is exactly very close to this popliteus tendon. How will you make sure that you are not penetrating into the popliteus?
Well, so we need to have a good vision for that. So this you can see here, I'll show you. That's where is the popliteus. That's popliteus. Can you see?
Yeah, yes, very well.
Okay?
Can see.
And
Yeah.
it's just behind the popliteus. That's the thread which I have cut. Hold this. Sorry. Relax. Take out the spatula. Oh, yeah.
So this is for the horizontal part or vertical? Okay, the longitudinal.
Sorry?
So on more vertical stitch you are putting under the meniscus,
Yes,
right?
under the meniscus, yes.
The first is goes into the capsule.
Hold this. Yes, first I have hold in the put in the superior capsule. Now I'm going into the inferiorly so that it reduces further. Hold it. I have already prepared graft.
Do you give counter with a knot
Yeah.
pusher, something like that?
No, I'm giving counter with my probe.
It's giving counter with this probe.
So
Yes.
there is Arthrox knot pusher, which is ideal for the meniscus repair, which is very malleable, which can be very well used for such steps. It will give more.
No, even they
a
have
better-
got, MyTech has got this knot pusher. This is also wonderful.
Yeah, this is
But
just
yeah.
somewhat like that.
Yes.
Better than a probe.
So I think I have just stabilized it. I'm going to leave it as it is. Because it was, I could withdraw it completely inside. Hold this. And reamer. Reamer. Give. Don't do that. With pin. So what I am going to do here, I always use the reamer as my guide.
Okay. So your
So graft is 8. Bend the knee, please.
so your reamer is placed
Bend
into
the
the
knee.
anteromedial portal, right?
Yes. Table down, please.
Knee is 90 degree.
Now it is more than 90 degrees.
Okay.
Can you see?
Yeah.
Show. Yes. It is fully hyperflex. Don't do it. Hold it. Table down. Yeah.
So is it your
That's
routine
the
practice?
resident reach, which we call it. I'm just behind the resident's reach. Sorry, what was the question, please?
So is it your routine practice to do this in hyperflexion?
Yes.
Or do it in 90 degree and then hyperflex?
No. So I put it in 90 degrees and then gradually I hyperflex. So now put.
Because basically the way how the Sundar did for the femoral tunnel in the PCL, right?
हाथ निकालो. अरे लागेगा उधर. नीचे पकड़ो. हाँ. Don't. Please go. Yeah. Go. Yes. So this is my guide. So go Arpar. Bas. So I withdraw and check. Okay, I'm happy. Disconnect this. Pull it. So you can see I have already put this. Move outside. I have put this already. So at my that's my handle. Put it. Chal. Go. 25. Go. Go. When I say stop, stop. Go. Go. Show. Go.
So what's the graft length?
I'll tell you. It is 8. 8, 8. 8 diameter, quadruple 8. Go. Go up to 25, please. Go. Go. Little more.
So you're reaming till 25. Your femoral tunnel is 25 mm,
I
right?
have not, I don't measure. Withdraw. Withdraw. So see what I have put the bit pin. Withdraw, please. Drill and withdraw. Yeah. I have put the 4.5 reamer lagao. I have put the bit pin first. I have reamed with 8 mm for up to 25. And now I'll do 4.5 reamer.
Is there any reason why you're doing that way?
There is no reason. I'm used to it now because see, I use adjustable always. $4.5, please. What happened? Only some technical problem with the reamer. Anyway, till that I sort it out, I'll just show the graft preparation. Show here, outside picture. Hold this. So that's the almost 7.5 quadruple hamstring.
You take only semi-T alone?
Only semi-T.
Yeah.
I'm getting 8 diameter. So I'll tell you what I do always. So I make the needle straight, okay?
Yeah.
Ethibond needle. Then hold this, hold the tip. I put it in like this at the end, leave this. Then I again go through the same substance. So it makes that loop. Can you see?
Yeah.
So I use the same loop. I have already prepared it. I thought I'll show you. Hold this. Leave. Relax. Hold this. 4.5 laga ke rakho. So this was what I have done now double. Okay.
Okay.
So that straight ET bond which I have made, I'm passing it. I'm making this loop. Keep on changing. So I make the same loop like the other commercial companies have, but I prepare it myself.
Yeah, nice demo for Dugard technique.
Yeah.
But you cannot do it with fiber wire, right? You cannot do it.
Yeah, it has to be done only with original ET bond.
Yeah.
I'll tell you, not other companies.
Yeah,
ET bond.
braided sutures
It
only.
breaks. Yes. That to number 5 ET bond, original. So before I asked Dr. Bashir, do we have that? He said, yes, don't worry. Because some hospitals, they may have some different brands.
Yeah, this ethibond can be used for suture settling with the same technique. You can pass through the braids and you can use it for suture settling.
So that's my double graft. Can you see? Now I'm passing the adjustable, rigid loop adjustable, hold it, leave it. So that's our final graft with a length of almost 7.5 to 8 with 8 mm in diameter. Okay?
Yeah.
That's 8 mm. Tensioning laga. I think we are ready here with the new drill. So I'll just trocar. Loose ethibond loop for shuttling. This will use, yeah. Huh? What? I know. Hold this. Yeah, it's full. So please go 4.5. Between, put it in between. Go. Go. Oh yeah, this out. Put it in between. Put the ethibond in between. Suction, please check. Hold this. I think shower, please. Shower. Wait. Hold on. Deep. Please press.
What is the femoral tunnel length?
As I said, I don't mention femoral tunnel length.
You flip the endo button.
Practically, I feel it is not important.
You flip the endo button on the lesion, right?
Adjustable. Blade, please. Hold this.
So will you prefer more close towards the lateral tibial spine or more close towards medial tibial spine?
I'm sorry, come again, sir.
Your tibial footprint, you are more close towards the medial tibial spine or lateral tibial spine?
More towards lateral.
Because we go laterally, there is a chance of impingement of the lateral wall.
Now, let's see. I might, after I pass my guide wire, if there is an impingement, I will debulk the remnant. No, that's okay. Please pass. Debulk the remnant. Hold this, please. Wait. Give. Yeah, please go. Perfect. Hold this. Scoop. Please put 8.
Do you want to adjust it a little bit medial
I think, sir, I'm
while
okay.
serial dreaming?
No, I think I'm okay.
You're okay. Yeah.
Yes. Yeah. Don't go full, huh? Because if we go medial, then whatever that remnant will go for sure.
Okay.
Will this?
So more like a remnant preservation ACL, right?
Almost. Yeah. Please go. Yeah.
What size are you drilling now?
8.
Directly 8.
Direct 8. Go. Not yet. Go.
Sandeep, any time will you prefer to do the all inside ACL? Do you have any specific indications
I'm not that fond of all inside.
any particular reason?
Well, the place where I work,
Okay.
the inventory is because when we take out, when we are doing all inside, then we need to have more inventory.
Okay.
And then in a hospital which with the government, so you think still we would have gone lateral medially?
No, it's fine. It's
Yeah,
almost
because-
just
Perfect.
Yes, because
Just brushing
why
with-
I use that tip hammer.
Okay, fine.
So it was on the tip. So I knew I was going to come out somewhere here. Grasper. Now if the graft diameter would have been 9 or so, then I would have done serial. Don't do anything, please. Grasper, probe, anything, please. Sorry? Huh? Don't know. Case is over.
Are you always happy with an 8 size graft in an adult athletic male?
Yes, why not? 8 is good graft.
8 is a minimum.
Hold this. 20. Yeah, very good. Don't worry. You mark 20, no? Hold this, hold this. Hold this. So that's a graft I have marked at 20. So now I have shifted my scope into the anteromedial portal.
Okay.
Because I'll be checking. So are you satisfied with my position?
Yeah.
Yes,
very
yes.
good.
Yeah?
Yeah.
Okay.
Almost 1 to 2 millimeter posterior wall is remaining.
Yes.
And you are high and deep, as Sibin mentioned, right?
Sorry?
Your femoral tunnel should be high and deep.
Yes. Leave. Sorry? Don't worry. Don't worry. I'll do. Hold.
So you're passing the adjustable loop, right?
Yes, sir.
Now you are viewing through the anteromedial portal.
Anteromedial portal. So
That's
now
the
the
reason
scope
you are
is-
directly viewing the flip.
Yes.
Endo button flipping through the portal. That's the reason why you are not measuring the tunnel,
Correct.
right?
Correct. Mop, please. Mop. Thank you. So usually they have got two types of rigid loop adjustable, the standard and the long. It seems they don't have long. So this, whatever it may be the case, I only do this step. I don't leave it to company person and don't leave it to my assistant. They are very important. These steps are very important, so you cannot afford to, because it will straight away increase your surgical time by 30-45 minutes. Yeah. Pull. Yes, thank you. Pull, hold it, pull, don't do.
Excellent
Yeah.
demonstration
Okay.
of flipping under
Don't
vision.
do that. We are not kushti. Trokar. So now you come. Whoever is the mytic person, please come here. Trokar, please.
Now your scope is going to again to anterolateral portal.
Again,
right?
anterolateral portal.
Anteromedially, you have two portals, only one portal. Only one portal, right?
Only two portal. I have not taken accessory portal.
Accessory portals.
I don't take accessory portal depending upon like what is my meniscus status. So as it was lateral meniscus status, lateral meniscus tear. So I knew lower anteromedial portal will suffice. So that's what I did. If it were medial meniscus tear, then I would have taken accessory portal. Company person, please come and pull now. You know, no? So now he is pulling and I am giving counter. So I am pulling, he will tighten now.
Your anteromedial portal is a little bit more medial. That's why you are getting
Yes,
a good vision.
Exactly. That's why I purposely took that. Aram se, slowly. Paduke. Wait for 2 minutes.
You have learned Malayalam.
Who is this?
Dr. Khayas.
Khayas, enike Malayalam nannayittu ariyam. Not learnt. Already, yeah, relax. So, 20 has already gone inside. That's where was the marking. That's it. Bas.
Yes, all your graft, native graft and the remnant are parallel going. I don't think that's too bulky.
Yeah.
As
Now, hold this.
that means that this is a judicial decision to take whether you have to preserve the remnant or
Full
not,
extension, no impingement. No impingement anywhere, no impingement even with the PCL. Because the old graft is already there. Old portion.
And you can still see the some amount of capillaries in the remnants of the tibia. Especially you see the.
Yes. So I'm going to put now, I'm going to check now what is the status here. So my main aim is to have minimum 18 to 20 in the femur. After that, I decide if I'm going to put screw or I'm going to put button. Yes. Please, right angle.
Sandeep, from your vast experience, what are the intraop complications you have been came across in your career?
So I'm going to put button here. Endo button, please. Suture disc, suspensory here also.
Sandeep.
Yes.
In your vast experience, what are the intraoperative complications you have come across, just for the interest of the audience?
Okay.
And how you tackle this?
Yeah. So what I have come across is, as I mentioned, I only pull that adjustable loop. Okay. So once company person was pulling, and then whole graft was on the lateral side under the skin.
Okay.
Okay. So what I did, I removed the endo button and I put the suture disc there. So there was a posterior blowout. So I tackled it that way.
And there is one complication one of my colleague Nabi will say when you're doing fellowship.
Right angle.
There was another visitation fellow from Nigeria.
Okay.
So after the endo button pulled up in the lateral cortex, the sir told me you just pull and see the strength. He just pulled all the lateral cortex, endo button, everything was outside through the tibia.
So that then there have been like sometimes these ethibond sutures they give away and then graft gets dislodged from the loop. So what I am going to do here now, I am going to tie this 20 degrees flexion, please.
So you are not putting screws, you are directly putting the...
Yes, only suture disc.
Suture disc, yeah.
Step.
So do you feel there will be more bungee effect when we, especially when you put a suspensory fixation
now,
on both sides?
If you noticed, I have drilled 25.
Okay, you will later.
Okay? I have drilled 25. Now even if it is tape and all, even if it is not working, that is okay for me. Because I still have 5 millimeters play to tighten.
Okay.
Okay. So leave. Now, company, pull.
So in your experience, any...
Yeah, hold it 20 degrees. Hold it. Yeah, you leave this now.
Have you come across ethibond breaking while tightening the suture?
Further. So I am asking him now to tighten and I am putting my finger here. I can see if the button gets, how much gets pulled. keeping at 20 degrees. Please tighten. Yeah, please gently, gently, gently. Good, good, good. Very good. So button has completely gone in. It is flush, as if like it is digging. You can see here, as if it is digging into the soft tissue.
Yeah, very good. It's almost flush with the
Complete
tibial,
flush.
andromedial tibial
Yes.
cortex. Right.
Have you come across a situation where the ethibond has broken?
Yes, I have.
Yeah,
So that's the reason I use only
fiber.
original. No,
oh,
no,
okay,
no
original.
fiber.
Okay, original ethibond.
Yes.
Yeah. Yeah, old ones can break.
Yes.
And if you tamper with the artery forceps, there is always a
There is
likeliness
always.
that it will break.
Prokar. So final picture I'll show, and then we'll sign off. Any questions or doubt?
No, you showed many different ways to how to tangle.
All this.
Some indigenous methods.
Every surgeon has got their own jugaads for the ones which are being done very. It works well in their hand. So that's the final graft.
Yeah, this is what the audience require. See, so many of the time there will be a lot of confidence. We are seeing where the tunnel is putting and how the graft is tightening. And these are some of the small tricks that we all want to. There's a question from audience channels.
Sandeep.
Yes.
How will you say that you have very nicely done an ACL reconstruction? What are the checkpoints after doing an ACL?
Correct. So,
you just do this like visual impression probing or something else?
Yes, so very good done ACL is judicious dissection. No, not leaving your signature or footprints on the cartilage. Second, while taking portal, so you need that minimum 18 to 20 millimeter into the femur. There is no compromise on that. 100% 20 plus is always better. Every technique has got its own advantages. So I use this one, adjustable. So that's how I do it. If it is a fixed loop, then I always do measure and all those things. But I have stopped doing that. Then another thing is a proper tunnel positioning in the tibia as well as femur, and there should not be too big graft as well, because which can cause impingement. So you can see now I'm fully extension.
Regard to stability, I am asking, not about the tunneling and position. After fixing your graft on both sides,
yes.
Do you on table do you assess with anterior drawer, latchman,
Yes, I did
or pivot
just now. I
shift?
did already before putting the scope. I did anti-drawer. I do, and latchman also. So that's, I don't do pivot. That's the anterior drawer.
So if at this point, if you get a grade 1 or grade 2 latchman, what will be your take?
Grade 1 or 2 latchman. So I might tighten my this adjustable if it is still there is some place, or then I may put in the for grade 1 no, but for if grade 2 and above, I might do then lateral extraarticular tenodesis.
Okay. Anywhere in your lifetime, whether you have to remove your suture disc and retention, something like that at the tibial side?
No, so far no.
No, far no.
How many knots do you put?
3. No, sorry, 4, not 3.
Okay. And will you tie the endo button adjustable loop?
I have left it little proud also.
Yeah, always.
I don't tie. No. Artery.
So now,
I just tried very.
thank you, Sandeep.
Thank you.
Very
thank you so
excellent
much.
show.
Thank you very much.
A big round of applause from the audience for
Good.
you.
Thank you all the staff and
Yeah.
anesthesia. Dr.
Thanks
Bashir,
for
excellent
being
OT.
here. Yeah.
Excellent setup. Dr. Samir and Dr. Abraham. Good.
Thank you, Sandeep. Yeah.
Deflect to next session.
Thank you, sir. Thank you, Dr. Khayas and Dr. Samir Ali.
Prokar.
Now I welcome Dr. Jyoti Prashant M. and Dr. Azhar to chair our next session. I invite Professor Gopinathan to discuss about unlocking the mystery of PCL injuries.
Respected dignitaries on and off the dais, my dear friends and colleagues. First of all, let me thank the organizers for allowing me to present this topic in front of this august audience. I must talk on post-lateral corner injuries. As we all know, most of the points in this presentation is already discussed, and I'll just brush through some of the salient features. So we know that posterolateral corner does not heal as posteromedial corner because of the inherent anatomical problem. And before discussing about how to deal with PLC injuries, we should know the anatomy well. We know that there are 3 layers, and the most important ones are the 3 structures: the LCL, the popliteal ligament, and the popliteus tendon. So if you learn about these 3 structures, then probably you can treat these patients well. And we should know that the healing of this tissue is quite different from that on the medial side. So this is what the dark side of the knee, it was described by Lateral, because the healing does not take place as easily as on the posteromedial side. And most of the time, primary repair on the lateral side may also not succeed, and you need reconstruction on the lateral side as well, along with primary repair. So when you have an isolated LCL injury, the opening may be around 2.7 millimeters normally. But when you talk about the injuries of the popliteus, it may increase up to 4 millimeters, and if it is associated with cruciate ligament, it may be up to 10 mm. So depending on the grades of the soft tissue injury, the opening and the instability also increases. So what's important to understand is about the popliteus muscle complex. That is what we should reconstruct along with the LCL. So the popliteus tendon is now known as the 5th ligament of the knee. Even though it is a dynamic structure, there is a static function also. So it is considered as a ligament. There is an attachment between the popliteus and the fibula, which is known as a PFL. So this ligament has to be given more importance, and that is what Laprade described about. And you have to remember that if you don't reconstruct any one of these structures, you have some sort of an instability. The most important is the popliteal fibular ligament, which gives rotary stability. The others gives the sagittal stability or the coronal stability. So this is what the anatomy of the PLC is, and this is what we should understand before you start reconstructing. This is the area where we talk about the popliteal fibular ligament, and this is an attachment of the tendon to the fibula. So you have a fibula-based technique, you have tibiofibula-based technique on the tibial side. So it has got a static as well as a dynamic function. And what is important is untreated PLC injuries does not heal well. This I already told you, because of the reason that on the lateral side you have convex on convex articulation, on the medial side you have a convex on concave articulation. So inherent instability on the lateral condyle, lateral side you should understand. And PLC injuries commonly are associated with other injuries as well. And a missed PLC injury causes failure and does not heal usually as on the medial side. So the mechanism of injury is a posterolateral force, and which leads to varus and hyperextension. And the symptoms are instability and rotary instability. And what is important to understand is that when the knee is dislocated, you may get a PLC or a PMC injury or a combined injury. And the pivot point is already injured, which is a PCL. So you may confuse between a PLC and a posterolateral instability or a posteromedial instability. And this diagnosis is quite important. Dial test is probably a good test, but when you interpret dial test, you should also know that the corner injuries could be combined one, the medial, posteromedial or posterolateral. And on both sides you can get a dial test positive. So it can be associated with a PLC or a PMC injury. That's what I would like to highlight. So when you talk about the X-rays, you need to learn about the alignment and also the stress X-rays, how much opening you get on either side. This will give you some idea regarding what treatment you are going to give. So varus stress radiographs or a weight-bearing radiograph will give you some idea about the skeletal alignment problem, which if you don't correct, PLC will not heal. So you have to correct the alignment first and then repair the soft tissues. You cannot treat the bony abnormality with a soft tissue reconstruction. MRI will give some idea about the LCL and popliteus, but it will not give any idea about the popliteofibular ligament. So on the lateral side, you can have some opening, and this could be due to a malalignment. So chronic PLC injuries sometimes need a high tibial osteotomy to correct the deformity before you go into the soft tissue reconstruction. So this point has to be kept in mind when you treat these injuries. So grade 1 or 2 PLC injuries may be treated conservatively, and cruciate tear is repaired or reconstructed, and most of the time you need not do any other treatment for PLC injuries. So you can have a non-anatomical reconstruction or anatomical reconstruction. So Non-anatomical we don't discuss right now, but we discuss about the anatomical reconstruction, which could be a fibula-based technique or a TBO fibula-based technique. So post-lateral reconstruction is a non-anatomic technique, but modified Larsen is one procedure. But the problem is when the TBO fibula, it's a fibula-based technique, and if the TBO fibula joint is not stable, this will not give much stability to the knee. So this is the principle on which we move on to the TBO fibula-based technique, which is a Lateral technique. So you have a Larsen's technique, modified Larsen's technique, and a Lateral technique. So which one you select for a given patient? That is what we should understand. So modified Larsen technique is a preoperative examination, and you have to decide for which patient what to do. So if the varus stress test is the only test which is positive, then a Larsen or a modified Larsen is good enough. If varus stress test and dial tests are positive, then Lateral technique, and in some cases modified Larsen may be enough. So when the dial test is the only test which is positive, then popliteus reconstruction is enough. So I'll repeat, if varus stress test is the only test which is positive, then you go for a modified Larsen technique. If varus stress test and dial tests are positive, you go for Lateral. And if dial test is the only test which is positive, you go for a popliteus reconstruction. But you may not get a patient with isolated dial test positive. Most of the times it is a combination of varus stress test and dial test. So most of the patients will be happy with a Lateral technique. So this is what we should understand. Modified Larsen technique, it's a very simple technique. As you all know, the modification is that initially it was on the same side, somewhere the femoral attachment was at the same point. Modification is that it is now bifurcated. So the disadvantage is that you need a larger incision, and sometimes we can do it with a minimal incision technique also. But there is one point of fixation on the femur and the tibia. So minimal incision LCL reconstruction is also possible without exposing too much. So that's about a minimal incision LCL reconstruction without exposing too much. But the important thing about Larsen technique, which is open, is you have to identify the common peroneal nerve and protect it. In minimally invasive technique, you are not identifying the common peroneal nerve. So you have to drill from the posterior to anterior. In open technique, you drill the fibular head from anterior to posterior. This difference you should understand. So popliteus reconstruction, there are some issues. Of course, if you do a tibial tunnel, there is always a risk for injury to the popliteal artery, which you should keep in mind. So your drilling point should be a little more medial on the anterior side and lateral when you go posteriorly. Otherwise, there is a risk of a popliteal artery injury, which you should keep in mind. So grade 3 PLC injuries has to be treated surgically. It will never heal in knee dislocation or isolated PLC injuries or with cruciate ligament injuries. So you need the technique of reconstructing both the LCL, popliteus, as well as popliteofibular ligament. So if you do that, that will heal. And there is not much role for a primary repair. Even if you do primary repair, you will have to reconstruct it or support with the other reconstructions as well. So primary repair also may not heal well in a PLC injuries. So grade 3 PLC injuries has to be treated with due importance, and we need the technique. And one technique described by Banja is an arthroscopical popliteus reconstruction, which many people are not doing in this part of the country, but still it's not moving forward. So grade 3 PLC injuries are sorry, the slide is not moving forward. I think almost there's a last or one or two slides are remaining. So grade 3 PLC injury, as I told, is a varus stress test or a dial test will decide what you can, how you can treat it. So the summary of my presentation is PLC injuries will not heal unless you treat, and there is no automatic healing for posterolateral corner injuries. So this is the algorithm for PLC injury. Patient selection, depending on your physical examination, you have varus stress test positive or negative. You have to look for dial test, and the important principle is anatomical reconstruction of both popliteus, popliteofibular ligament, and LCL if varus stress test and dial tests are positive. or if the virus test is only test positive, then you do a modified laparoscopy technique. In the last, which is the dial test, which is positive, you do a popliteus reconstruction. It's the same one. So to summarize my presentation, PLC injuries are common, accompanied by ACL or PCL or PMC injuries. Failure to recognize PLC can result in failure of your ACL or PCL reconstructions. So PLC injuries manifest in pathological external rotation, which you can detect by your stress X-rays or by your clinical examination. Repair or reconstruction should be done to prevent early OA, and even cruciate failure occurs. If you don't reconstruct the PLC, just your cruciate ligament also may fail in the long run. Thank you for patient listening.
Thank you, sir.
Thank you, sir.
I invite Dr. Nabil to give a memento to Gobi sir because part of excellent discussions and a great complex topics almost put in a very nice way. Thank you, sir. And I invite Sandeep to come and receive a small token of appreciation for you from Dr. Nabil for an excellent live surgery and all the support for the CME and be a part of it. Thank you. A big round of applause for you. Thank you all. Thank you.
Thank you, sir. Now I invite Dr. Anand KS to speak on mastering medial side injuries.
Good evening, all. At the outset, I would like to congratulate Indian Arthroscopy Society and Team Mitra for putting up such a wonderful academic bonanza. Thanks for the invite. So, Dr. Hassel has already covered in great detail regarding MLKI, the algorithm. Professor Gopi has already explained in detail regarding the lateral side of the knee and its reconstruction techniques. Now, the honors of describing the medial structures is on me. So, this is mastering the medial side injuries. So, regarding the incidence and injury mechanism of medial side injuries, they occur in isolation in 29% of all ligamentous knee injuries. In combination, they account for almost 50% of the injuries. Most common combination would be along with an ACL injury. So there are two different mechanisms as with any other ligament injury. The direct mechanism is a direct blow to the lateral side of the knee where a pure valgus stress knocks off the superficial MCL. The indirect mechanism would be a valgus and external rotation. What all ligamentous structures would fail, that whole lot depends on at what flexion angle the knee and ankle were in. So anatomy is paramount for effectively treating medial side injuries. So the medial side anatomy is broadly classified into the superficial MCL or a SMCL, the deep MCL, which essentially has meniscofemoral and meniscotibial components, then the posterior oblique ligament, the posteromedial capsule, the semimembranosus tendon, and the posterior horn of the medial meniscus. So we have to remember certain bony landmarks to understand the anatomy on the medial side. These three would be medial epicondyle, adductor tubercle, and the gastrocnemius tubercle. These form sort of a triangle on the medial aspect of the knee on the femoral side. We have certain soft tissue landmarks as well. Adductor magnus tendon, vastus medialis obliquus, medial gastrocnemius tendon, semimembranosus tendon, and MPFL. So this is the most important slide, I think, because in order to effectively treat the medial side surgically, we have to have a good understanding of the anatomy. Attachment sites for superficial MCL would be 3.2 millimeter proximal and 4.8 millimeter posterior to the medial epicondyle. So the most important thing is it's not on the medial epicondyle, it's posterior and proximal to the medial epicondyle. And on the tibial side, superficial MCL has two different attachments. One is 1.2 centimeters beneath the joint line. The other one would be around 6 centimeters beneath the joint line. Regarding deep MCL, it is again 15.1 millimeter posterior and distal to the medial epicondyle on the femoral side, and very close to the joint line on the proximal tibia, that is about 3.2 millimeters. Now regarding the posterior oblique ligament, again the measurements are taken from the gastrocnemius tubercle generally. So it is 7.7 millimeters distal and 2.9 millimeters anterior to the gastric tubercle, and it is pretty much centered between MPFL, medial epicondyle, gastric tubercle, adductor magnus tendon, all these structures on the medial aspect of the lower femur. So it has got a direct connection to the distal attachment to the tibia just in front of the anterior or direct arm of the semimembranosus tendon. So with all these things in mind, the function of superficial MCL, it's the primary restraint to valgus forces at all angles of the knee, especially in flexion angles of 30 and 90 degrees. It controls internal rotation in extension. Then deep MCL, again a restraint to valgus, works in full extension. Then POL, again primary restraint to valgus in full extension, and again prevents translation, posterior translation in extension and internal rotation. So in general, the medial or the posteromedial structures of the knee, they control valgus and external rotation forces. So with regards to the diagnosis, the clinical diagnosis is by means of battery of investigations tests we do on patients. So the valgus stress test, which is typically done at 0 and 30 degrees of knee flexion. So grade 1 opening would be less than 5 millimeter at 30 degrees of knee flexion and with a hard endpoint, and no opening at 0 degrees of knee flexion. Grade 2 would be 5 to 9 in 30 degrees of knee flexion, none at 0. And grade 3 superficial MCL injury, we call it when the opening is more than 10 millimeters in 30 degrees of knee flexion and no opening in 0 degrees of flexion. If the knee opens in extension medially, so it is sure that it is either an associated cruciate injury which is causing the opening, or it is a diffuse medial injury. By that what I mean is posterior capsule, semimembranosus, posterior horn of the medial meniscus, POL, deep MCL, all these stabilizing structures on the posterior medial aspect of the knee must fail in order to have an opening of significant proportion in extension. So another important test would be a dial test in supine position. Normally we do our dial test in prone position at 30 and 90 degrees. It's a test for isolating a combined PCL and PLC injury from a PLC injury in isolation. But here the importance of doing a dial test always in supine position would be, we don't know yet whether the 15 degrees of side to side increase in external rotation was a posterolateral translation of the tibial condyle over the femur, or an anteromedial translation of the proximal tibia on the femur. We don't know. So in order to address that, we have to see the knee from anterior. If it is an anteromedial aspect of the knee which is causing the external rotation, while looking at the tibial tuberosity, we would know that. And if that is the case, then it is an exaggerated dial test in supine position, which denotes a diffuse medial injury rather than a posterolateral corner injury. Another test would be an anteromedial drawer test, where you put the knee in 90 degrees of flexion, externally rotate it and do an anterior drawer. If there is a diffuse medial injury, that there would be significant anterior translation. Regarding the imaging, the most important slide is this regarding the imaging, stress x-rays. On simple x-rays, we would diagnose bony femoral avulsions in acute cases of MCL avulsion, calcification in chronic injuries, that is called the Pellegrini stridor lesion. Then the valgus stress x-ray, the most important one, that is done at 0 degrees and 30 degrees. It's a comparative x-ray. Both knees has to be in the same range of rotation. So if at 30 degrees of flexion, there is more than 3.2 millimeters side to side difference, then that is suggestive of a grade 3 superficial MCL injury. If at 30 degrees of knee flexion, the opening difference is more than 9.8 millimeters, or in extension, if it is more than 6.5 millimeters, it is suggestive of a diffuse medial injury where all the structures on the medial side has failed. So regarding the MRI, it will tell us regarding the level of medial structure failure, femoral, mid-substance or tibial. Lateral compartment bone contusions are indirect evidences that the medial structures have gone away. Associated injuries could be read from the MRI. Then diffuse injury pattern can be read from the MRI as well. MRI will also tell us regarding, as shown in this MRI picture, a sterner lesion where a distal superficial MCL avulsion from the tibia. Normally, the superficial MCL finds its place beneath the pes tendons, but it comes to lie superficial to the pes tendons, thus inhibiting any sort of natural healing to the ligament. So this is an examination under anesthesia of a case, one of the cases with multi-ligamentous injury. So that shows ACL, PCL laxity and a diffuse type of medial injury where the knee opens in both flexion and extension. So regarding the non-operative treatment, most of the, in contrast to the posterolateral corner of the knee, most of the medial side injuries are treated non-operatively. So hinged knee brace is the rule. The normal hinged knee brace for grade 1 and 2 injuries, 3 weeks of brace is recommended, full weight bearing allowed, full range of motion allowed, and quadriceps drill started on day 1. Grade 3 injuries, 6 weeks of immobilization is, brace is recommended. Weight bearing depends on knee alignment. If it is a overly valgus aligned knee, then we delay weight bearing for 3 weeks. Then full range of motion and quads drill are allowed. Operative treatment, it could be a repair with augmentation or a reconstruction. So a repair is usually done with or without an augmentation. Semi-T or internal brace can be used for augmentation. The indications would be within 3 weeks if the patient presents. Ideally, if it is 10 days, it is very handy to repair. Displaced bony avulsions, they have to be repaired. Grade 3 MCL injury, if we are planning a primary ACL repair, not reconstruction. Then diffuse type knee injuries, they have to be addressed surgically because high chance of non-anatomical healing is expected. Grade 3 tibial injury with a sterner inculum lesion has to be repaired. If associated with PCL or other multi-ligamentous injuries or repairable buccal tear of the meniscus, it has to be addressed acutely. If associated with ACL, we usually delay it until the medial side heals. So we have reconstruction options as well. The indications would be residual laxity after non-operative treatment in case of a grade 3 injury, laxity found at the time of repair which cannot be managed by augmentation, poor quality tissue at repair, delayed presentation of the patient beyond 3 weeks. So there are 2 different techniques, laparade anatomical techniques and non-anatomical techniques. I'm not going into the details. The detailed reconstruction technique will be demonstrated by Dr. Joyce in subsequent presentation. So to summarize, acute injuries, anatomical repair of deep MCL, capsular structures and POL along with superficial MCL repair with augmentation. For chronic injuries, anatomical reconstruction of superficial MCL and posterior oblique ligament and correction of malalignment with usually supracondylar osteotomy on the femoral side if the knee is in over valgus alignment. Early range of motion should be the key after repair or reconstruction. So 0 to 90 is usually the aim of immediate posterior range of motion. Thank you.
Thank you, sir. Next topic is about MCL reconstruction by Dr. Joyce Verghese, MJ. Welcome you, sir.
Good evening all. Sorry for the bad voice. At the outset, I would like to thank Team Mitra for inviting me over here for this wonderful conference. Without much introduction, let me dive into the topic. So we all know that MCL is the most common knee ligament to be injured, and 1 out of 4 ACL injured patients will have an associated MCL injury. So you should have a technique for MCL reconstruction with you, which will be often required. When there is an MCL injured patient, you should always look for a posteromedial corner injury if it is there. If there is a posteromedial corner injury, there will be an anteromedial rotatory instability And it can be detected by a lot of tests which have already been described by Anand, the dial test, the anteromedial drawer test, and the valgus opening in full extension. And the treatment of MCL injuries, that depends on a lot of factors, whether it is isolated or multi-ligament scenario, whether the injury is acute or chronic, depends on the grade of the injury and depends on the type of injury. And most MCL injuries, as already been discussed, can be managed conservatively, especially the femoral injuries. But these are a few indications which indicate towards operative management. The Steiner type of lesion, then when there is a bony avulsion, then sometimes the MCL can be seen entrapped under the medial meniscus when you do a scopy. The posteromedial corner injury, the multi-ligament scenarios, and a chronic MCL injury. These are all indications towards operative management. And from between repair and reconstruction, the acute ones within 3 weeks can be repaired, but between 3 to 6 weeks can be repaired or reconstructed, but reconstruction has a better outcome in the literature. And more than 6 weeks, it is always reconstruction. And also, when it is acute, but the ligament quality is less poor, then we need to reconstruct it. So, when do we need? These are the common scenarios, especially the combined ACL MCL when it becomes chronic MCL injuries. Again, chronic MCL with a PCL injury, then an isolated grade 3 MCL injury, again with a persistent instability after treating conservatively, or a chronic multi-ligament injury. All these are in the usual scenarios when we require an MCL reconstruction. And how to reconstruct? So the commonly used technique is the anatomical double bundle Laprade technique, which requires 4 tunnels, 2 grafts, 4 bioscrews. And the problem with this is it's a slightly longer surgery, and there are chances for complications including tunnel collisions. So this is another technique called the modified Kim's technique, which is a rather simpler technique, and it is rather reproducible and it takes less surgery time. So I'll be demonstrating this technique. This is a schematic representation of the technique which I will be demonstrating. So this is just a patient with an MCL and there's an associated ACL injury as well. This is an arthroscopic picture. You can see the ACL is torn. And on the medial side, this patient, we could see there was a meniscal tear, and there was an opening on the medial side, and the capsule was torn, and the MCL was also found to be, we could see the torn MCL as well there. So this patient, it was at around 3 weeks, so we had a plan to repair and then augment it. So this patient actually had a Steiner type of lesion. You can see the MCL was found to be curled around just above the fascia, and we mobilized it and then repaired it onto the proximal tibia. So when you're repairing it, it's always better to repair the distal stem on the tibia at 2 locations. There are 2 insertions on the tibial side. The proximal one, just around 1.2 centimeter, just Anand was mentioning, 1.2 centimeter below the tibia, and then the distal insertion is around 6 centimeters. So you should repair on both sides for a better outcome from depending on the literature. So this is a reconstruction technique which I was mentioning. So what we do is we take out the CME graft without detaching its distal attachment, with even preserving the vinculae, and the inferior bands are preserved so that the fan-shaped insertion of the CME is preserved onto the tibia. And using an open tendon stripper, the CME is harvested, and the CME is prepared, keeping the distal insertion intact. And then we take the graft under the sartorius fascia onto the, for reconstruction on the femur, for superficial MCL reconstruction. The point, as Anand was mentioning, it's around 3 to 4 millimeter proximal and posterior to the femoral epicondyle, medial epicondyle, and at that point we make a tunnel, and we see the length which is required to reach there, and fold it and make it into a tubularize with a whip stitch, and then insert it into the tunnel and fix it with a bioscrew. So that is a superficial MCL which has been reconstructed. That's a bioscrew. With pulling from the opposite side, holding in tension at 30 degrees of knee flexion, we can tighten the screw. After this is done, then the next is a post-oblique ligament reconstruction. That is done with the remaining limb of the same graft, which is brought down again under the sartorius fascia, and we can either attach it using a bioscrew or a anchor, or even we can suture it onto the semi-membranosus tendon, which is tightly attached on the proximal, posterior proximal aspect of the tibia. So that is a technique. This is just another video, again similar, same technique, just to repeat it. Again, the tendon is harvested without detaching its distal insertion, and the proximal insertion point is identified, and again the tunnel is drilled. The graft is brought down through the sartorius fascia, underneath the sartorius fascia onto the femoral attachment, and again the graft is inserted there to reconstruct the superficial MCL initially with a bioscrew. So the only graft which is often required is a bioscrew, and the distal part for the POL component can be fixed either by suturing it onto the semi-membranous insertion area there where we're seeing, or even you can use an anchor there to fix it. So that's all. Thank you.
Thank you, Dr. Joyce. Can I have one question to Dr. Joyce, please? And this is supposed to be a modified Kim's procedure, right? So in this, the insertion is not taken out. That the open tendon strapper is used to not to take out the insertion of the semi-T. So do you use any redirectional procedure so that the superficial MCL you are reconstructing comes into a more anatomical position rather than the insertion of the semi-T?
Yeah, there are a few techniques like the beam technique which redirects the superficial, semi-T into the superficial MCL direction. But what I did was we did not release the distal insertion as well as the posterior bands which comes from the gastrocnemius area. That is also not released. So that makes it more posterior compared to the normal when we release the inferior bands. So that makes it little more anatomical, not as anatomical as it is. As an anatomical technique, but still it makes little more, and that's what I feel. But and we had a study which showed us that there was comparable results with the Lateral technique.
Do you use any extra anchors in the deep MCL portion so that it will be tethered?
I don't use that. So that's also another technique where they use an additional anchor just distal to the articulars of the tibia, and anchor it there also to make it. I don't use that.
So take home message is you should have an open tendon stripper in your armament area. So if you want to have an MCL reconstruction,
sure. And also always when there is an ACL injury, always look for an MCL and make sure that you identify that before you take up the patient surgery.
So you always counsel them for an open surgery also on the medial side.
No, when there is an MCL injury, in the first visit itself, we should always examine the patient and identify if there is a meniscal suspected MCL injury. We should always counsel them, and we also sometimes counsel them that I prefer to take the graft from the opposite side sometimes when there is an MCL injury. We don't take the graft from the same side, even though literature doesn't support it. But I usually counsel them that also in the first visit. That makes it easier.
Thank you, Dr. Joyce.
Thank you, sirs.
Sir, just one question to Gobi sir, who threw light to the dark corner of the knee. That is regarding the popliteus tendon. Mic, sir. Sir, as in Lepra described an anatomical technique of reconstructing the entire PLC, the only thing which couldn't be repaired anatomically probably was a popliteus tendon, because a tendon is or a muscle is being replaced by a ligament or tendon like that. So there is no way to reconstruct a popliteus tendon which was functioning earlier. So is there any role of repair of a popliteus tendon in an acute setting, because it can't be reconstructed in a proper way with which it was before injury?
That's a very nice question. That's what I mentioned about Banja's technique in my presentation. Banja's technique means you reconstruct the popliteus intraarticularly using arthroscopy. You can reconstruct it.
What will be the indication for that in that case?
Any grade 3 PLC injury, there is a role for popliteus reconstruction. Popliteus reconstruction can be done when the dial test is positive in isolation or dial test and virus test is positive. When virus test is the only test positive, you need not do popliteus reconstruction. So what you do is you have extraarticular reconstruction of the LCL, extraarticular reconstruction of the popliteofibular ligament, But popliteus tendon is reconstructed intraarticularly, which Bancha demonstrated in Arthrocon last day.
Yes, yes.
So
There was a
you-
live surgery.
live surgery. So he has published it also. So that is an advantage of Bancha's technique over Lateral technique. Lateral technique is completely extraarticular. Bancha's technique is both intraarticular and extraarticular. Popliteus tendon can be reconstructed intraarticularly. So your drilling can be done on the tibia and femur through the arthroscope.
Thanks.
I think not
Thanks.
many people are doing it here, but he has described it. Dr.
Yeah, one
Sibin,
doubt
what
is
is your
there.
opinion? Bancha's technique.
So we have seen it also, right?
Definitely, it's a nice technique. You need not to open so much like a Lepra technique. So much dissection is not needed. But you should be well versed in the arthroscopy technique to do that.
Yeah,
Because the
it's,
problem is you can damage the popliteal neurovascular bundle for the popliteal tunnel if you are not experienced with that.
Thank
But
you, sir.
again, we are not addressing the issue, isn't it? Because popliteus is a dynamic stabilizer. So again, and we are reconstructing only the static stabilizer even with the arthroscopic technique. So the original question.
Actually, the muscle can't be replaced by a ligament. Whatever we do, we are doing a reconstruction only. So that is what that was what I asked because yeah, only it is always yeah.
There is a statement in Campbell's Orthopedics which states that muscles will never take sutures. It indirectly means that when a muscle is damaged or cut or injured, it will never heal. So when popliteus muscle is damaged, it is gone forever. But we are achieving static stability. So we are not expecting a dynamic function of popliteus after popliteus reconstruction. We are expecting only static function. That's evident. We cannot do much about it.
ഇനി റൊട്ടേറ്റർ കഫിലൊക്കെ ലോവർ ട്രപ്പീസസ് ട്രാൻസ്ഫർ വരുന്ന മാതിരി മീഡിയൽ ഗ്യാസ്ട്രോളിമസ് നിന്ന് എന്തെങ്കിലും ടെൻഡൻ എടുത്തിട്ട് പോപ്ലിറ്റസിനെ റീകൺസ്ട്രക്ട് ചെയ്യാൻ പറ്റുമോ എന്നുള്ളത് നമുക്ക് റിസർച്ച് ചെയ്ത് നോക്കാം.
That's a great comment.
Thank you everyone. Thank you so much. One doubt is from the audience.
Grade 2 MCL injury with ACL injury and patient is presenting more than 6 weeks. And if we decide to go for operative intervention for ACL and conservative treatment for MCL.
Dr. Anand, you may take up that question because he is asking about MCL.
Sir, you.
Sir, patient presenting with a grade 2 MCL injury along with ACL full tear. More than 6 weeks.
More than 6 weeks. Okay.
And MCL it is conservative and ACL it is reconstruction.
Originally managed conservatively.
Originally managed conservatively.
Okay.
More than 6 weeks. So initially patient came at 6 months.
Sorry, I didn't get you. 6 weeks.
So the patient presented to the department at 6 months.
6 months after the original injury.
Original injury.
Everything was conserved until that time. Yeah.
The patient didn't know. So at the all the tests for ACL was positive and there is a grade 2 laxity for MCL.
It's very unlikely actually because grade 2 injuries they heal beautifully. I mean, it was not treated or conservatively treated.
No, it was not treated at all.
Not okay. Not diagnosed.
It was not diagnosed.
Okay. Even then, it's that situation is unlikely. But if that comes grade 2 MCL injury,
there was opening up.
In extension, there is no opening. It is just a superficial MCL injury.
Only at 30 degrees there is opening. So hard to differentiate whether it is 2 or 3.
No, 3. Then that is the importance for getting stress X-rays done.
Okay.
You get stress X-rays. If there is significant opening of superficial MCL, that is at 30 degrees of flexion, if the knee opens more than 3.2 millimeters, that the side-to-side difference, that itself it's a grade 3 superficial MCL injury. So if you get a patient with superficial MCL injury with delayed presentation along with an ACL, you do the superficial MCL reconstruction along with ACL reconstruction.
Okay. So my question is not that. If it is type 2. 2. In a stress X-ray.
Okay.
So for ACL, what graft should we take?
CME actually
ipsilateral CME or
ipsilateral CME actually CME is not an independent medial stabilizer. It's been shown by different studies. It can be taken. Yeah.
Ipsilateral.
Yeah.
CME is overrated as a medial dynamic stabilizer.
Yeah, nothing.
Actually, there is no much role. The recent literatures and even in the complex knee injury course, which was held 2 weeks back, Laprad has very clearly mentioned that every biomechanical studies and recent literatures have shown that you can take semi-tendinosis and gracilis as graft even if there is MCL grade 1 or 2 injury. That was your doubt, I think. You can take, no problem. Because it is overrated as a medial stabilizer. Semi-membranosis has got the dynamic stabilizing action. It's 5 arms, direct arm, anterior arm, and so you should not violate semi-membranosis. And another thing, if it's grade 2, if it is grade 3, you examine the patient under anesthesia thoroughly. If you are in a doubt, you just have a CM picture. And if it is a good opening out in extension, if the gap is side to side difference is more than 1 centimeter or it is 9.8 mm, then you have to go for MCL reconstruction also. Otherwise, if you do only ACL, definitely it will fail. That is it.
Gopi sir, the PLC, there's a modified Arthroscopy technique, almost same as a modified Larsen.
Sir has put a slide because here this changer is not moving. Arthroscopy slide was there.
Last slide was modified.
And if the provided the proximal tibiofibular joint is intact, can we do an Arthroscopy instead of a Laprad?
Yeah, that's correct. But it is very difficult to assess the integrity of the proximal tibial in the long run. Because you may think that it is all right, but in the long run, that joint will fail. That's where Laprad always highlights. So you may think that everything is okay, but in the long run, it will start moving and failing. So he says that you always do a tibiofibular based technique, not a fibular based technique. It may fail at any time. That's why he showed a video animation like that, it moves like that, like this. So it's always better to do a tibiofibular based technique, especially in a grade 3 injury, where the dial test is positive, where the virus test is.
I still remember, Rajanish, we had a discussion in the Arthrocon group.
Yeah, sir, look, I don't know whether I beg to differ, but I think I do a lot of RCROs and I find that intra-op assessment, definitely I make a decision based on the pre-op MRI and the intra-op decision to see if it is stable and go for RCRO. But I know when somebody experienced like Gopi sir tells it, then definitely we should take into consideration. The current literature really supports the modified Larsen technique of RCRO for the post-lateral corner. But yeah, I think I should take it with a word of caution because, you know, the proximal tib fib joint can be injured, which I would have missed. But yeah, I still do it.
Because this is about my opinion. These are the publication for Laprad.
Yeah.
And he personally says, last time he came to Goa, he told the same thing. 2 weeks back in Jaipur, he told the same thing. He published it also.
Obviously, he would promote his technique.
But whatever it is, it makes some sense.
Yeah, I agree.
Because when there is a fixation on the tibia and fibula, it is foolproof.
So
over the time, whether it fails or not, we don't.
Yeah, so that is why I think in the current new classification system, they are putting the proximal tib fib joint stability as one of the factors when we decide whether you go for RCRO versus Laprad. I still do, probably out of 5 cases, I would do 4 RCRO and 1 Laprad. If it is ACL, PCL, post-lateral corner, and there is significant bony injuries, then I'm much more comfortable doing a Laprad rather than RCRO.
I fully take that point, but still, I think that over the time, whether it fails or not, you cannot tell on the table.
I tend to
over
agree.
the years, whether tibiofibular joint fails or not, you cannot assess on the table.
Absolutely.
We can put a simple cancel screw from fibula to tibia for the along with R0 as a prophylactic.
The tunnel is exactly at that point.
So another point is that many of the LCL injuries, if it is a high velocity injury, sometimes the fibular head will be shattered or it will be pulled out. The biceps along with it. So we can't get, we can't put tunnels in there.
No, the basic issue is over the years, whether it fails or not, we cannot predict it. So on the table, it may be all right.
Just one last question to Dr. Anand. That is just an extrapolation of the question that is being asked. An ACL with an MCL injury, you got a femoral avulsion of MCL and you treat it conservatively, and ultimately you come for a ACL surgery, and you need to have a meniscal repair done in the medial side. So you might need to pie crust to open up to see the medial side, so which has been treated conservatively, MCL. So what will be your take for that?
After how many weeks?
Maybe you treated conservatively and after 6 weeks the patient has come for
Yes,
ACL.
okay.
So can you just pie crust or will you opt reconstructing?
I will do pie crusting. I will do pie crusting.
No. Open thing was treated conservatively and now it is closed. The patient came for ACL. There is a repairable medial meniscal posterior horn which needs spike resting. So then only it will open.
So any conservatively healed medial collateral ligament, I see there will be some amount of 1 or 2 millimeter opening.
Yeah. So
Definitely.
even if
I
you
never
pike
seen
rest,
any
it
meniscus
will
more
be
than
okay.
grade 1 healed with a rock solid medial stabilizer.
Yes, that is correct.
That is
Because
true.
it is not the medial ligament alone. Because there are so many. You talk about ALL, but you don't talk about the opposite compartment. You talk about ALL always. Yeah, not only posterior capsule, anteromedial capsule also. So the capsular injury, we talk about ALL, we never talk about MLL. Like that, there is a capsule.
When you pike rest, you are not pike resting the whole MCL. No, you're pike resting mainly the posterior oblique ligament, just minimum pike resting. You are not pike resting the main superficial deep MCL. So it's only
Actually,
posterior oblique.
Jyoti, that's a good technique described by Banja.
Yeah, the magic point.
Magic point Banja. You just
Posterior,
Tamasu University line, TU line, from the posterior tibial flare, you just draw a line and just above the joint line, 2 to 1 inch, within 1 inch, there is a point, the femoral attachment of the MCL. You just 18 gauge needle, just to put 1 nick in valgus extension, it will open out. Otherwise 2 or 3 maximum, it will open out. I am routinely doing that.
G needle is little dangerous.
Sir, ലേശം കുറച്ചാലോ.
So thank you all for the wonderful discussion. Thank you.
As we come to the end of today's CME, I would once again thank our esteemed guests for their valuable contributions and gracing us with this esteemed presence. Let's heartily applaud them once again. And moving on to the valedictory function, I invite Dr. Samir Ali to hand over the mementos to the faculties.
I would like to invite Dr. Sibin for the. Dr. Sibin, please a good round of applause for Dr. Sibin. Dr. Rajneesh. Dr. Shahnawaz. Dr. Jyoti Prashant. Dr. Ajit Wilson. He has just reached yesterday from Australia just for this conference. Very happy. Dr. Gafoor. Dr. Janice. Dr. Janice. Dr. Joyce. Dr. Azhar. Dr. Anand. I invite all the faculties to the stage for a photo.